Each good morning, we are born again. What we do today is what matters the most. Honorable dignitaries, learned delegates, respected teachers and students, we would like to greet a very good morning to all the delegates from India. It feels great to see so many participants from all around the world. It's the beginning of a new week, and it's appropriate that we start the week with a session on patient safety, which is one of the most important aspects of nursing care. We anticipate to make this day not just wonderful, but also a day full of learning and new experiences. I am Shinu Anish, and my co-host today is Jayashri Misal. We are privileged to welcome you all to this international conference on patient safety, a step towards quality care, organized by TPCT's Terna Nursing College in collaboration with National Healthcare Academy, Singapore and Maharashtra Nursing Council on the topic Patient Safety, a step towards quality care. Before we begin, we have a few announcements. We request all the delegates to keep your microphones muted. The link for pre-test is shared on Zoom chat box, WhatsApp groups and YouTube live chat. Kindly fill the pre-test. For those participants who get disconnected from Zoom meeting and are not able to log in because of the participants exceeding limit, kindly attend the sessions through the YouTube live streaming. The link is given in every chat box. Also, your audios and videos will be disabled to avoid disturbances. So if anyone has any query, you may raise it in the chat box.
The world is full of diamonds and gems. We are having some of them here today with us to build this event. With this note, we would like to give our heartiest welcome to all our distinguished speakers, delegates and faculty members. This conference brings together academia, researchers, esteemed guests and speakers who have excelled in various fields. This conference also provides a great opportunity for prospective participants to share their research findings. We hope you all will learn a lot today, and as we have lined up for you very informative sessions.
We would like to start the conference by offering prayers to the Almighty. We will have a customary virtual lamp lighting for seeking the choicest blessings of God and to make a program a successful one.
कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः.
To affirm the significance of this event, I invite Ms. Mrunal Bandal, third year basic BSc nursing student, to present the invocation dance.
गुरुदेवो महेश्वरा गुरुः साक्षात् परब्रह्म तस्मै श्री गुरुवे नमः।
Thank you, Mrinal, for your soulful rendition. I remind all the delegates to kindly fill the pre-test. It's my privilege to call upon our principal, Professor Mrs. Pratibha Thare ma'am, who has been our pillar of strength and a constant source of motivation. I request Madam to deliver the welcome address.
Thank you, Shinu. Success is not the key to happiness. Happiness is the key to success. If you love what you are doing, you will be successful. A warm good morning to all of you. A warm good morning and good afternoon, good evening to all of you. While it is obvious to feel happy to deliver welcome address and also excited and feel blessed about this role, as this international conference is built with intent of active and interactive learning organized by Terna Nursing College. This is the first international conference in the history of Terna Nursing College. This conference is shaped in a way to attract your interest, and I trust that we will be successful. By looking at the participations, we are of course very pleased. Let me share with you, we have put a lot of passion in the conference to give blend of theory and practical. We wish you to enjoy and learn maximum from the conference. We are honored and pleasure to welcome Founder President of Terna Public Charitable Trust, Honorable Dr. Padmasee Ji Patil sir, a man with golden dreams and enthusiasm to convert dreams into reality. I extend my warm welcome to our Chief Operating Officer, Mr. Mallar Rana Jagjit Singh Patil sir. I heartily welcome our CEO, Mr. Deshmukh sir, who is always our supporter. I extend my welcome. Serving the society is the foremost principle on her agenda and have made a difference in clinical setting. Our chief guest, Ms. Minimol Verghese, Chief Nursing Officer, Fortis Hospital, Mulund, Mumbai. Good leaders create vision, articulate the vision, passionately own the vision, and relentlessly drive it to completion. A nursing leader have made difference to academic and a clinical area with her great efforts, who has graciously consented to be the keynote speaker today, Dr. Nilima Borema, Dean, Faculty Nursing and Principal, Bharati Vidyapit, Dean to be University, College of Nursing, Sangli. I welcome you, ma'am. I welcome Dr. Smriti Mani Madam, Principal, OCD Nursing College, Nursing Director, Government of West Bengal, who is a storehouse of knowledge. I welcome MNC Observer, Dr. Vaishali Taksande, Vice Principal, Srimati Radhika Bai Mege, College of Nursing, Wardha. I am extremely happy to welcome our eminent speakers and guests from all over the country, from different walks of life, have come to share their knowledge and vast experience with us. I welcome Ms. Anishma S., Training Manager, NHCA, London. Dr. Sushila Kaude, Head Operation and Quality, Royal Muddul Hospital and Research Center, Pune. I welcome you, ma'am. Ms. Dini Melvin, Training Director, National Healthcare Academy, India. Dr. Elizabeth Joseph, Regional Nursing Head, Wokards Hospital, Mumbai, and Dr. Shubhangi Jadhav, Nursing Head, MGM Hospital, Parel, Mumbai. I extend my warm welcome to Dr. Jyoti Naikere, Principal, HOD of Child Health Nursing, Siagar College of Nursing, Pune. Professor Mr. Lakshmanan M., Vice Principal, Shri Daneshwari College of Nursing, Aurangabad. Professor Eknath Gowde, Srimati Sindhutai Eknath, V.K. Patil College of Nursing, Pravra Institute of Medical Sciences, deemed to be University, Ahmednagar. We are fortunate enough to collaborate and get support by Dr. Pawan Mittal sir, the Program Director, NHCA Singapore. He is the real motivator for this international conference and brilliant speaker. I welcome you, sir. Very active, enthusiastic and brilliant lady, Dr. Deepali Umay. I extend my warm welcome to you, ma'am. I am extremely happy to welcome all the principals, faculties, staffs and students. I wholeheartedly welcome all the delegates across the country. I am very proud to say that we have more than 1,500 delegates registered from different states like West Bengal, Rajasthan, Gujarat, Tamil Nadu and many more states, including faculties today. As you all know, the current scenario of healthcare system in India, we stressed on a quality care in healthcare. We all have gathered here to discuss on the theme of patient safety, a step towards quality care. What is patient safety? Patient safety is a discipline that emphasizes safety in healthcare through the prevention, reduction, reporting and analysis of errors and other types of unnecessary harm that often lead to adverse patient events. So, the speakers of the conference are uniquely placed to discuss and highlight the key points, trends, reforms and practical aspects of patient safety. It will be great to hear from our keynote speaker about patient safety, goals and models, which will focus on theoretical aspect of patient safety. Other speakers will be discussed on international goals of patient safety, and next session is on issues in patient safety, followed by practical aspects which will fill the gap in the practicals. We have post-lunch session on communication, which is the key part nurses plays in the clinical area. We had tried to blend evidence-based practice in the field of patient safety. After a whole day of speculation on the most demanding field of healthcare, we have organized very interesting session, and next session is on issues in patient safety, followed by practical. I am sure my budding nurses and everyone will learn the tricks of facing interviews, aspects which will feel we also arrange a paper presentation opportunity for our delegates to put forward their reforming thoughts in this nursing field, and our special judge panelists will judge them. I want to inform all delegates and moderators to be very strict about this schedule and don't let overcome any session. Terna Nursing College is very thankful to each and everyone who is contributing to this conference. Thank you, and again welcome everyone.
Thank you very much, ma'am, for the welcome speech. We are very honored to have with us our chief guest for a day, Ms. Minimol Verghese, Chief Nursing Officer, Fortis Mulund. Ma'am is an intellectual academician, very active in clinical nursing. She always strives for the better nursing care by conducting clinical research. Ma'am has a huge ma'am has a huge experience. Ma'am is graduate from SNDT University, 18 years of nursing administration experience in Fortis Hospital, Mulund. Ma'am has 10 years experience in various hospitals from India, Kuwait and Bahrain. Ma'am is certified in Six Sigma Green Belt Hospital Administration and Quality Control Management. Ma'am is in President for Critical Care Nursing Society, team member for Creating Critical Care Nurses Practice, assessor for Critical Care Nursing Practice Standards, assessor for the INFUSE certification. Ma'am has conferred with Special Award for COVID-19 by FICCI 2020 for her work as a frontline warrior in the fight against COVID-19. Ma'am has also won multiple awards from various QIPS conducted in the hospital. Ma'am has published various publications in national and international journals. We are very honored to have ma'am with us today. Over to you.
Good morning. Good morning, Terna team. And am I audible?
Yes, ma'am.
Okay, so at this time, I would like to thank Terna Nursing College for such a wonderful initiative, which is they have associated with National Healthcare Academy and MNC. Thanks to Professor Pradipha, thanks to Dr. Mittal for arranging such a wonderful session. So when it comes to patient safety, we here in our hospital day-to-day work, every day, many times we talk about patient safety. Now, why patient safety? If you see in the data, it says that adverse event due to unsafe care in the hospitals and the death, which are every death, 10 leading cases, cause of death is only due to unsafe care of practices. And every 10 patients harmed while patient receiving care in the hospital. And just want to say that in this 50% of this errors are preventable. So I just want to tell the team who is listening to me that the safety of the patient is in our hand when we look after our patient. Now, what are some of the main concern when we talk about patient safety? There are medication errors, healthcare associated infection, unsafe surgical procedures, unsafe injection practices, diagnostic errors, unsafe transfusion practices, radiation errors, venous thromboembolism, sepsis. So these are few errors which I have mentioned. And if you go into detail now, there are error happen. Can we just sit and say that, okay, error happens and what can we do? No, there are many ways as healthcare workers we can prevent this errors. Now, how do you prevent these errors which is happening in the healthcare sector, you can have a clear patient safety policies. And as leadership of the any healthcare organization, as leaders, we also should be in tune to how to prevent these errors. So for this, we need to have knowledge, and we need to have skilled healthcare workers who are trained in taking care of this patient, who are knowledgeable about this, what are the patient safety concern, and always involve the patient in the care aspect, which is very, very important. So nowadays, when hospitals, when they built the hospitals, so the design only talk about the safety of the building, safety of the patient. Examples like evacuation plan is put up, proper fire safety in the building. Then some of other initiative what we can do is strengthen the communication and handover process for doctors, nurses, and you need to have real alerts and reporting tools for if there are any panic values or a verbal order, telephonic order, and you can have measure the patient safety indicators. There are now almost all hospitals have NABH, JCI, all this accreditation. So they help us in saying that which are some of the patient safety indicators the organization can track. And if as healthcare, if we focus on 6 IPSG, so I'm quite sure that today in the session there will be focus on the IPSG. So 6 international patient safety goals, which is the key core of any patient safety. So just I will brief them, which is of course identifying the patient safe correctly, improving the effective communication, improve safety of high alert medication, ensure that correct patient, correct procedure, correct surgery is done, reduce the risk of healthcare associated infection, and reduce the risk of patient harm relating to fall. So these are the 6 core IPSG any organization should follow. So and I once again thank Terna Nursing College for having such a wonderful topic, because in our nursing curriculum we focus less on patient safety and such topics, but this is a need of an hour, and I thank Terna Nursing College, NHCA, and Maharashtra Nursing Council for initiating such a wonderful topic and such a conference. All the best, and today I think whoever is listening will get to know and will learn. Their knowledge will be improved because the speakers are experts in patient safety. And all the best.
Thank you very much, madam. I think you are a perfect person from the clinical area, and the audience or the delegates have briefed about within short period of time about patient safety. Thank you very much, ma'am.
Thank you very much, ma'am, for accepting our invitation despite your busy schedule and gracing this occasion. We are very grateful to you, ma'am. Now, we are very delighted to have the presence of Professor Mrs. Vaishali Taksane, ma'am, Observer, Maharashtra Nursing Council. We are indeed grateful for her support, constant guidance towards the smooth conduction of this program. Let me introduce ma'am. Madam has completed her MSc Nursing in OBGY Nursing, MPhil in Health Professional Education, and is currently pursuing PhD in Nursing. She has more than 21 years of work experience. Presently, she is working as a Vice Principal in Srimati Radhika Bai Meghe Memorial College of Nursing. She is recognized as UG, PG Fellowship and also PhD Supervisor in OBGY Nursing. Madam is examiner for UG and PG programs in various universities across India. She has 5 copyrights to her credit. She has written books and chapters in the field of OBGY nursing. She has 42 research articles, review articles, published in various national and international journals, and number of paper and poster presentations to her credit. She is involved in international collaboration, research work as teacher, facilitator in funded project with SIDA with Sweden. She is also a member of various academic committees and professional organizations as well. A very warm welcome to you, ma'am. Over to you, ma'am. Madam Vaishali, are you ma'am? Ma'am, are you here?
ठीक है.
Delegate, I remind you to fill the pre-test by the time Madam joins. You can complete your pre-test forms.
Good morning, all of you. Today, we are gathered here for the International E-Conference organized by the Terna Nursing College, Navi Mumbai, with collaboration of National Health Academic and Singapore Maharashtra Nursing Council. And the theme of this is patient safety, a steps toward quality care. And this is very good opportunity that the Terna Nursing College, they have organized the topic regarding the today's conference. I really congratulate all this, and I tell all the participants they have to listen, because they are a very good speaker available today's session. So I am not taking too much time regarding this, and really congratulations, and I welcome all of you. And this is a very good topic regarding the patient safety. It is a very things, means as a nurses, when you are working in the ward, when you are working in the community area, patient safety, it is one of the very much important things that we have to keep in mind. And this is a very good topic. So thank you so much for
Thank you, ma'am, for your words of encouragement. Ladies and gentlemen, now it's time to throw light on theme of today's conference. May I invite our first speaker of the day, Dr. Nilima Bore Madam, Dean, Faculty Nursing and Principal, Bharati Vidyapit, Deemed to be University, College of Nursing, Wellnesswadi, Sangli. Now I request Organizing Secretary, Mrs. Soumya Menon, to introduce ma'am.
Started the presentation.
It's my immense pleasure to introduce you all to the special guest for the day, Dr. Nilima Bhure Madam. She is a well-known, senior and eminent personality in the nursing fraternity due to her rich and varied professional experience in India
I'm
as
guiding
well
them.
as abroad. For more than 3 decades in serving the society as a nurse clinician and academician as well. Presently, Madam is efficiently handling the post of Dean, Faculty of Nursing at Bharati Vidyapeeth deemed to be University, College of Nursing, Sangli, Maharashtra. Madam is actively involved as a member in various professional organizations, is an examiner at various universities all over India. She is an advisory board member in 10 national and international nursing journals. Besides, she is also actively involved as a board of studies member in various universities of Maharashtra and India. Madam has also been organizing chairperson, resource person for innumerable conferences at national and international platforms. She has presented more than 20 papers and published around 38 papers in various national and international journals. What to say more about Madam? Despite of her uncountable achievements, I can tell you that she is one of the most humble personality on earth, a great mentor, a motivator, and a great supporter. Madam, it is indeed an honor and privilege for us that you agreed to be a What to say more about Madam? Despite of her uncountable achievements, she is one of the most humble personality on earth, a great mentor, motivator and supporter. Madam, it is indeed an honor and privilege for us that you agreed to be a special guest and speaker for this event. I take this opportunity to extend my gratitude and heartfelt thanks for accepting our invitation. So, here I request Dr. Nilima Bhore Madam to begin with your keynote address. We are enthusiastically waiting to listen to you, Madam.
Thank you. Thank you so much. Am I audible?
Yes, ma'am.
And can you see my slides?
Yes, ma'am.
Okay, thank you. At the outset, I want to thank Professor Pratibha, the principal of Terna College, and the organizing committee for this opportunity that they have given to me to share something on the topic which is very, very valuable, which is the need of the hour. So the theme.
Ma'am?
Yeah. The theme which is given, for, which is chosen for the conference is patient safety, a step towards quality. Now, these are two important aspects which need to be focused: patient safety and quality care. So, what is patient safety? I think Professor Pratibha in her welcome address has already defined what is patient safety. So patient safety is defined as the prevention of harm to patients. And here the emphasis is placed on the system of care delivery. And this system is supposed to prevent errors. It's not only prevention of errors, we have to learn from the errors which have already occurred so that it is not repeated, and to build on a culture of safety which involves healthcare professionals, organization, and patients. These three aspects are very, very important. When we are talking about safety culture, you not only emphasize on healthcare professionals, but you have to emphasize, I mean, you have to focus on the organizational setup. And not only that, even those who for whom you are delivering the care, that is your clients or patients. So why patient safety, is patient safety and quality important? So it aims to prevent and reduce risks, errors, and harm that occurs to patients during provision of healthcare. A cornerstone of the discipline is continuous improvement, and this continuous improvement will come when you are learning from the errors and adverse events. The meaning is that when the errors occur, we are not supposed to leave it at that point. It's not that you will report, and leave it. We must learn. It should be taken as a learning experience so that they are not repeated. So patient safety is a fundamental to delivering quality essential health services. If you are not delivering a care which is safe for the patients, then you cannot say that you are delivering a quality care. So these both aspects are very, very essential. So let's see some of the causes. When the analysis of error was done, they have identified few causes, and these causes lead to unsafe patient care. So these are first causes: failure to follow standard operating procedures. I think in every clinical area, every hospital, we are aware that now SOPs are developed, especially because of NABH accreditation in the hospital. So when you do not follow these standard operating procedures, errors may occur. Poor leadership, I think leadership plays very, very important role. Nursing leadership has to be motivating. It has to be, the leader needs to be role model herself or himself. If you have leaders who are role model themselves, then they will definitely make difference to that system. Then breakdowns in communication or teamwork. Communication, effective communication and teamwork is very, very important for patient safety and quality care. Overlooking or ignoring individual fallibility. That means if the individual has committed some error, it is very, very essential that you need to have a 1:1 counseling with that person, with that nurse, and identify what was the cause or what was the reason for that individual to fail in delivering patient safety and quality care. So you cannot overlook or ignore. It is not that you are going to criticize that individual when the person commits the error or mistake. It is for the individuals improving the quality care. It enhances the personality or the professional development of the individual, and the mentor should not hesitate to counsel that particular individual. Losing track of objectives. I think all of us are aware because of NAC. Time and again, we are talking about vision, mission, and objectives. Every institute, whether it is a hospital, whether it is a nursing college, every organization has set objectives. And if you are aware, if you are focusing on these objectives, I'm sure the errors will be less. So how will you, what are the steps for patient safety? What are the few steps I will discuss here? Identify loopholes in overall quality program. So meaning is that nobody is perfect. When you develop a program, when you develop a quality program, in your planning stage, maybe you have missed out something which has caused loopholes. So identify these loopholes. Actually, when you implement the program, only you will understand what are the loopholes. So identify these loopholes, then perform event investigation to identify patient safety failure points. So after identifying the loopholes, you must have an assessment team or investigation team, and this investigation team should identify that exactly what are the reasons. Then focus on proactive approaches that reduce the risk of future patient harm. Means once the errors are assessed, once you have identified the causes, then you must decide what are the strategies or what are the approaches which will reduce the further risk in your patient care. Then prioritize patient safety initiative. This is very, very important. Your team members or the nursing staff should know that patient safety is the priority in the patient care, in delivering the patient care. So that should given a first position when you are planning for a quality care. Then use monitoring technology. Monitoring is very, very important. It's not that once you identify and then you plan and then you implement. During the implementation phase, continuous monitoring means time to time monitoring is very, very important. Ongoing evaluation is very, very important. Ongoing assessment is important. Make sure patients understand their treatment. Already I said that patients, clients, and their families are very valuable in your team. So they are part of your team. Unless they understand what treatment is given and what is their role, you cannot say that your delivered care is a comprehensive care. Verify all medical procedures. I think just now the chief guest has already said that one of the leading cause of error are the medical procedures that are performed in the hospital. So you check the medical procedure and the protocols that are followed and see that these protocols are safe for the patient. Then promote team atmosphere. Already I have said that every member of a team is very, very important. We cannot say that every member has equal responsibility for patient safety and quality care, and we cannot underestimate role of any person. So everybody is important. So promote that team atmosphere, then the errors will be less, the environment will be healthy. So these are, to add to these steps, establish a safety and health management system, build a rapid response system. This is very, very important, rapid response system. Once the error has occurred, you should react to it very, very quickly, effectively, and scientifically. So rapid response, do not waste time. Just keeping it on paper for a very long time is not going to help you to prevent errors in the future. Make sure that employees know and understand safety policies. This is very, very important. In majority of the cases, what we see that the policies remain on the paper. They are not implemented. This is mainly because the employees are not oriented to the safety policies. Another drawback is that there is so much of turnover. We have nurses coming and going every now and then. Today, whatever staff you are going to recruit, maybe after 6 months you may not see them. Another new lot comes. Whatever it is, but understanding and giving them orientation to safety policies during your induction and orientation program is very, very important. And this is the responsibility of a nurse leader. That the persons who are recruited or who are taken newly must understand safety policies. Then develop a safety compliance plan, practice patient-centered care. I think time and again we have given emphasis that you must practice patient-centered care. It's not what you feel is important for the patient, but identify the needs and problems of the patient, and then you deliver the care. So patient-centered care is again very, very important. Communicate safety information to the patients and their families, and incorporate safe hospital design. Hospital infrastructure also is very, very important. So here also a nurse leader plays a very, very important role. She is the one who can communicate the hospital design, which is safe for her clients, to the management. See, many times managements may not be aware of certain safety aspects which are involved in the patient care. So nurse leadership plays a very important role in convincing the management to have a safe hospital design or hospital infrastructure. So
what is patient safety practices? So far, we were talking about patient safety care, but patient safety practices, the definition is that the practices, these are those practices that reduce the risk of adverse events related to exposure to medical care across a range of diagnoses or conditions. Now, this is very, very important that it says that every factor, every practice that reduces the risk of adverse events. Now, these adverse events, they could be temporary or they could be permanent. Now, temporary or permanent impairment of physical or psychological body functions or structure. So whether it is temporary or permanent, it damages the functional capacity of our clients. So as far as possible, we must try our level best to avoid these practices, and whatever practices we are adopting, they should be safe for our clients. So these are 5 patient-centered strategies which will allow patient safety. Number 1, allow patient access to electronic health record data, but this may cause legal problems. So as a nursing leadership or as a nurses imparting care, you must know what data can be given to the patients, what data should be withheld from the patient. But remember, they have right. It is the information which is related to them. So they have the right to access to that data. Then care of hospital environment. It is very important. Your hospital environment should not contribute to patient safety errors. So take care of your hospital environment. Create a safe patient experience. When the patients are admitted, they should experience the safe care. When they go, take a feedback from them, and this feedback is very, very important. If the patient and the family is giving feedback on certain aspects, negative feedback, don't get annoyed, don't get angry, don't ignore these feedbacks or the experiences of the patient can be utilized for future planning. Create simple and timely appointment schedule. Encourage family and caregiver participation. See what happens if you don't give time or you don't give opportunity for the family and clients to participate in your care. You will actually not know where are the loopholes. So involve them. There is no harm in involving them. So some of the types of errors which are identified are latent failure, and this involves decisions that affect organizational policies, procedures, and allocation of resources. So the types of errors that occur usually, which are related to patient safety, latent failure. See, what happens is many times we take time to form organizational policies, procedures, allocation of resources. We know that fire safety is required and it requires immediate release of funds or it requires immediate attention. So this allocation of resource, if it is delayed, then that may result in error. Then active failure, which is directly related to contact with the patient. Organizational system failure. These are indirect failures which involves management, organizational culture. Say, for example, no clarity in job description, not clarity in functions of people who are involved, protocols. Then there is a failure in transfer of knowledge to those nurses and team members who are involved, and technical failure. I think all of us know technology plays very important role, but technical failure can result in error. So sometimes things are beyond our control. Sometimes technology can be messy, beyond your control, but as far as possible, do not allow these errors, these types of error to occur. Now, this is just one model, which is known as Swiss cheese model. These are flecks of the cheese, and every fleck has got the factors which may cause whatever I have said just now, the factors which may cause errors like latent factor, error producing factors, active failures, and differences. So as far as possible, do not allow these factors to come into your practices. I know that it is not purely in hands of nursing leadership or the nurses who are imparting care, but as far as possible, try to convince your management. See, it all depends what your relationship with your management. I'm very sure if you have an open relationship, if you are committed, and if you are showing result, I'm sure your management also will be cooperating and will help you to develop a safe environment to impart quality care to your clients. So there is one model of patient safety which involves 4 elements can be used to impart patient safety and quality care. And this involves people who work in healthcare, those who receive healthcare, and the infrastructure or the system which is imparting the care. And the 4th element is methods for feedback and continuous improvement. Now, if you concentrate on these 4 aspects, I'm sure to a certain extent, you will be able to achieve your vision of imparting patient safety and quality care. There are various models. It is not necessary that you should follow only one. I'm just giving you one example just to create an awareness for the nurses that there are models. See, the problem is that we don't review, we don't read. Especially, I encourage people working at the bedside to refer to the library, to spend some time in developing knowledge, and you will definitely get guidelines through the literature. So, why nurses? Now, what is our role? Nursing as a key to improve quality through patient safety. I think the most critical contribution of nursing to patient safety in any setting, whether it is a hospital setting, whether it is a community setting, it is the ability to coordinate and integrate the multiple aspects of quality within the care directly provided by the nursing and across the care delivered by others in the setting. So see, when you are saying a quality care, it doesn't mean only nursing care. Nurse is only a part of a team, but there are many other members, like say, for example, doctor, physiotherapist, you have a dietitian, even the supportive staff. So you must learn to coordinate, and you should be able to integrate the multiple aspects of quality within the care and given by multiple people. So if you are able to do that, then you will be able to achieve your objective. Then monitoring and surveillance that identifies hazards and patient deterioration before they become errors and adverse events. Now, this is very, very important. You should have a system. You must have a trained staff, trained, knowledgeable, skilled staff, nursing staff, who will be able to do continuous monitoring, survey, and identify hazards before they become permanent, before they have permanent adverse effects. So this is very important. This is where a nurse plays important role. And next is the key role of communication and communication lapses. I think you cannot replace anything with communication. So as a nurse leader, or whether you are a bedside nurse or whether you are a supervisor, effective communication is very, very important, because we have seen, the researchers have shown that many of the errors are because of communication gap. So and these are preventable. These communication gaps, if they are overcome, the errors are preventable. So let us try to build effective communication within our nursing team and with the other members of the team who are imparting care with us. So nurses' role in improving quality and safety in healthcare. I have already said that effective communication, patient empathy, put yourself in the place of that patient and his family or her family. So patient empathy, and take a person-centered approach in all that you do. Now, if you put yourself in the place of a patient, I'm sure you will be able to deliver a patient person-centered. I did not, I mean, the word used there is a person. Treat your client or a patient as a person, as an individual. See, many times nurses do not even know the name of their patients. They call them by their bed numbers. This is very, very bad. So start treating your client as a person, and then definitely the whole approach to the care will change. So already I said that you are also responsible for monitoring, assessing patient, performing immediate interventions to reduce the risk or prevent medical complication. So patient safety and quality care. What is patient safety and quality care? The quality has been defined by the Federal Agency for Healthcare Research and Quality as doing the right thing at the right time for the right person and having the best possible result. I think the definition is very, very clear. Doing right thing at the right time for the right person. Now, if anything goes wrong, if you are not doing a right thing, and if it is not done at the right time, I think nurses need not be told about this. You know that, for example, if the medications are to be given at certain time, it has to be given at that time. So giving care is not only important, but giving that care at a particular time is again very important, and also to a right person and having a best possible result. You may do many things, but if the results are not positive, if the results are not good, then whatever you are doing is of no use. So always have objective or aim at getting best possible result. And the WHO has defined patient safety as prevention of errors and adverse effect to the patient. So quality and safety in nursing is defined in the knowledge, skill, and attitudes that are designed to be developed in pre-licensure program. This we do when we are training the nursing students. We improve their knowledge, we update their knowledge, we improve their skills, and we try to inculcate positive attitude. And that should go even after you are a trained nurse. I think we need to update our knowledge. Every day knowledge is changing. There is an explosion of knowledge. Every day with new technology, every day some new therapies are coming, and many times we are not aware. So even you are working at any level as a nurse, please, my humble request is that try to update your knowledge. Skills also are to be improved, and this is where a role of a nurse leadership comes, to arrange for training programs for the nurses, in-service training programs, encouraging and motivating nurses to go for higher education. And it should not be only getting degree on the paper, but it should be converted into imparting quality care to the patients. So knowledge, skills, and attitude. Let us have a positive attitude towards quality patient care, and the scenario will definitely change. So role of a nurse in patient safety: conduct patient safety leadership rounds, create a reporting system, appointing a patient safety officer. This is usually done by a nursing leadership, involving patient in safety initiatives, share safety reports at shift change. When you are giving report, it's not only when you are changing, when morning shift is changing to evening shift, when you are giving over, you must include safety reports in your over. Not only talking about patients' vital signs or other parameters, but intentionally include safety reports when you are having a shift change. Creating an adverse event response team in your own organization. In conclusion, patient safety is the cornerstone of high quality healthcare. Much of the work defining patient safety and practices that prevent harm have been focused on negative outcomes of care. See, usually when we talk about the patient safety, I know that everybody talks about negative outcomes, but there are some positive outcomes also which are not reported. So let us start talking positive to change negative into positive. Nurses are critical to the surveillance and coordination that reduce such adverse outcomes. much work remains to be done in evaluating the impact of nursing care on positive quality indicators such as appropriate self-care and other measures of improved health status. So let us talk more on the positive outcomes and less about the negative outcomes. A takeaway message from my side: safety protects people, quality protects job. So let us have both. Let us protect people who are under our care, who are given in our hands. So it is our moral and ethical responsibility to protect these people. And if you want to protect your job, there is no other parameter but to no other aspect unless you maintain a quality. You cannot compromise on quality. So if you want to protect your job, you must emphasize on quality. Thank you. Thank you very much for this opportunity that I have got. And once again, I want to thank the organizers and the organizing team, Maharashtra Nursing Council, the collaborative team, for this opportunity that they have given me to share my views on patient safety, a step towards quality care. Thank you.
Thank you, Madam. Madam has explained in very simple words about patient safety, its importance, root causes, which everyone, Madam has highlighted root causes in the clinical areas and steps to improve patient safety. Also, tips for ensuring patient safety in healthcare setting. 5 strategies to improve patient safety, model of patient safety, and role of nurse in patient safety. Thank you, Madam, for your knowledgeable words. I am sure everyone in the clinical area, we can improve our knowledge and we will put it in a practical area. Thank you, Madam.
Thank you, ma'am, for your thought-provoking address, which has set a perfect platform for all our speakers to deliver the presentations on various aspects of patient safety. I have a few reminders for the delegates. We will have question and answer session at the end of each speech. You may write your questions in the group chat. Also, I request all the delegates to register or rename yourself with the name that you have registered with Maharashtra Nursing Council. I remind all the delegates to kindly fill the pre-test form. Now it's my pleasure to invite our second speaker of the day, Ms. Anishma Sajusekan, Training Manager, Patient Safety, National Healthcare Academy. Reminders for the delegates. We will have question and answer session at the end of each speech. You may write your questions in the group chat. Also, I request all the delegates to register or rename yourself with the name that you have registered with Maharashtra Nursing Council. London branch of National Healthcare Academy, fill the pre-test. Let me introduce pre-test form. Now it's my pleasure to invite our second speaker of the day, Ms. Anishma Sajusekan, from Training Manager, Patient Safety, National Healthcare Academy. Reminders for the delegates. Further, have question and answer session at the end of each speech. Infection control. You may write your questions in the group chat. And also, I request all the delegates to register National Healthcare Academy yourself with the name that you have registered with Maharashtra Nursing Council. Currently, she is working London branch of National Training and Development Manager. Let me introduce ma'am with National Healthcare Academy. Now it's my pleasure. Over to you, ma'am.
Am I audible? Is the screen visible?
Yes, ma'am. Yes, ma'am.
Yeah, okay, thank you. So without further ado, we'll just go into our topic. So I have been given the topic for international patient safety goals. We will be discussing in brief about 6 patient safety goals. Okay. So a brief history on the IPSG, that is International Patient Safety Goals. It was first formulated by the Joint Commission International, JCI. Okay. So after that, when they formulated this 6 goals, it was under various names. So in the year 2006, they had formulated this international patient safety goals. And later they had few versions of it. The concept was quite same. They even in the initial version they had the same goal, and even the version which is using now, we are having the same goals, but the namings are different. That's the only difference. So the version has not changed the concept. The concept remains the same from the start to end. So JCA had formulated it, and after formulating the international patient safety goals, it has been used into into accrediting their hospitals. So all the hospitals under JCI, they have to put international patient safety goals as one of their standards to keep the accreditations going on. Later in India, where it comes to NABH, NABH has also formulated the same. It has took the concept of the international patient safety goals formulated by JCI and kept the same for their accreditation standards. So that was a brief about these patient safety goals. Okay, so international patient safety goals helps in accreditation of organizations, addresses specific areas of concern in some of the most probability areas of patient safety. What are these problematic areas of patient safety? We will be discussing it right now. So this is a snapshot of all the 6 goals. So first we have to identify the patients correctly, effective communication, goal 2. Goal 3 is the safety on high alert medication. Goal 4, timeout, okay, correct surgery, correct procedure, correct patient. Goal 5, reduce the risk of hospital or healthcare acquired infections. Okay, goal 6, reduce the risk of patient harm resulting from fall. So this is a snapshot of it. Each one we will discuss in brief. So goal number 1, identify the patients correctly. 2 identifiers you have to use. Use the full name. Okay, as Dr. Nilima ma'am has said earlier, do not use patient number, bed number, or any such thing to identify your patients. Okay, use their full name, and along with the full name, medical record number. Because what happens is sometimes we may be dealing with the patients who are having the same name at the same time, right? So to avoid that confusion, yeah.
Ma'am, first slide is still visible.
Okay, sure. Is the screen
Yes,
visible now?
now it is visible. Yes, ma'am.
So this was a snapshot of all the 6 goals. Okay. Yeah. Goal 1, identifying the patients correctly. Use the full name. And if at all you're dealing with the same name patients at the same time, okay, when those chances are very rare, but still to be prepared for that, use the medical record number also. Okay. So that will ensure that you are not giving wrong treatment to the wrong patient. Okay, and before all invasive and diagnostic procedures, before giving any administrating medications, especially blood and blood products, okay, to before any invasive treatments at the OPD level or at the operation theater level, okay, these criteria should be the first thing that has to be ticked off, okay, to avoid any cases of gross medical negligence. Okay, the best concept which we have come up recently is having wristbands. Okay, in wristbands nowadays we use barcode also, given what technological facilities different hospitals have. Depending on that, we use wristbands with barcode, without barcode, or wristband just with the medical record number. Okay, so that's what we are looking at. And the main thing, do not use patient room numbers, bed numbers, or just the location, which ward, okay, the corner ward, the middle ward, the second ward, like that. Okay, do not use that kind of concepts to identify your patient. So that was in brief about the first goal. Okay, identifying your patients correctly. Second, the importance on effective communication standards. Okay, before that, from a healthcare professional point of view, you remember the mnemonic ISBAR, ISBAR. Okay, I stands for identification. As from coming from a nursing fraternity, when the shift changes, when the shift ends and the new nurses come, okay, I stands for identification. Identify yourself first. Okay, I am so and so. I am reporting for my duty for this shift. Okay, so like identify yourself. Then situation, the patients which you have been hand over. okay, which the list of the patients which you have got. Identify their current situation during your reporting time. What was the situation? Okay. Then we have bar background. Okay, so the patient is having cardiac arrest, and he's on oxygen, etc. So background, had cardiac arrest. Okay, so read a bit on the case history or the case file before your shift, what was given to the patient, etc. Okay, so background. And then assessment. You do your work. You do your assessment. Take the vitals. Check if the medications under your shift has been given or not. Okay, then report down the response what the patient has shown. Okay, the symptoms and the response what the patient has shown. So that is ISPAR. So follow this mnemonic ISPAR. Okay, identification, situation, background, assessment, response. Follow that. Your effective communication, the first criteria is done. Few tips which I would like to share on improving the effective communication with regards to the healthcare structure. Share the floor. Whenever you're discussing a patient's history with the doctor, specialist, consultants, with the healthcare team in general, okay, give each one of them time to put their inputs. Okay, every opinion, every knowledge from each of the members in healthcare team counts. Keep focused. Do not deviate from the conversation. When you're talking about one person, one patient in front of them, keep focused. Talk about the situation of that patient only, and do not include any other patients or any other patient party into that conversation. Take care of yourself, what you need to stay, okay, where you have to be focused. Okay, if you in the previous shift you were in other ward, yesterday you were in other ward, okay, don't worry about the patients of that ward. Present at present where you are focused on, where you have been put into duty, focus on those patients only. Embrace the differences. Okay, sometimes a nurse's point of view may clash with the doctor's point of view, with the specialist point of view, with the patient himself or herself, that point of view. Okay, embrace the differences. Respect confidentiality. What is shared by the patient on case history, on case file, in the private communication within that four walls, it has to stay there only, until and unless obviously called by the court of law. Okay, or until and unless, do not share your patients even while discussing with your fellow staff, or on the corridors, in the lift, on the staircase, anywhere, walking around just talking about the patients. Avoid that kind of situation. Avoid healthcare speak, the same thing. Avoid any discussion about the patient's history, patient's case. It applies for doctors, nurses, everyone in the healthcare team. Avoid healthcare speak when there is a third party around who is not the part of the healthcare team. Okay. Be present, give your full attention. The same thing, remain focused. Okay, be present in your conversation, in your communication. Know your stuff. This is for the student nurses. Okay, when you are posted in a ward for the first time, the first day when you're posted in the ward, you will be coming up with bombarded with many different types of cases. Okay, theoretically you may know very less about these cases when you start working in the practical field. Okay, so do your homework. When you come across new cases or any case for in general, go to the library, read about it, come back the next day prepared to answer questions, to share an evidence-based care for your patient. Respect people's time. Don't be late. Be punctual. From your side, there should not be any complaint on being late. So coming to the third goal, improving the safety on high alert medications. So every hospital, they have to develop and implement a process to manage and to safely administer any kind of high alert medications. Here, not just the concentrated electrolytes, it's just an example, but every type of high alert medications. We will discuss about that, which all things come under high alert medications. Okay, potassium chloride, potassium phosphate, sodium chloride, magnesium sulfate. Nurses who are administrating these medications, okay, sometimes may get confused with the chemical formulas which is written on the ampules, etc. Okay, so missing certain key notes here and administering the wrong medication is very hazardous, and it is kind of a common thing. That is why potassium and any other concentrated electrolytes come under this category of high alert medications. remove the concentrated electrolytes from the patient care unit only to the pharmacy. So when the doctor puts the order to give concentrated electrolytes, any electrolyte for that sake, the nurses, when the nursing department, the ward doesn't have the store for it, okay, because from the hospital's point of view, it has been given to the pharmacy. Okay, the pharmacy will be very vigilant in sending the right formulation, so avoiding that kind of mistake. So these are the examples for high alert medication. Again, one more mnemonic, A pinch. Okay, remember A pinch. A stands for anti-infectives, amoxicillin, ampicillin, methicillin, etc. All the antibiotics will come under this category. A stands for anti-infectives or antibiotics. P, potassium and other concentrated electrolytes. I stands for insulins. N for narcotics and other sedatives. C stands for cytotoxic agents. H for heparin and other anticoagulants. Okay, so remember this mnemonic for A pinch. So that will be even you can segregate your pharmacy department or even in the ward what pharmaceuticals you have. Okay, you can segregate these pharmaceuticals in this order, A pinch, and away from other pharmaceutical drugs, and mention that these are high alert medications. So when the nurses enter that particular area to acquire any drugs, they will be much more concentrated in their work. Okay, now coming to the fourth goal, ensure correct site, correct procedure, correct patient surgery. Timeout, that's what we call. Okay, before you do the incision, remember that, not after the incision, before any surgical incision, these things has to be checked. Okay, we have a WHO surgical safety checklist. It can be implemented. It's not compulsory, but it having a WHO surgical safety checklist implemented in all the hospitals, that will reduce the chance of any wrong patient or wrong site surgeries. Okay, so that becomes a sentinel event at the end. So, and it not just the doctors, but the hospital itself, the institution itself has to bear the consequences of such serious outcomes. Okay, so timeout, is the patient right? Okay, have we bought in the right patient? Okay, do we have the right location, the right surgery, which area, right, left, okay, superior, anterior, which area we have to do the surgery? Are we doing the right procedure? Do we have the right surgical instruments and the kit ready? Okay, so these all things will come under timeout. So correct patient, identify the patient is correct. Correct procedure, check the surgical instruments which you have kept ready. Remember that before the patient arrives into the operation theater, the surgical instruments for that particular procedure has to be ready. Before the patient enters the operation theater, check the count of the surgical instruments which are ready, and is it comprehensive for this particular surgery or not. Okay, correct side, correct location of the procedure has to be checked, verified with all the surgical team present around the patient. Okay, agreement that we are set to go. When everything is all ready, okay, the main surgeon will give a thumbs up and they will start the surgery. Okay, so that's the goal. Now, reducing the risk of healthcare associated infection. Goal 5, 7 strategies to prevent healthcare associated infection. The first thing is your 5 moments of hand hygiene. Okay, before touching the patient, after touching the patient, before the procedure, okay, after the procedure, etc. All these 5 moments of hand hygiene, it has been known that the mere use of 5 moments of hand hygiene can statistically reduce the healthcare associated infection to 70 to 80%. Okay, so that's the importance of hand hygiene here, using the right detergent, soap, etc. For the right amount of time given to what procedure you're going to do. Is it surgical or medical hand washing, etc. Okay, for the right amount of time, 20 seconds, etc. That has to be practiced, and you can see the change yourself. Okay, various hospital acquired infections like communicable infections like MRSA, VRE, etc. Okay, it has been seen that healthcare professionals, just because they are not diligent with hand hygiene, is leading to the increased rise of MRSA, etc. You can just imagine, just by putting hand hygiene into place into a diligent practice, okay, you can reduce all these infections to completely negligible amount. Okay, then environmental hygiene. that comes in with the package of the housekeeping staff, what work they have to do, how you as a hospital administration department, how you are training your housekeeping staff whom you are hiring. Okay, for administrative areas there is a different kind of cleaning, for OT there is a different kind of cleaning, for wards there's a different kind of cleaning. Okay, we should not be doing dry mopping, only wet mopping should be done. Okay, so that kind of knowledge and training has to be imparted to the housekeeping staff. Okay, screening and cohorting the patient whenever you are facing in a situation just like the pandemic which we are witnessing right now. Okay, cohorting the patient means putting all the patients who are having the same diagnosis together. Okay, for example, multi-drug resistant TB patients. Okay, multi-drug resistant tuberculosis patient. When you see 2 or 3 cases in your hospital, they have been admitted. It's ideal to put all them together in one ward if you are falling short of private wards or single rooms. Okay, ideally in the Indian scenario with our public health hospitals, we are always falling short with private rooms or single rooms. In that case, this is the next best option, putting the patients who are sharing the same infections together in a ward with a ideal separation of 5 to 6 feet difference between each of their beds. Okay, so that is screening and cohorting the patients. As soon as the patient comes in, screen them. If they are carriers of MRE or carriers of VRE, carriers of any multi-drug resistant, any antibiotic infections, etc. Okay, screen them for that, and accordingly, based on the results, positive or negative, cohort them if necessary. Okay, cohorting means that putting together the people who suffer from the same infections together. Okay, surveillance, check for the rate of hospital acquired infections, CLABSI, COTI, VAP, okay, SSI, or every ICUs, every critical care units will have their surveillance register to keep a track on how many cases per month or weekly they are seeing. Okay, is the statistics going up? Is it an upward trend or is it a downward trend? Okay, that surveillance will show. Antibiotic stewardship, it's a policy which the hospitals have to take an oath to commit to the antibiotic stewardship. That means unnecessarily you will not prescribe antibiotics to your patients, because we are looking at a system of healthcare where we have generated this new strain of bacteria and viruses because of our unjudicial and unjustified use of antibiotics. To control that, we have pharmacy audit, doctor's audit, medical audit, etc. Different audits are kept into place when antibiotic stewardship is took by the hospital. And following the guidelines, whatever your infection control policies are there, which the hospital has formulated to suit to its performance. Okay, follow that guidelines. What guidelines the CDC has given, what guidelines the WHO has given. Okay, make a mixture of all these guidelines, what suits you well for the optimum function for your healthcare organization. Follow that. Okay, and safety culture. All of these goals which we are discussing, the 6 IPSG goals which we are discussing, are the core factor here in this safety culture. Okay. Finally, the last goal, reduce the risk of patient harm resulting from falls. In this slide, in this particular slide, you can see various images on how we can prevent falls. For example, in the IV line, when the IV line is there, with which the patient can walk around. Sometimes the patient feels like walking, doesn't want to sleep or sit around in the ward all day. Okay, you can put a tag like this. Okay, ask for help, don't fall, like that, and assist the patient. Have a nurse or someone to assist the patient while they are walking along with the IV lines. Okay, in case of pediatric wards, we see a lot of fall cases in pediatric wards, especially in cases of toddlers, etc. You can put safety precautions like this, a yellow slider onto the railings, bed railings. So the even when the shift changes, the new nurses come into the ward. Just by looking at the railings, they know which patients are at the risk of falls. This can be put even in the ICUs and even in the general patient wards, not just for the pediatrics. Okay. Then we have this wristband, which is yellow colored. Okay, fall risk. Those patients who are under fall risk, they will be having this shared wristband. So even the new nurses, if it is not communicated in reports, okay, just by visualizing, they can identify which patients are under fall risk and which are not. Okay, whenever there is a wet floor for the housekeeping staff while training them, whenever they are doing the wet mopping, etc., they have to use this caution floor signages, etc. Okay, so first of all, you have to identify which all patients are at risk of fall, especially in the previous 24 to 48 hours. If the patient had received any form of sedatives, or if the patient was under anesthesia in the previous 48 hours, they will come under the high risk category for falls. Okay, they will be in the post-operative ward, but still they will be considered as a high risk category for falls. The patients who do not have the control over the neuromotor functions, okay, impaired neuromotor functions, patients who come under that category, children, okay, patients who are mentally challenged, okay, those also will come under the risk of fall. Wet floor signages which is not placed, okay, if housekeeping staffs forgot to place the wet floor signages, it will result in not just falls for patients but also for the staffs as well as the visitors, okay, and protect the vulnerable patients. Especially falls are much more common in old age senior citizens, patients who are senior citizens, okay. Make sure their bathrooms, etc., have the side railings on which they can latch on in case of any falls. Ask them to always hold the side railings in the bathrooms or while walking or while climbing the stairs. Okay, use the side railings to prevent any unforeseen events. Okay. So again, concluding the 6 goals. First, goal 1, identify the patients. Goal 2, improve effective communication. Goal 3, improve safety on high alert medications. Goal 4, ensure correct site, correct procedure, correct patient surgery. Goal 5, reduce the risk of healthcare associated infection. Goal 6, reduce the risk of patient harm resulting from falls. A brief on our courses in NHCA. The nurses who are graduating soon, they can look for these courses, the management courses in quality control, infection control and prevention management, and Six Sigma Green Belt. Okay, these courses are 6-month duration courses. We have exams, everything is conducted online. Okay, the certificate is valid for the lifetime. You do not have to renew the certificate, and these certificates are accepted in India, USA, Gulf countries, African countries, European countries, Australia, Canada. Okay, we have online classes also, weekly online classes, which is not compulsory. If at all you're free, you can attend the weekly online classes once you have took the admission. Okay, along with the job, you can pursue this courses. Okay, it gives you your resume a feather, an extra feather, so that your resume is highlighted with these courses. Okay, chances of you getting a promotion, climbing up the hierarchy is much more with this diploma in middle management course. Thank you. That's all from my side. Thank you all for having me here.
Thank you, ma'am, for your influential message. Your session was very enthusiastic and valuable knowledge. Ma'am has very efficiently described all the 6 international patient safety goals, including high safety alert, importance of communication. I hope, I'm very sure that all the delegates are very much beneficial with ma'am's presentation. Thank you so much, ma'am.
Thank you for having me. Have a nice day all.
National Healthcare Academy is ISO 29993 and ISO 9001 accredited world's eminent training and certification provider. Headquartered in Singapore, NHCA is accredited to international organizations like International Accreditation Forum, International Accreditation Services, and Ecofin Healthcare. NHCA courses have been audited independently by US and UK National Healthcare Academy is ISO accepted in 29993 and ISO 9001 accredited world's eminent training and certification providers are valid. Headquartered in Singapore, NHCA is accredited to international organizations like International Accreditation Forum, International Accreditation Services, and Ecofin Healthcare, and also NGOs. NHCA courses have been audited independently by US and UK National Healthcare Academy, as well as ISO in ISO 9993 and ISO Hospital 9001 accredited world eminent training and certification providers are valid. Headquartered in Singapore, NHCA is accredited to international organizations like International Accreditation Forum, International Accreditation Services, and Ecofin Healthcare, and also NGOs. NHCA courses have been audited independently by US and UK National Healthcare Academy, as well as ISO in We will have a short 5 minutes break. Please don't go anywhere. You can have your 5 minutes and rejoin back. Go anywhere. You can have your 5 minutes and rejoin back.
Now I invite our third speaker of the day, Dr. Sushila Kavde, Head Operations of Quality, Royal Mudal Hospital and Research Center, Pune, to speak on issues in patient safety. Let me introduce ma'am. Ma'am is a BHMS. Ma'am has completed her BHMS and MBA in Hospital Administration. Ma'am is in State Chairperson of Accreditation Health Organization, Maharashtra. Health, Quality and Operations, Royal Mudal Hospital and Research Center, Pune. Ma'am is a Specialist Lead Auditor in Bureau Various. Ma'am has a huge 20 years of experience in healthcare and hospital management. 10 years of experience in hospital quality management and NABH accreditation. Ma'am is a consultant for over 40 hospitals for getting various accreditations and certificates. Ma'am is a manager of quality and patient safety in Bharati Vidyapit University, Patient Health Medical College, Maharashtra, and Research Health, Quality and Quality and Operations, Royal Mudal Hospital and Research Center, Pune. Team of Ma'am is a Specialist Lead Auditor in Bureau Various. Ma'am has a huge 20 years of experience in healthcare and hospital management. 10 years.
Hello.
Yes, ma'am.
Shall we start?
Yes, ma'am.
Yeah. So make the PPT full screen. Na? Yeah. So shall we start?
Yes, ma'am, you may start.
Yeah. So good morning, everyone. Hello. Yeah. Good morning, everyone. This is Dr. Sushila. So today we shall have we start?
Yes, ma'am.
Hello. Yeah. So make the PPT full screen. Na?
Yes, ma'am, it is full screen.
Yeah. So good morning, everyone. Yeah. So welcome you all for this. So shall we start?
Yes, ma'am. Yes, ma'am, you may start.
Yeah. So good morning, everyone. Hello. Yeah. Good morning, everyone. This is Dr. Sushila. So today we shall we start?
Yes, ma'am.
Hello. Yeah. So make the PPT full screen. Na?
Yes, ma'am, it is full screen.
Yeah. So good morning, everyone. Yeah. So welcome you all for this. So shall we start?
Yes, ma'am. Yes, ma'am, you may start.
Yeah. So good morning, everyone.
Ma'am, you may start again. We will share the PPT once more.
Shall we start?
Yes, ma'am.
Yeah. So good morning, everyone, and welcome you all for this international e-conference. So topic of the today's my session is issue in the patient safety. Next. Next. So before starting my session, I would like to
Ma'am,
do special thanks to the Terna Nursing College, Nerul. So on the behalf of the Terna Nursing College, I am taking this opportunity to express my information and knowledge about the patient safety to you. Shall we start? Yeah, next.
Yes, ma'am.
Yeah. So good morning, everyone, and welcome you all for this international e-conference. So topic of the today's my session is issue in the patient safety. Next. Next. So before starting my session, I would like to do special thanks to the Terna Nursing College, Nerul. So on the madam. Hello, Terna team. Hello. Hello. Terna Nursing College. Next. So before starting my session, I would like to do special thanks to the Terna Nursing College, Nerul. So on the madam. Hello, Terna team.
Yes, ma'am, we are able to hear you.
Hello.
Ma'am, can you hear me?
Hello.
Ma'am?
Terna Nursing College. Hello. Yeah, ma'am. Next. So before starting my session, I would like to do special thanks to the Terna Nursing College, Nerul. Give me some time. On the time. Madam. No. Hello, Terna team.
Yes, ma'am, we are able to hear you.
Hello.
Ma'am, can you hear me?
Yes, ma'am. Hello.
Some technical difficulty, ma'am.
Hello. Yes, ma'am. Terna Nursing College. Hello.
Yes, ma'am.
Hello. Next. I think some technical problem is there, ma'am. Starting my session, I would like to we will stop. I am able to hear again and again. I am not able to miss some time on the time. Madam. No. Hello, Terna team.
Yes, ma'am, we are able to hear you.
Hello.
Yes, ma'am. Ma'am, can you hear us?
Yes, ma'am.
Yes, ma'am. Ma'am, you may continue. There was some technical error because which voice was repeating, ma'am. You may
Okay,
continue.
ma'am. Ma'am, what to do? Okay, okay. Then I have to download this presentation which I had sent to you. Yeah, just give me some time. What is the problem? But why it is making echo? Same voice coming again and again. Oh, sorry. Ma'am, is it, hello?
Yes, ma'am.
Do you see my PPT right now?
Yes, ma'am.
Yeah. Is it okay or I have to make a full screen?
Yes, ma'am. Can you make it full screen, ma'am?
Just a minute. Huh?
Yes, ma'am.
Hello?
Yes, ma'am.
Is it okay, ma'am?
Yes, ma'am. Yes, ma'am.
Yeah. Shall we start?
Yes, ma'am. Sure.
So, good morning once again and sorry for the interruption. So, welcome you all for this international e-conference, which is on the issue on the patient safety. So, special thanks to the Terna Nursing College, Nerul, who has given this opportunity to express my knowledge about patient safety in front of you all. So welcome you all once again. Sequence of today's presentation is history of the patient safety. Hope I am audible and I am visible also.
Yes, ma'am.
Yeah, so I'll proceed. Yeah. So sequence of my presentation is that history of the patient safety. Then NAPH 5th edition requirement about the patient safety. Understanding the patient safety program and different element of the patient safety. NPSG, that is National Patient Safety Goal, though it is a topic of next speaker, I am just touching to the tip of the NPSG and guidance on implementation of the program. So before going ahead, I thought we should know what is meant by patient safety. So history of patient safety started from the Hippocrates. Hippocrates has stated several centuries ago that do not harm because nursing are the backbone of the healthcare industry. And in this industry, 24/7, they are closely with the patient. So while taking care of the patient, we should ensure that we should not harm to the patient. We should care the patient, but if not, at least we should not do harm to the patient in the healthcare. So why healthcare is unsafe? What are the reasons why healthcare is unsafe? Because healthcare is a very complex and complex infrastructure, complex in the structure. In the healthcare is the main industry, main service industry, wherein human factor playing important role other than the machineries. And basics are very challenging in the healthcare because of the continuous ongoing recruitment and ongoing movement of the staff in the century. And in the 21st century of the medicine is going for the quality. So though we are going for the quality, considering the complex structure of the healthcare and having the high involvement of the human factor, this is very unsafe industry that way. So what we have to do? How we should ensure the safety in the industry? So why safety in the hospital? As you know, hospital is the people intensive place. It provides services to the sick patient, not to the healthy patient. In hotel and all, we are providing to the healthy customer, to the happy customer. But healthcare is the industry wherein we are taking care of the sick patients round the clock, 365 days. So people have a free access to entry any part of the hospital, any time for the advice and the treatment. And hospital atmosphere is filled with the various emotions because in gynec and OBGYN, happy emotions are there. In intensive care unit, there are very sad emotions are there in the relatives. So it is a mix. It is a place where mixed emotions are there in the hospital industry, like excitement, life, happiness, death, and sorrow. Since hospital operate under continuous strain, it gives rise to the irritation, confrontation, conflict, aggression, threatening the life of hospital staff and hospital properties. That's why safety is very important in the healthcare. So this impact of unsafe healthcare, if healthcare is not safe and we are not taking care of the safety in the hospital, what will happen? So in the unsafe healthcare industry, definitely there will be incident of near miss, no harm, or sometimes it could be sentinel event or death. So we have to play our role very, very judiciously in the healthcare. So near miss means incidence is about to happen, but someone has stopped the incidence. If sometime incidence has happened, but luckily patient or the relative has not got any injury. Sometimes incidents has occurred, but there is a minimal injury to the patient. And sometimes because of the unwanted, unexpected incident, even sentinel event also could occur, or it could be due into the death outcome to the patients or relatives. So this impact is very, very serious. So what is the tool for that? So to achieve the safety in the healthcare, we should know the patient safety. So what is meant by safety first of all? Safety has full form like sense the error, act to prevent it, follow safety guideline, inquire into the accident and death, and take appropriate remedial measure, and this is your responsibility. So my dear colleague, though you are from various stratas of the nation, you should know this full form of the safety. Sense the error, act to prevent it, follow the safety guideline as per the local guideline of your country, inquire into the accident, incident, take any small incident or near miss very seriously, act on it and do the CAPA. This is your responsibility. So who are the stakeholders involved in the safety? In the safety, staff, visitor and patients are the main stakeholders. And why safety? Because safety is very much important for the people, for the place, for the property, contributing into the hospital safety. So this is very important role of everyone who is working from chairman to doorman in the hospital to ensure safety in the healthcare industry. So coming to the patient safety. Why patient safety is very much important? Nowadays, patient safety is need of the hour. Though we are progressing towards technology, we are progressing towards the high-end equipment and all, still safety is the concern. Safety is the center point for the patient care. So patient safety is absence of preventable harm to a patient during the process of healthcare. This is very important that it is absence of preventable harm. It is preventable. So discipline of patient safety is the coordinated efforts to prevent harm to the patient caused by the process of healthcare itself. It is generally agreed upon the meaning of the patient safety is please do not harm. See my colleagues, already Hippocrates in long decades ago or century ago, he had explained that do not harm, and still we are talking on the same aspect that please do not harm to the patients. So why there is the risk? In the healthcare, human error can lead into the risk. So human error is the important aspect which gives the risk. Sometimes it could be near miss, sometimes it could be harm. So always human error is not intentional, my dear colleague. Sometimes it could be lapses also, sometimes it could be repeated error also. But once unwillful error is there, it is called as miss. You have to act on the small near miss so that it should not be repeated again and again and again in your practices. If it is repeating again and again, it is called as crime, not as a error. So here comes to the role of the patient safety. Everyone's role is ensure that error should not be repeated again and again in the healthcare industry. We should be very careful at the near miss level, at the buffering level, so that error should not reach to the patient. So patient safety work with this motto that there will be no avoidable injury or harm to the patient from healthcare they receive, and appropriate clean and safe environment will be provided to the delivery of healthcare. My dear colleagues, patients are coming to the healthcare industry to take care of their health, to take care of their disease. They are not coming to the healthcare to receive the error from the staff or the doctors. So we have to be very careful in the healthcare industry. So develop a patient safety program. So what is the strategy? How we should achieve this patient safety in your hospital? So simple step, though it is international accreditation program or national accreditation program, they are saying that you should have your patient safety program in place. With the help of patient safety program, definitely you could document, you could implement, you could train your staff on the safety aspect to achieve the 360-degree patient safety. What I am saying, 360-degree patient safety is very important in healthcare. So you should develop a patient safety program. So what is the value of patient safety program? Why it is very important in any healthcare organization? To reduce the fear of reporting, to reduce the error through tracking, through analysis and targeted improvement. Patient safety program is very important to reduce the error through prevention. We should prevent the error. Patient safety program improve quality as well as patient safety and employee satisfaction. Also, this patient safety program certainly reduce cost associated with error. My dear colleagues, if we are preventing the error, definitely error related cost will be reduced. There will be less burden on the patient pocket. We will see in the next few slides how it will give the less burden on the patient pocket if there is no error. And definitely if any hospital is giving good service, zero error, so this will be the good hospital for patient, and this will be one of the marketing opportunity to attract the customer in your hospital. So value of patient safety is very important. So we'll turn to the patient safety. As you know, one of my colleagues is taking this topic of the patient safety. So first goal of patient safety is identify patient correctly. Second is to ensure safety of the patient during the surgery. To ensure infection prevention, to prevent hospital acquired infection in the patient is the third goal. Fourth goal is medication safety. Fifth goal is prevent patient fall and bed sore. So these are the national patient safety goal. So identify patient correctly is the first goal, which will be taken by my next colleague. So I'm not wasting time, but here I would like to emphasize one point. In every hospital, you should identify patient with the UHID, unique hospital ID number and name of the hospital. And in the neonatal, you should take footprint to identify the patient. This is very important at every step. Then improve effective communication is the second goal, which you have to take care. When you are exchanging information in the healthcare, you should ensure 360-degree communication is hassle-free. Enhanced communication is also required at certain steps, wherein breaking bad news, informing critical status, handling adverse event, handling patient violence. You should ensure correct communication and effective communication amongst the patient and the staff, improve safety of high alert medication. So medication safety coming into picture. So at every step, at the starting of medication, taking the medication, adding the medication, reviewing the medication, and stopping the medication are the 5 elements of medication safety. Food drug interaction is very important in ensuring the medication safety. So patient and family engagement. Nowadays, this WHO, World Health Organization, is also very much behind patient for patient safety. They are saying that patient safety is not only responsibility of hospital industry, it is a core responsibility of patient. If I am a patient, being a patient, my core responsibility of my own safety. If I am a family member of any particular patient, I should ensure safety of my family person as a patient. So patient and family engagement in medication safety is very, very important. If you are a patient, you should keep a list of your medication, use a weekly or monthly pill box, ask your pharmacy in the provide blister packaging, ask the pharmacist to provide label, how to take, when to take, after food, before food and all, set alarm for the reminder, and ask the pharmacy in case of any complaint or any adverse event. So ensure safe surgery. As you know, WHO surgical safety checklist is there, which will take care of the patient safety. Reduce HAI. Each and though we are taking utmost care of the disinfection, cleaning, and infection control practices in the hospital, though there are certain organisms existing in the hospital setup which gives hospital acquired infection to the patient, and we should not give such infection to the patient, because patients are coming to take care of their disease, not to get infection from the hospital. So we should be very careful in hand hygiene, following the standard precautions, so that there will not be any HAI to the patient. Then, as you know, WHO also has stated 9 patient safety solutions. So what is meant by 9 patient safety solutions? My dear colleagues, whatever the patient safety goals are there, these goals are top up with the 3 new points. These goals, National Patient Safety Goal, are top up with the 3 new points. That is LASA safety, like medication safety, look-alike and sound-alike medications, and control of concentrated electrolyte is the one solution additionally added into the goal. Then avoiding catheter and tubing misconnection. If you are using look-alike catheter and tubing, that is vascular catheter and non-vascular catheter in your hospital, you should make some provision to identify catheter. You should give labeling to the look-alike catheter, so that there will be no error. And while giving any injection or while draining out any catheter, you should trace that catheter from source till the top. From the patient body, you should ensure, you should verify whether correct catheter I am using for injection. Sometimes vascular, so in our hospital what we use today, you can give label red catheter color, red label to the vascular catheter, and blue color to the non-vascular catheter. This practice you can keep in your hospital to avoid the misconnection of the catheter. Third, last goal, 9 patient safety goal is that assuring medication accuracy at the transition. That means medication reconciliation, medication checking during the transit period of the patient. So these are the 3 goal, 6 patient safety goals and 3 additional solutions called as the 9 patient safety solutions. Now we'll go to the principle of patient safety. In any organization, as a nurses, you should follow the 10 rights of medication. All you must be aware about the 10 rights of medication. I'm not going into the depth of it, that right drug, right patient, right dose, right route and time. So proper identification, following the safety, accuracy of the medication, and checking verification before the drug, during the drug, after the drug, you should ensure the patient safety from nursing point of view. So what are the elements of patient safety? Apart from National Patient Safety Goal and apart from 9 patient safety solution, there are some additional points called as an element of patient safety. What are they? So vulnerable patient, very, very important. So below 60 and above, below 60, below 60 year and children, all the ICU patients, all anesthetic patients, bedridden patients are called as a vulnerable patients. So critical alert report is the second element of the patient safety. You should do the read back policy while getting critical alert report from the lab or from the radiology. Lab and radiology should list out critical alert, and this critical alert should be taken by nurse and doctor with read back policy. And after getting critical alert intimation to nurse or to the doctor, immediately treatment should start to the patient, because these are the life-threatening reports. That's why it is called as a critical report. Then clinical alarm settings. In healthcare, only particular doctor and nurse has right to set the alarm. This is very important. Then to prevent the pressure ulcer. This is also very big concern in the healthcare industry, that we should prevent pressure ulcer development to the patient. Venous thromboembolism. So each and every patient should be assessed by the nurses during their initial assessment and daily assessment for DVT, deep venous thrombosis. So this DVT you can keep as your part of daily assessment to the patient post-surgery or for bedridden patient, especially you should give the care. Then proper biomedical waste management. So why include the near miss? Why near miss is very important? You should give highest importance to the near miss other than the error. This is our principle. Why? Because near miss is giving chance to identify error before reaching to the patient, so that you can take appropriate strong measure to prevent error reaching to the patient. So this is good opportunity to capture the information. So encourage reporting of near miss in your hospital, so that you will get maximum reporting and you can prevent the error and you can prevent the sentinel event. So this is very important to capture the near miss. So what are the nursing quality indicators? Very, very important. In nursing quality indicators, considering the patient safety, you should follow this mandatory quality indicator, I would say from my side, because if you are judiciously following this quality indicator, definitely it will give you sense of relaxation if your rates are within the benchmark limit. So what is meant by quality indicator? First of all, quality indicator are nothing but the measuring component. These are the measuring device wherein we can able to get information about our quality. So percentage of patient identification error. This is very important indicator. Though it is very, you will say it is very small. This is very important to prevent the further harm. Percentage of nursing initial assessment within 30 minutes of admission of the patient. Within 30 minutes of admission of the patient in the ward, you should complete nursing initial assessment, wherein in the ER and the critical critical department like ICU, NICU, PICU, you should complete your nursing initial assessment within 5 to 10 minutes, depend on the hospital setup. Then appropriate handover. In any hospital, if you are practicing this nursing quality improvement program, you should ensure that appropriate tool is used for giving the handover. It could be I pass the baton or ISBAR. So what is full form by ISBAR? ISBAR means ISBAR. I means identify the patient correctly. S means brief about situation. B means brief about background. A means assess the patient. And after assessing, if you are getting some information, give some recommendation. Identify the situation, background, assessment, and recommendation. This is the full form of ISBAR for appropriate handover. So you should identify inappropriate handover in the shift. Percentage of, you should monitor bed sore, patient fall as a nursing mandatory indicator. You should also monitor restraint related injury, because in the critical setup, you are giving physical restraint as well as chemical restraint to the patient. So you should monitor this indicator. Then pain assessment, daily pain assessment and pain management. It could be, what do we say, non-therapeutic pain management or therapeutic pain management. You should monitor the management. Then percentage of needle stick injury in the nurses. Percentage of hand hygiene injury, hand hygiene percentage in the nurses. So you should monitor this nursing quality indicator. And last but not the least is percentage of extravagation. If you are having chemotherapy or pediatric setup, or you are transfusing the concentrated electrolyte to the patient, there are chances, if you are not using right cannula to the right age of the patient for right intravenous solution, there are chances of getting extravasations. So you should follow any tool or to identify the extravasation sign from grade 1 to grade 4. So now we'll turn to the patient safety program. This was about the patient safety. Now we are turning to the patient safety program. So how you should achieve this indicator, how you should achieve this zero patient error and all, by having the structured, robust patient safety program in your hospital. So this patient safety program needs to be having all the components of the safety. So how to develop this patient safety program, first of all? So you should involve your team members, nursing head, nursing quality coordinator, hospital doctors, hospital quality coordinator, quality manager, top management, clinician. You should sit together, infection control team, you should sit together, do the brainstorming and develop your patient safety program. So what is the reference for developing the patient safety program? WHO patient safety goals are the, this is the reference to develop your patient safety program. So you should develop your brainstorming session, and you should start thinking the safety of the patient from entrance to the exit, from admission to the discharge. You identify each and every process wherein patient safety is breached or it is very important. So from admission, from the transportation, from the moving, shifting, admission, giving medication, while assessing the patient, giving while performing the bedside procedure, while performing the diagnostic, while performing the operation, normal delivery, then during the what we say transit period from ICU to ward, ward to ICU, or from operation theater to ICU, at every step you should start identifying the processes wherein patient safety is very much important. So you should, while having this patient safety program, definitely you will reduce the mortality, you will reduce the infection and other adverse event in the healthcare industry. So you should start identifying the process. I'll go from reverse. So process changes is very important. Once processes change, primary and secondary drivers are there which will reduce the mortality and give you the sense of patient safety. Now we'll go to the difficulties along the way. You must be thinking that this Dr. Sushila Madam is continuously saying about the patient safety, but there are a lot of difficulties. I know this healthcare industry is not so easy. Few hospitals are trust hospital, few are academic institution, few are the corporate hospital, and few are the medical colleges and nursing colleges. So difficulties along the way. So we should, I know there is a lot of workload to the nursing staff, lack of cooperation with some medical staff, and they didn't work with everyone, for everyone. So these are the difficulties. But my dear colleague, you should work together for one common goal, and that is national, international goal for patient safety. So what are the components of patient safety you should consider in your hospital? First, medication safety. Second, surgical safety. Third, electrical safety. You must be thinking why electrical safety is very important. Because of improper warmer and all, even neonate can get burned from the warmer. So electrical safety, electrical settings are very important in patient safety. Then laboratory safety, turnaround time, critical alert, wrong sampling, wrong labeling to the component gives the laboratory safety. Then sanitation, infection control, biomedical waste disposal is also very important for patient safety. Blood safety, right component to the right patient in right quantity is the motto of the blood safety. Equipment, installation, calibration, machine maintenance all come into the equipment safety. And environmental safety, last but not the least, environmental safety is also very important. Fall risk area, then fall what we say infection prone area, some leakages, seepages in the patient room, in the operation theater, improper handling of the HIPAA, improper maintenance of the HIPAA gives you the infection to the patient. That's why environmental safety is also very important. So these are the 8 components of the patient safety. So first we'll see the employee safety. In employee safety, blood and body fluid exposures are also very much important for the employee safety. As a nurse, though we are taking care of the patient, you should use appropriate PPEs in the respective areas. For example, PPEs for chemotherapy patients are different. PPEs for negative pressure isolation rooms are different. PPEs while performing the surgery are very much different. So you should adhere to the standard precautions while taking care of all the patients. So musculoskeletal injury immunization program is very important. All the staff should get immunized with the hepatitis B. So this is very important in considering the employee safety. And health checkups, pre-employment health checkup, annual health checkup is very important for employee safety. Credential and privileging. What is meant by credentialing? Credentialing means though there are 3 BSc trained nurses pass out from the college, they are having and they have done internship in one hospital. 3 BSc nurses skills are very different. One nurse is skilled in ICU patient management. One BSc pass out and trained nurse is experienced and skilled in the operation theater patient management, and one is expert in emergency patient handling. So based on their skill, the qualification is same, based on their skill and their experience, they should get different privileges, they should get different permission to practice their skill in the healthcare industry. This is called as a privileges. Credential means your qualification and experience and registration. And privileging means practices as per the skill and as per the expertise. So this is called as a credential and privileging. This is very important in employee safety. We should ensure that right candidate is working in the right place to ensure the patient safety. This is very important. Then appropriate PPE should be used. I already have informed to you. And empowerment, nursing empowerment is very, very important. And blame-free culture is very important in healthcare industry. Now we'll turn to the environmental safety. I already told you that construction and infection control risk assessment, ICRA, infection control risk assessment. If any hospital is going for construction, renovation, you should do the ICRA activity. Google form, on the Google ICRA form is freely available. You please download it, study it. And if your hospital is going for the renovation, before the renovation, you should identify the areas will get affected because of the renovation, nearby areas, and you should start performing active surveillance and active cleaning of that area to minimize the risk. So this is called ICRA. Then you should ensure appropriate air quality in the hospital, especially in the operation theater, dialysis, endoscopy and all. So STP, ETP is very important. Biomedical waste segregation is very important. Anti-skid floor is very important. Side railings of the bed should be applied all the time. While using the reuse of water and all, you should be very careful. It should not be used for drinking. It should be used for gardening and all. And proper good illumination in the patient care area is very important considering the patient safety, environmental safety. So call bell is also very important. Fire extinguishers, fire alarm. Patient should know where is the fire alarm, where is the, how to activate the fire and all. If any construction is going on, patient should not get disturbed because of the noise, because of the sunlight, because of any dumbness and all. You should be very careful. Then call bell has to be there in the bathroom as well as near the patient bed. So in some areas, you should put patient safety devices in the hospital, like grab bar near the commode, near the bathroom to hold for the patient safety. Railings has to be there. If any slope is there in your hospital, you should have an anti-skid tile, as well as you should put some railings for the patient safety, especially for the vulnerable patient safety. Then call bell, I already have explained you. Then safety belt to the wheelchair and stretcher. This is very small things, but very important. While transferring patient from one unit to another unit, while shifting patient on the wheelchair and the stretcher, safety belt has to be there. And bilingual signage is very important. And disabled friendly toilet has to be there. At least one disabled friendly toilet has to be there in each organization. Then near the washroom, patient usually getting the fall incidences. So you should prevent patient fall by putting the anti-skid mattress, and you should have a bilingual display across the hospital on patient and family education, especially family education. All vulnerable patients should not be sent alone for the washroom, and always they should be accompanied with someone else, either from hospital staff or by the attendant, to prevent the fall. Now we'll turn to the electrical safety. In electrical safety, safety issues has to be checked. All machines, connection, loose hanging wire has to be tied properly. Then properly plug has to be there. No shortcut has to be avoided in the electrical safety, and all machines should be on the UPS. So now we'll turn to the fire safety. So fire safety is the hospital responsibility. Most in the hospital, patient should know where is the manual call point, MCP, manual call point for activating the code red. So assembly point has to be there, no smoking area has to be there, and such bilingual signboard has to be there across the hospital to get the fire exit route. So these are the very important information, and all the hospital staff, especially nurses, those who are there along with the patient 24/7, they should know how to use a fire extinguisher in the hospital for the patient safety. These are the safety codes. You should, these are the some important basic safety code, but you can have more codes also as per your hospital requirement, but these are the important and basic code. Code blue is for the medical emergency, code red for the fire, code black for the bomb threat, code pink for the child abduction, code violet for the violence of the patient, staff or visitor, code orange is for the man-made and natural disaster. In every hospital, code mitigation team has to be there, and that dedicated team should act immediately once the code get activated. So different method you can opt in activating the code. You may have a PA system, you may have a telephone address, you may have software which give mobile verbal message that code red, ICU second floor, code red, ICU second floor. Such type of verbal message can be pop up on the mobile by putting some app, etc. So there are the various ways and means by for that way you can activate the various safety code in the hospital. Now we'll go to the blood safety. In blood safety, your blood bank or your blood component blood storage unit should ensure safety in the department. So how they will ensure? Proper grouping and cross matching is very important. Test of HIV, in hepatitis, VDRL is very important before the transfusion. Proper labeling of the group, name of the patient is very important. Control of mismatch reaction. Standard operating procedure has to be there in blood storage area or blood bank. And inform the adverse reaction. If patient is getting any reaction after blood transfusion, patient should immediately report to the nurse. So what is the role of nurses in blood safety? Nurses should monitor patient within immediately. So cross verification, double verification has to be there before the transfusion. After, once the transfusion started, you should monitor patient very frequently, 15 minutes, 20 minutes or 30 minutes frequently to the patient, and ask patient in case of any reaction, please call to the nurse. So this education to the relative or patient is very important in the blood safety. And you should analyze all your blood transfusion reaction very thoroughly. Now we'll turn to the biomedical waste infection control. You must be thinking that why sanitation is very important for the patient safety. If you are putting biomedical bins near the patient bed, definitely it will give infection to the patient. So all the biomedical bins should not be near, should be near the patient bed, but it has to be covered with the lid. It has to be covered with the lid. No any bins is open. We are not expecting bins are open and like small insect and all sitting on the bin, and it is spreading infection across the hospital. So correct segregation of waste is very important. It is the moral and prime responsibility of all healthcare workers, including doctor, nurse, and technician, that segregation has to be done at the source of creation. So patient and family training on various isolation practices is also very important in infection control. For example, negative pressure isolation room is there and patient is there inside the room. And if relative would like to go to see the patient, you should give proper education to the relative that use appropriate PPEs for the negative isolation room. Don't touch to the patient. Stand 3 feet away from the patient bed and all. Such educational bilingual board you can put outside the isolation room for the relative safety or for the family safety. So restricted visitor policy has to be there for isolation patient. And community awareness. For example, COVID pandemic was there. Already 3 waves we have seen from the COVID. So community awareness poster, information you can put across the website, across the area perimeter of your hospital should be covered with the community awareness posters on the outbreak. Now we'll turn to the laboratory safety. In laboratory safety, biohazards, these are the 3 risks: biohazard, chemical hazard, and fire safety. So all the waste generated in the laboratory has to be put into the correct bin and staff should use appropriate PPE. In the laboratory, a lot of chemicals are used. Nowadays, use of the chemical has reduced as compared to previous practices, but still risk is there. So hazardous material, hazardous material safety data sheet. You should know the MSDS. MSDS means small leaflet of information. It is getting along with all the chemical, which gives information about how to handle, how to store, and how to take action in case of spillages of chemical on the body part, or if this chemical going into the eyes, what the first aid action we should take. So this is called as MSDS sheet. So all hospital, though you are nurses, you should know the material safety data sheet of the chemicals which you are using in your wards, in your patient care areas. So these chemicals has to be kept in the separate cupboard called as hazmat cupboard. Hazmat cupboard has to be away from the other material. Then fire safety, I already have explained you. In nurses, those who are using the various chemicals, you should know in case of spillages of this chemical goes into the eyes or splashes goes into the eyes, you should know where is the basin for eye wash, and you should have a facility to take shower in case chemicals spill over on the head. Then some nurses are also working in the radiation department, like radiology, MRI, CT and all. So caution board, radiation hazard signboard has to be there on all the doors. If any procedure is going on in the CT, in the X-ray, in the mammography, this red light has to be there to prevent the entry in the department. All the staff working in the radiation department should use appropriate PPEs of lead apron, thyroid shield, gonad shield and all. You should use a TLD badge while working in the radiation department. Safety in the dialysis for the patient. For example, if you are a nurse and you are working as a technician by doing any technical course in the dialysis, then safety of patient is very important along with the safety of the staff. So what are the points related to patient safety? If dialysis department is there, you should know first of all the same patient having the same dialyzer. So you should reuse, I would say, you should reuse this dialyzer minimum for 5 to 6 times. And during each, after the each use, you should make some marking on the dialyzer. And after reusing for 5 times, and after finishing the 5 times use, you should put into the correct bag for biomedical disposal. So dialyzer reusing is very important. You should take consent from the patient. And you should have an appropriate storage as per the patient UHID and name for the dialyzer. Dialyzer should not be exchanged in between the patient. Always you have to check sero status of the patient for the single use. While giving the dialysis, you should monitor patient very carefully and you should ensure that no active bleeding is there in dialysis. Care of dialysis catheter by patient at home is very important. If dialysis patient is going home and they are daycare procedure, they are coming for the dialysis, you should give proper education to the family members about the renal diet, about the care of the catheter and everything. Hand hygiene is very important. You should encourage hand hygiene in the dialysis patient, and education is very important in dialysis. Water testing, endotoxin level testing is very important in the patient safety in dialysis. If you are using RO water in dialysis, endotoxin monthly checking is very important from the hospital side to ensure the patient safety, because endotoxin is very nephrotoxic for the dialysis patient. Now we'll go to the hazmat safety. I already explained you that this is the hazmat sticker. You can put such sticker to the all chemicals wherein there is the cupboard is there for the hazmat. Hazardous material list has to be there in the hospital. All the staff using the chemical, they should know what chemical is having what reaction and how to use it, how to store it. If any staff is using the chemical, you should use heavy duty gloves. Equipment safety. All equipment, though it is ventilator, though it is monitor, though it is a radiology equipment, lab equipment, or operation theater equipment, CM and all, internal quality, operational quality, and performance quality has to be there. Quality conformance certificate has to be there from biomedical engineering department. Timely calibration and maintenance is very important for the patient safety. Building safety, structural audit, leakage, seepage should not be there. Crack to the wall, broken tiles are the source of infection in the patient care area. So no any broken tiles should be seen in the patient care area. Patient involvement is very important in patient safety. So patient for patient safety is very important concept you should practice in your hospital to improve the outcome, to improve the satisfaction. So we should respect patient right and responsibility. We should give highest importance to the patient decision. You should involve patient in decision making. You should promote, empower patient in taking the proper diet, proper medication and all. So a communication signboard has to be there in the hospital for non-verbal patients. So for the verbally non-communicating patients, such type of posters has to be there in the ICU. Those patients who are not able to talk, at least by showing the picture, they can call for nurse, they can ask for water and all. So non-verbal communication poster has to be there in the hospital. Patient and relative counseling, educational leaflet on various disease condition for nursing condition you can develop in your hospital. I'm not going into the patient right and responsibility. So patient has right to voice the safety concern. So you should take, though you are nursing department, you should take feedback from the patient about nursing services. This will be very good tool of improving the nursing quality. Patient feedback is very important for the improvement of nursing quality. So you should have a complaint box, complaint register in the hospital. You should have a hierarchy of complaint redressal. If any nurse is getting any complaint, you should address patient complaint there and there itself. If that complaint is very major and you are not able to address, you should reach to the top management. Now, we should ensure safety of patient in the transit, inside the hospital and outside the hospital. If you are moving patient from one department to another department in the hospital, you should put safety belt, you should identify correct patient is moving to the correct site. And if you are transferring patient outside the hospital for any particular test, like nuclear scan or any particular services, you are shifting patient outside the hospital, you should give transfer summary to the patient and ensure ambulance, proper ambulance arrangement, BLS or ACLS and all. And you should ensure safety of the patient. Right ambulance for right patient is very important for shifting patient to the another hospital. Then 17th September, every year, WHO is celebrating World Patient Safety Day. 17th September is the World Patient Safety Day across the globe. Everyone is celebrating this day. So you can activate your patient safety cell and you can involve patient, family, staff together, and you can have various activities in your hospital like poster competition, health talk, lectures, patient testimonial and all various activities you can conduct in your hospital to enhance the patient safety. Last topic is that documentation. You must be thinking that what is the documentation required? But SOP of patient safety is very important. So program is there, SOP is there, but who will implement this program? So patient safety team or patient safety committee has to be there in each hospital. So this patient safety team will involve quality staff, nursing staff, infection control staff, your clinical pharmacist, your pharmacist, your clinician, your surgeon, and all. They all together work for the patient safety. You should conduct patient facility round. You should monitor patient safety indicator. You should map patient safety related incident. You should maintain risk register. And you should take regular meeting, trainings, and you should improve the patient safety. So as per NABH current guideline, they are saying that each hospital should have a clinical safety officer. It could be clinician, then patient safety officer. It could be quality staff, nursing director can become a patient safety officer, and general safety officer. 3 safety officers are very important to ensure 360-degree patient safety. So in each and every department, my dear nurses, you can identify patient safety champion. So ICU patient safety champion will be different, emergency patient safety champion will be different, operation theater patient safety champion will be different. So each patient safety champion will be reporting to the patient safety officer, and patient safety officer along with the clinical safety officer is reporting to the top management to involve the 360-degree hospital staff. So implementation, training, monitoring is very important for the role of the patient safety champion. You should conduct various audit to check the implementation of patient safety goal. Then you should have a clinical safety rounds in the hospital. You should identify various risks involved in the patient safety. You should give risk rating. You should act on the risk, and you should ensure the corrective and preventive action in the hospital. So this is the constitution of patient safety. These are the common agenda points you can add into the patient safety. These are the some example, but you can take maximum points for the patient safety committee. So patient safety facility round, grand round, I would say, grand round of nursing head, quality head, management. You all together start taking the patient facility round to identify various the risk point and take appropriate action on the same. So tips for the implementation of patient safety. Leadership commitment is very important. My dear colleagues, team role is very important in patient safety. Not only nurses, not only doctor, or not only the quality staff is important for patient safety. So unless and until leadership commitment is not there in the hospital, you should not work for the patient safety. So patient safety team, patient safety committee can come together. You should document your patient safety program. You should revise this patient safety program every yearly. You should review national patient safety goal or adherence in your hospital. You should conduct various audit. You should start using various checklists. You start using indicator, incident, and involve families and patients. Very important. Involve families and patient in the patient safety. Definitely you will achieve the goal of patient safety, and your hospital will be patient-centered hospital. Your hospital will be patient-centered hospital. So branding together for patient safety is need of the hour. This is my last take-home message to you all. Thank you very much. I am concluding here. Now session is open for question and answer. If you have any question and answer, let me know. Now over to Terna team. Thank you.
Thank you very much, ma'am, for sharing your expertise on this session. Anyone has any queries?
No queries? Then I think
If you have any queries, you can put it in the chat box. Thank you very much, ma'am,
Thank
for
you.
sharing in details about patient safety various programs for ensuring patient safety, and also all the tips you have given for making our hospital patient-centered with all the patient safety measures. Thank you very much, ma'am, for your elaborate presentation. I hope all the candidates are benefited with your session. Thank you, ma'am.
Thank you. Thank you.
To proceed with the session, I invite our fourth speaker of the day, Ms. Denny Milvin, Training Director, National Healthcare Academy, Singapore. Let me introduce ma'am. Madam has completed her Masters in Medical Surgical Nursing in Critical Care Specialty. She has achieved 6 Sigma Black Belt in NHCA. She is a certified ACLS, NALS and PALS instructor. She has a clinical experience of working as an ICU in charge for 5 long years. She has served as a nurse educator and quality nurse. I welcome you, ma'am, to speak on the topic practical aspects in patient safety. Over to you, ma'am.
Thank you so much. Am I audible to all?
Yes, ma'am.
Okay. So I'm Denny Melvin and I'm a training director of NHCA. It's a great privilege to have to be taking this session for MNC CNE, and also I would really like to thank Terna Nursing College for taking such a great initiative. Getting back to the topic, before I could even start, I was attending the previous sessions and I just realized that patient safety is so important. Like Dr. Sushila ma'am has covered almost everything, and the session really emphasizes on how we need to be taking care of patients, how important patient safety is. And I realized that the NHCA courses, the content that is there is all included and directly or indirectly relates to patient safety. Like I have people coming and asking, ma'am, do you have some course related to patient safety in quality or infection? And we have got so many of our alumni and we keep training them, keep training nurse leaders so that the emphasis of patient safety is given to all and we are able to develop good nursing team. So to start with the topic, okay, I would like to share few experiences with you all. Okay, let's make it very practical and I'm sure all of you will be able to relate to it. So I'm sharing an incident with you. Recently, maybe a year back, there was an incident, a post-CABG patient. A post-CABG patient had was admitted in the hospital. She was a little disoriented. Her age would be approximately 67, 60 years. And what happened was that this patient was on restraints. After that, suddenly there were some bruises and skin peel on the hand, and the patient's relative complained, and the doctor, the intensivist, just gave a random order, please remove the restraints. Now what happened was the patient's restraints were removed and she was given boxer bandage. I'm sure you all know what is boxer bandage. And after few hours, I can say maybe like 1 or 2 hours, there was a news that this patient removed her ICD drain, the tubing. It was a great shock. The in-charge contacted, called the X-ray department and X-ray was taken. Luckily, there was no much complication. There was little pleural effusion, pleural tapping had to be done. So many problems for the patient, so much of extra expense for the procedures. Now, what went wrong? It's for all of us to think, what went wrong in this? What was the thing that could have been changed in such a scenario? Now, what happened was, when the restraint policy is there, like most of us know that we have documentation in all hospitals, we have all the forms to be filled, but it's like a tick, 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 tick. When the doctor says that stop restraint, if you are a nursing leader, you have to assess the situation. Till that day, there was no issue. Just because there was a small skin peel on the hand, was it justified to stop the restraint policy? Can somebody answer? Was it justified to remove the restraint from that patient when she was disoriented? Anyone? Exactly. You cannot. Thanks, Daisy. So thanks, Disha. Yeah, all of you agree with me. Now, what happened is, because of this problem, because of this one carelessness, I don't blame only the doctor. The nurse could have said, sir, the nurse could have said that I am there with the patient for 24 hours and it is very difficult to handle this patient. Doctor said, give 1:1 nursing care. Now tell me, when a patient is there and 1:1 nursing care, does it mean that the nurse is going to just stand in front of the patient and look at the patient and hold her hands? It's not possible. You cannot just stand and hold the patient. There's so much of work to be done. You have to mobilize the patient. You have to give physiotherapy. You have to give medications. You have to go for your breaks. It's not possible, right? So the fact is that the nurses, the leadership in nurses have to be such a way that you are able to speak for the patient. Okay. And then there was a lot of problem and all the problem got solved later. But remember, when someone says, remove the policy, stop this policy, remove this line, remove that line, as a nurse, you should be confident enough to talk to the doctor or the person concerned that this is the issue. Should we think about it? Should we focus on this? Or should we think of a better plan? Am I making clear? So this was one incident. I want to share one more incident. So there was this one patient who had just undergone a valve surgery. So you know, valve surgeries, patients are a little more weaker than other surgeries. And they have like 2 or 3 drains. You have to be mobilizing the patient. Now what happened was, there was this one tiny little nurse. Normally nurses are all tiny, below 55 kg. Poor nurses, they don't get time to eat, drink. And now the policy says that mobilization require 2 people, 3 people. Everything is mentioned in the policy. Now what this girl did, this patient had to be mobilized. Till now she used to mobilize her alone. Nobody said anything because the curtains were closed. Nobody knows about it. When she mobilized this patient, it should never happen, but unfortunately the patient had a fall. Now, she reported it to the in charge and there were a lot of problems. Patient's relative complained, all the things happened. What went wrong here? Because for the last 2 to 3 days, she was mobilizing the patient and there was no problem. She thought, let me mobilize her today alone. But the protocol in patient safety says, do not mobilize patients with lines and tubings alone. Take assistance. The situation is such that the nurse cannot take help. There is nobody around. Everybody is busy with their own work. So you understand the practical aspects. Everybody talks about filling forms. Everybody talks about making patient at the center. But there are a lot of difficulties, the practical aspects of it. So I will discuss certain points that you can keep in mind as nurse leaders, as staff nurses, so that in future you can benefit out of it. These examples that I'm sharing are in some way related to me because I was present at this moment. Okay. Going to the first slide. Okay. That is about surgical errors. There was an incident in Washington that took place. 2 patients. One patient was patient complained with brain swelling. And there was another patient with a clot. The procedure was for the patient with the clot to be removed. The clot to be removed. Now somehow, whatever documentation happened, patient on the table was not the patient who had to remove the clot. It was a patient complained with brain swelling. The procedure started. It was the wrong way. This has happened, okay, in 2018. The procedure, and you know, neurological cases, the surgeries take quite some time. You have to go through remove the scalp, then the skull. It takes hours. Neurosurgery can go up to 12 hours. The first 1 to 2 hours, nobody knows about it. Everything is clear. Marking is there. I think fortunately, both the patients by coincidence had the same site. Okay, one for swelling and one for clot. After 2 or 3 hours, after drilling the patient, they couldn't find any clot. Then they contacted the main surgeon, and then they realized the surgeon said, stop the surgery immediately. Now just imagine, procedure was done, the whole thing got complained, there were a lot of issues, and after all the issues got solved, luckily the patient with a clot did not have to go for a surgery because the clot dissolved on its own with medical management, and the patient who had swelling, they treated him finally. Now, what went wrong? Everybody knows that there is a surgical safety checklist. There is a timeout policy. In spite of all this problem happened. And who all were blamed? The anesthetist, the nurse, the ward nurse, and the OT nurse, both, because they are the ones who receive the patient and transfer the patient. And the surgeon. All were blamed, all were punished. Matlab, I can't say punished. They had to undergo some consequences for this problem. Now, I feel personally the major concern, now that it's only nurses around here, I can talk frankly to you, a nurse could have avoided this error, because when you shift the patient, you have your identifiers, the identity band, you're talking to the patient. So in any case, the error shouldn't have happened. Okay, there they kept all of them responsible. So these are some of the practical aspects that we have to keep in mind when we talk about patient safety. Okay, so like I have put one slide which talks about surgical safety checklist. Every hospital has a checklist. Now people emphasize on filling the form. People emphasize on putting a tick mark. They don't bother to see what is there and what is not there. Now, if there are 100 cases that are happening, around 95 cases, you may not even bother. It just happens normally. There's no error. You just put tick, 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 shape, tick, remove lines, tick, nose ring, remove, tick. It's a tick thing that is going on. All right. Maybe a 1 or 2 patient may have a problem. Okay, just 1 or 2. But can we be negligent for this 1 or 2 patient? We cannot. Therefore, as educators, trainers, the nursing heads should not be just training on filling the form. There should be a sensitization session. Every single nurse should be sensitized on these things. They should be told and informed. The surgical safety checklist, why? Give 2 or 3 examples. Definitely in every hospital, some or the other errors happen in the OT. It's just not disclosed. But every OT, at least once, there is an error. Without taking names, you can discuss this with the your team. This has happened. We don't want any errors in future. This is zero tolerance. I'm sure the nurses will understand when you give them a sensitization session on each topic. All right. So this is with the surgical safety and timeout. The timeout has to be done before the incision. Before you make a cut, you, the doctor, the surgeon, the nurse, the anesthetist, all scream out loudly that this is the patient and check it with the records, the ID band, and this. Definitely you shouldn't have an error. How can you have an error if the timeout is followed strictly? Now, in the Washington incident that I told you, if the doctor, the nurse and all had to check the site, the name of the patient, the ID band, obviously the ID band cannot be wrong. The timeout was not done correctly. It was just done for a tick mark. Is it clear to all of you? So remember, the timeout has to be always done before the skin incision. So that was with our first slide. Now let's move on to the second slide. That is about curbing infections. All the previous sessions spoke about the different care bundles to be followed, like your WAP bundle, COTI bundle, SSI, CLAPSI bundle. Some of you may not be familiar, but there is a HAPU bundle. HAPU bundle is for pressure ulcers. All right. All these bundles are there. But how to follow them is very, very important. Okay. Now, what you can do, I would request all the team leaders, the in charges, to appoint a patient safety officer or a patient safety nurse. You may have a patient safety officer in your hospital, all right, but don't depend on that person. In your nursing team itself, like how you have an infection control link nurse, patient safety nurse, you can rotate, you can give every nurse a chance. I've seen so many hospitals have this beautiful rotation where every department one nurse is appointed for a month. You know how is the benefit? That nurse understands the importance of patient safety. That nurse is confident to take up better roles. It helps her in her career. Okay, she can take up big roles. Also, she becomes accountable, and when every nurse does this, everyone becomes accountable. Today, if I tell you, tomorrow you can, I'm appointing you as a quality nurse. You may not be confident to take up that role, but when you work in such situations, you are confident. You can build efficient nurses who will emphasize on patient safety. Am I making it clear to all of you? So, like I have noticed, like whenever a role is given to a nurse, she is doing a staff nurse duty, and she says, somebody says you have to give from tomorrow, can you work in the infection control team on a part-time basis, maybe twice in a week? The first thing that comes in the nurse's mind, why should I work? I'm not going to be paid more. This is not my job. I'm having more headache. I'm going to take more headache. Right or wrong? This is the first response from every nurse. Do you agree with me? Come on. Do you agree with me? There's resistance at the first instance. See, thanks Hepzibah for being frank. Thanks Simran. Thanks Jordan. Thanks Beena. Thanks Daisy. I'm happy that all of you are attending this session. Thanks Sonali. Thanks Krishna. Thanks Stella. Okay, I agree and you all agree with it, right? So now after this session, I want you all to change your attitude. When you get an extra role, let them not give you an increased salary, but take it up. Take that role. You know why? Because that is given to you free of cost. And because of that, you can see yourself in the future as a leader. All right. Suppose I tell you, tomorrow you're going to be working in, I'm just taking the name of the hospital, just Terna Medical College or Hinduja Hospital as the head of nursing, and I'll give you 2 lakh salary. You would be excited to take the job, but would you be excited to take the role? You'd be like, salary, I'm happy, but the job, I'm not so confident. What will I do? How will I do? Understanding. So what you should do, grab these opportunities. You have to go behind the head of nursing and say, ma'am, I want to take up the role of infection control nurse. I want to take up the role of a patient safety officer. I want to take up the role of OT manager. I want to take up the role. I can do both the work. I'm okay to take up little stress. Understanding. This will boost your career. This will help you emphasize on these important aspects. Okay? Yeah. I see, I can get the vibes that you all are all motivated, and I'm going to see all of you as future nurse leaders, future patient safety officers. Okay. So every shift you can take one nurse as a patient safety officer. So when you resign from that organization, you can request your head to give this in your CV. That will add weightage. You will grow as a nurse. Now the third slide, which nobody spoke about. These are called alarm limits. Okay, all of you are aware that you all have cardiac monitoring system in every ICU, right? This cardiac monitor is very, very essential. If you see, many of them are not aware of how to operate it correctly. Every parameter, what all parameters are there? Heart rate, SpO2, PA pressures, respiratory rate, cardiac output monitoring for some cardiac patients. All these are there, right? And you have an upper limit and lower limit. So suppose it is for blood pressure, 120/80 is a normal systolic, diastolic. So you will put an alarm limit, 130. Okay, if the patient's BP goes above 130, it will start beeping. And you put the diastolic as 80 mm of Hg, So anything below 80, it will start beeping. Now in the night duty, nurses want to sleep. So there's nothing wrong in sleeping. If you finish your work, you can take a nap. I don't know, in India, you have a problem, you can't sleep. In abroad, every nurse has the authority and right that you can sleep for half an hour, because by nature, human brains cannot concentrate on work otherwise. So these things are there to be changed. But I don't know, if you have to follow your hospital protocol, please follow and don't listen to me, and then you will get a memo and they'll blame me for that. But yes, do not stop the alarm limits. There was an incident what happened in one of the hospitals. There was a patient whose alarm limits were shut off because the nurse was getting disturbed continuously. It was beeping and she was busy with another 3 patients. In an ICU, 2 patients is sufficient. The guidelines in NABH and JCI say 2 for 2 patients is okay, not more than that. Now this was 4 critical patients this poor nurse had to manage. Now what she did, she switched off all the alarms and kept. She took the patient's sponge. It was a patient with drains and all those things, cardiac patient. And at 6 o'clock, suddenly the patient went into BTAC, ventricular fibrillation, CPR was given to the patient, and the patient expired at 6:30 a.m. It was a shock. Okay. Then they did the RCA. What is RCA? Root cause analysis. They checked the monitor. They realized that there was so much that the patient saturation was dropping from 2 a.m. 92, 90, heart rate was 140, it became 139. Suddenly a patient cannot collapse. Obviously, it goes gradually. So then the problem occurred, and there were some issues. The nurse had to face the consequences and all those things. How could we avoid it? No matter how busy you are, do not switch off the alarms. Do not switch off the alarm. The alarms are to notify you that there is something wrong with the patient. Sometimes you don't deal with the source of the problem. There are ventilator alarms beeping, beep, beep, beep. So what does the nurse do? She goes to the alarm and silence the alarm. Why does the sound come? Why does the ventilator beep? What are the issues? Come on, somebody answer me. Why does this ventilator keep beeping? What is the reason for that beep, beep, beep? Come on, somebody just answer. All of you are aware of it. Some changes in the patient, okay. Anything else? Yeah, in the vitals, correct. It shows it is working, okay. Anything more that you can think of? Value changes. See, most of the time the ventilator beeping is because there's a block in the tube, either because of too much secretions, or the patient is biting the tube because there's a ventilatory fight, or he is alert now, he's off sedation, he's biting the tube, there's a leak in the tubing. There are a lot of changes because of which that. So if you solve that, if it's a bite in the patient's tubings, you put an OPA, oropharyngeal tube, it's enough. You will stop that. Correct. You can have displacement and all these issues, disconnected tube. So treat the source of the problem rather than switching off the alarm or silencing the alarm. Is it clear? So till now we talked about the practical aspects in surgical safety, where you have to do your timeout, where you have to count the gauze pieces before you close so that you don't have any complications. Then we spoke about infection control. Then we spoke about alarm limits. Next. Identify patients correctly, all have discussed. I'm not going into the depth of that. The medications. Yes, low battery. I'm happy that all of you are replying and you all are alert and you all are not sleeping. Good. Now about the medication safety. Already the discussions have happened about look-alike, sound-alike drugs and all. The spots, the nurses have to be explained why the high-let medicines are kept in a separate lock and key, why there is a red spot for identification and all those things. I'll say about one incident what happened. So all of you are aware of crash carts. Crash carts are very important in terms of patient safety when it comes to code blue. Now what happens in certain places, certain hospitals, the crash cart locks are not very tight, and therefore in emergency people take medicines from the crash cart for their personal patients when there's no code blue. And when this actual code blue, when you open the crash cart, something is missing. Laryngoscope is missing. Or when a pediatric code blue is happening, that cuff pressure, that the mask that is there, that is used for cuffing the patient, that is missing because the physiotherapist use that for postural drainage. And you miss suddenly, you don't have a laryngoscope or your laryngoscope is not working. These are some of the practical aspects. To check the crash cart, everybody has a tick, 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 tick. But when the procedure is happening during an intubation, only that ET tube, or not ET tube, that laryngoscope is not working. Yeah. So it's people are just doing it, just following the protocols as tick, 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 and not understanding that sometimes, many times you can just put a tick and you get escaped. But when the problem happens, you will be jacked. So I'm telling all of you, I'm sensitizing you all. If till today you have been doing this tick, tick system, make sure you do. See, there's some God watching you from above, and one day you will be caught. So don't let it be like such something that is very bad for you. So before that, if it is your responsibility, it's your accountability exactly to check the laryngoscope, please do it, because you don't know on that day if there's an emergency, the intensivist is going to use that laryngoscope. So patient safety matters here. If you're taking drugs from the crash cart in a very difficult situation, make sure you replace it. Don't just do tick mark. If you are for checking expiry of the crash cart, just because you wanted to finish your work, you just do tick, 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 no use, because expiry medications are harmful to the patient. You are not taking care of it only for audit's sake. You're taking care of it for the patient. And I'm telling you, if you have breached the policies, somehow you get caught. Somehow that expiry thing comes into the picture. And in spite of all that you've corrected, that one mistake is, see, Yogini is saying you're right, you will be caught. Understanding? So whenever there's an expiry in near expiry drugs, remove it from your department. Because in emergency, you are going to check your expiry drugs. You're just going to use it. So it's your responsibility to remove them. Okay. That was with the crash cards. The next slide, that's the 6th slide. Prevention of thromboembolism. DVT and all those prophylaxis, all those bundles are followed strictly. But as a nurse, you should be smart enough to understand. Okay, this is my patient. He's not getting shifted today. He's put on alpha bed. He's put on water bed. He is going to be in the ICU for quite some time. Immediately order for an SCD, sequential compression device. Immediately inform the doctor so that he may give some proton pump inhibitors as a GI prophylaxis, DVT prophylaxis, so that the patient is prevented from the problem occurring, from pressure ulcers. You know the patient is now having a risk for pressure ulcers, so you prevent it by giving alpha beds or Huntley's beds or all those things. You have to be alert before the problem occurs. After the problem, then doing dressing doesn't make sense. Before the problem occurs, you are vigilant to not let it happen. All right. Then it's fall prevention. I discussed about the first topic about falls. So fall prevention, Morsi fall scale, risk assessment, all these forms are there. Everybody puts a tick mark and fills it. If you have to assess the GCS scale, if yesterday the patient GCS score was 11, today the nurse might not even check the patient and just put 11. I know, because this is happening. There are many times patient is pupils dilated or constricted. They check 3 mm, 2 mm, 2.5 mm. They don't even know how to check it. They don't know that the torch is to be used. They will just copy paste and say 2 mm, 3 mm. I want you all to understand one thing, girls, you and boys, you have to check this. You have to auscultate for lung sounds. You have to auscultate for bowel gas. You have to take that initiative. Don't depend only on doctors. If you want yourself to be respected, you have to be called as an efficient nurse. If you are a nurse who's going to focus and emphasize on patient safety, you have to take care of all these things. Understanding? So the second incident that I spoke to you about, that patient who fell, when you talk about the Morsi fall risk, obviously her score may be very high. She may be at high risk. In spite of that, the nurse mobilized her on her own. She cannot be saved. everybody would blame her only, and she wouldn't be able to defend herself. Probably there was no risk for the patient and that patient fell, there could be a possibility that they could be saved. But she had to be given a memo because of utter negligence. Am I making it clear to you all? Now, there is something called as a 24-hour relative consent. If a patient is hemodynamically stable and has to be shifted to the wards. Now in wards, 1:1 nursing is not at all possible. One nurse takes care of 7 to 8 patients, okay? Nobody's charging extra, nobody's giving extra salary to a nurse. Then you have to assign a private nurse, okay? So this one patient has to be explained that now what happens is after 2 or 3 days after surgery, the patient feels a little confident. In fact, they become a little overconfident and they think that they can go to the washroom on their own. They are extremely casual about it. And many times when the patient's relative is not there in the cubicle, they go to the washroom and they have falls. Now, what has to be done in such scenario? 24-hour relative consent is signed, but then the patient relative leaves without informing the nurse. So when that patient is admitted to the ward, you have to emphasize and give a strict training to the relative that in case, even for a minute, this patient is left without a relative, we are not responsible. You explain to them 2 or 3 incidences that have happened. Patient was very confident, they fell, and in spite of explaining to them the seriousness, so now we won't be able to save you if you don't follow the rules strictly. Now the relative, if she has to go for something urgent and she explains it very clearly to the patient and still the patient disobeys the relative and the nurse, the patient is at fault. At that time, you can be saved, but otherwise, absolutely no, you cannot save yourself. So re-emphasis on training, sensitizing the patient is very, very important. Not just talking and say, don't allow your patient, don't do this, don't do that. No, you have to sensitize them that this can cause problem to the patient. Okay. The next slide, customizing hospital discharges. Now, when a patient is discharged, make sure that the patient is given proper instructions about follow-up, how to take care of the dressing. It's very pathetic. Nowadays, people don't even bother. The training is not given properly. The explanation is not given properly, and patients land up doing a lot of mistakes. We assume they will know, but they don't know. Recently, there was a surgery patient, head surgery. She had a big cut here, and she was not even explaining when you can start having bath. Just said you have to use wipes, okay, do not have bath. But when to have bath, not given any clue. So these kind of negligences can cause, and you all know, any infection for the patient within 30 days after discharge will be considered as hospital acquired infection. The hospital is going to be blamed. Therefore, the education system should be such that one dedicated nurse has to explain them correctly. Don't be ignorant about it. And patients who have arrhythmias or problems, something new has started, telemetry nursing. I don't know if you all are aware of it. Telemetry nursing in some of the hospitals, they have started it, where a dedicated telemetry nurse looks after, can track the patient's ECG monitoring. So when the patient is 24 hours, when the patient is eating, exercising, the ECG is recorded in the hospital. Wow, that's really good. And because of that, whenever there is a change, major change, the patient is notified and he can be called back to the hospital. So you can save the patient from unexplained cardiac arrest, sudden cardiac arrest. Okay. So this telemetry is very effective, and follow-ups, strict follow-ups, this will help the patient be safe even after discharge. All right. Next slide is the better teams and rapid response. I'll share an experience again with you. So there was this one patient who had to be discharged. The rule says remove your IV line just before the discharge. Now this was a TPA patient, and you know very well, for TPA patient, discharge takes more than 4 to 5 hours because of the approval and all those things, right? So now what happened? This patient, the nurses removed the IV line in the morning at 9 a.m. itself and changed his clothes and everything was ready. At 1 o'clock, he was for discharge. At 12:30, he had a VTAC. There was a code blue. Now what happened? This patient's IV was very difficult. They gave CPR and all that, and then to put the IV line, it took so much time. Can you imagine? You have to give drugs to that patient. Exactly, Reena, I understand. Patient forces you to remove the IV line. Very valid point. I'm so happy that you're attending this lecture. So when patient forces to remove the IV line, make sure to re-emphasize. Give them example, like just now how I give example, give them the example. Yes, and tell them lies. Yesterday there was a patient whose IV line was removed just 2 hours before, and there was a code blue, and he couldn't get an IV line and he expired. You have to tell this. When you tell such things and tell the relative will take the responsibility of preserving the IV line. Does it make sense? Does it make sense? That is what I said. Sensitization is very, very important. You'll have to hit them and talk to them. You have to tell them, if you don't do, you have to threaten them actually for certain things, because some patients are a little immature, even the relatives. So tackle them in that way. Okay. So that is with better team and rapid response. So what happened? This happened. Another one incident happened where the patient had to be discharged. Patient sat inside the car outside the hospital, and then he collapsed. Now what happened? The crash car took so much time to come outside the hospital. This happened in 2017, and I was there. I was in charge in one of the departments. I was there in the code blue and I ran. But crash car to get there was a time consuming. It took almost 10 minutes, my dear people. Now then they realized the NABH quality indicators, you have to have code blue bags. Then we started, code blue bags are mobilizing bags. So these bags have a defibrillator, which is your AED, your emergency drugs. You just have to get that and attach it to the patient and give the shock and medicine and everything. Then we understood the importance of a code blue bag for patient safety. So you can also apply all these in your hospitals. And the next slide is about share data for quality improvement. So the Dr. Sushila has already explained about sharing data. This sharing data is not to give fancy data like no errors. We don't have any medication errors in our hospital. We don't have any CORTI. We don't have any VAP. No, you should say when you have, because NABH doesn't say we want 0. NABH says, JCI talks about correcting them. You show that you have these errors and that you have corrected and taken corrective and preventive action. Am I making it clear to all of you? So just to brief, I wanted you to understand that the practical aspects are very, very essential. When you train, when you as nurse leaders talk to your nurses, train them, sensitize them, why you need to do. Remember this 5I technique. First question, 5I. Second question, again a why. Why the patient fell? Because only one person assisted this patient. Why only one person assisted? Because she didn't call another assistant. Why she didn't call another assistant? So when you say 5 whys, now you will come to know your problem. I hope you understood what I tried to explain in this last 45 minutes. Now, when you talk about, I work in NHCA. Okay, before this, I worked as an ICU in charge, a quality nurse. I've been a patient safety officer, so I can actually tell you these problems. And you are already aware about NHCA, National Healthcare Academy. All the sessions that are taken, this syllabus is covered in NHCA. So if you are really interested to do some course on patient safety related to quality management, patient safety related to infection control, patient safety aspects in relation to nurse leaders, you can contact me anytime. I'm sharing my number with you all, 9870-920-431. You can ask, take my number from the organizing team also. You are always free to contact me anytime. I can guide you on what patient safety aspects you can apply in your hospitals, how you can implement them, how can you rotate your nurses, how can you become nurse leaders. Don't feel ki, how should I contact ma'am? Can I disturb her? You can disturb me any time of the day because I am into this profession. Okay. And we take sessions. Our NHCA sessions are all on these patient safety aspects. Like we have diploma programs for quality, infection, hospital administration. That are so beautiful. Even Mini ma'am, who introduced the session today, she herself takes sessions for us. She has done the course from us, and they are really beneficial. And I can tell you very confidently that if you do these programs, if you attend our weekly sessions, you will definitely become a very efficient nurse leader, efficient nurse manager, efficient nurse coordinator, and what all you want to add on to your CV. All right. So I hope you've understood. Yeah, my number is 9870920431. We have some exciting offers and all for the courses which are available for a few days. Today is a special day. So those who message me soon, I will give you the best offer. Okay. So you can message me anytime on WhatsApp. Even if I don't call you or receive your call, you can always message me. Okay. Anything related to concerns related to patient safety in your hospitals, you can always contact me. Wait. I'll just message on the chat box.
Thank you, ma'am, for sharing your valuable insight on this topic. Ma'am has elaborately explained the practical aspect of patient safety. Ma'am has very elaborately explained the various practical aspects of patient safety in the hospital by explaining the clinical scenario. I hope the topic is more clearer now. Madam has also dealt with how to got infection and also the importance of alarm, which is often overlooked. Session was quite interactive, and I hope delegates are very much benefited with the session. Thank you so much. Announcement for the delegates. Kindly fill the pre-test form, and delegates, please fill the pre-test form only once. If you have filled it before, please do not fill it. Please fill your pre-test form only once. Now it's time for lunch break. We will resume after half an hour. Please note that we will continue with the second half of the conference post lunch. Let's gather back sharp at 1 p.m. Thank you.
One o'clock is 12:30.
Please join back at 1 o'clock after the lunch break. Lunch break is for half an hour. Delegates are requested to please join back at 1 p.m. post-lunch for post-lunch sessions. Thank you.
Coming, coming. Yes, Joshua. ധനി പറഞ്ഞോ സ്പീക്കറോ ലൗഡ്ലി പറഞ്ഞ ഓ എന്റെ ക്ലാസ് കഴിഞ്ഞു മമ്മി മെൽവിൻ ഇരുന്ന് കേൾക്കുന്നുണ്ടായി അച്ഛാ അത് യൂട്യൂബിലുണ്ട് ഫുൾ ടൈം കാണാനായിട്ട്
The explanation is not given properly and patients land up doing a lot of mistakes. We assume they will know, but they don't know. Recently, there was a surgery patient, head surgery. She had a big cut here, and she was not even explaining when you can start having bath. Just tell you have to use wipes, okay? Do not have bath. But when to have.
Call me today for admission. ജോഷു സിയും ടിയും വന്ന എന്തൊക്കെ സെന്ററിൽ പിന്നെ സെക്കൻഡ് വൺ വന്നു കഴിഞ്ഞാൽ
सम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यम्
Hello. Okay. Elizabeth Joseph, right? Yeah. Okay. Yeah, I have posted it, but in the description I can't do that because some errors is there. But in the comment section, I have been posting it. Yeah, from the both the accounts, Cogville and NHCA. Yeah. Yeah. Hello. ஆமா. இல்ல இந்த கான்ஃபரன்ஸ் ஆயிருந்தேன் இந்த கிளாஸ் இல்ல. സംസാരം തുടങ്ങിയാ? സാബുദാനയുടെ ഖിച്ചടിയില് തൈര് ചേർത്ത് വെക്കും അല്ലേ? എത്ര മണിക്കൂർ വെക്കണം? ആ ആ ആ ഓക്കെ.
Ladies and gentlemen, welcome back to the second half of the International Conference on Patient Safety, a step towards quality care. It's very nice to see all of you once again, and we hope you have been enjoying the conference so far. Now I invite our fifth speaker of the day, Dr. Elizabeth Joseph, Regional Nursing Head, Wockhardt Hospital, Mumbai, to speak on the topic Communication, a Key Patient Safety. Let me introduce ma'am. Ma'am has completed her graduation from SNDT University. She has completed her post-graduation from SNDT University, and also she has completed her PhD in nursing. She is a diploma holder in hospital administration from Tata Institute of Social Sciences, Mumbai. She has acquired the prestigious P.N. Berry Scholarship to UK. She is a certified NABHS assessor. She has over 30 years of experience in all the areas of nursing care and education, with 17 years in nursing administration, quality, accreditation, and patient safety. We welcome you, ma'am. Over to you, ma'am.
Good afternoon, everyone. Is my screen visible and am I audible?
Yes, ma'am. Your screen is visible and you're audible, ma'am.
Okay, thank you. So since the post-lunch session is not going to be easy, I thought let me start with some Shah Rukh Khan clipping.
Indian Exporters Conference, good evening. Hello, may I speak with Aman Mehra, please? Whom should I say is calling? Anjali? Anjali, right. Indian Exporters Conference, good evening. Hello, पापा को फोन दो. पापा? तुम्हारे पापा कोई फिल्म का देखे? ना बोलो ना. Hello, may I speak to Mr. Ral Khanna, please? Whom should I say is calling? Anjali. Certainly, Anjali.
Ma'am, video is not visible. Ma'am, can you increase the volume?
हेलो हेलो अमन मुझे कुछ सुनाई नहीं दे रहा है मुझे सब सुनाई दे रहा है तुम बोलो मैं बोल रहा हूँ मुझे तुम्हारी बहुत याद आ रही है हेलो अच्छा सुनो कल सुबह मैं समर कैंप जा रही हूँ कहाँ जा रही हो समर कैंप इस समर कैंप मैंने तुमको एक बार मना किया ना कि तुम समर कैंप नहीं जा रही हो तो नहीं जा रही हो अच्छा सुनो I'm feeling very किस तरह देखो मुझे ऐसा मजाक बिल्कुल पसंद नहीं मेरी माँ को मेरे 10 साल हो चुके हैं नो समर कैंप यू अंडरस्टैंड दैट अमन तुम चिल्ला क्यों रहे हो अरे चिल्ला क्यों रहा हूँ क्योंकि मैंने तुम्हें एक बार मना किया समर कैंप के बारे में अब सुन लो अगर तुमने समर कैंप का नाम लिया ना तो मैं घर आके तुमको थप्पड़ मारूंगा अमन तुम पागल हो गए हो अंजलि तुम्हारे पापा पागल अंजलि अंजलि I am Ral Khanna. I'm a Mehra. How you doing? मुझे लगता है वो नाम से नहीं
Okay, so now with this video clipping, I don't know if how many of you have seen my session before, but I tend to have the same slide because I thought this is a very good introduction to a topic which is very, very sensitive in a hospital. Can you imagine if a confusion like this has to happen in a hospital, which can lead to major goof-ups, which can be very devastating to the patient, to the patient's relative, to the entire hospital. This can even lead to death of the patients at times. Now, which is why IPSG, that is International Patient Safety Goals, talk about effective and the importance of communication in an organization. The purpose of International Patient Safety Goal is to promote specific improvements in patient safety. Now, to broadly tell you what the International Patient Safety Goal is all about, we have 6 IPSGs. One of them, the first one is identifying the patient correctly. The second is talking about improving effective communication, which is what I will be talking on today. The third one is improving the safety of high alert medication. The fourth is ensuring correct size, correct procedure, correct patient surgery. The fifth one is reducing the risk of healthcare associated infection. And the sixth one is talking about the harms caused because of patient fall. Now, when we are talking about importance of communication, let us first of all understand why this is important. As we all know, in a hospital setup where we have a lot of patients coming in, the patient's relatives, a lot of healthcare workers who are actually dealing with the patient, and a lot of cross communication keeps happening between patients, between the healthcare workers. Now, when we're talking about importance of communication, we need to understand why it's important and how it can ensure patient safety. The reason why it's important is, one is it helps to establish rapport with the patient. It will help to reduce errors and protects patients. It helps to save on cost, because if you are doing things correctly because of efficient communication, a lot of rework loop is avoided. It increases efficiency. It solicits crucial health information. It improves quality of care and patient outcomes. It is safe and it ensures a safe and productive workplace, promotes critical emergency responses. It promotes safe transition of care from one healthcare setting to another, and it enhances patient experience and improves patient safety. Now, when we're talking about international patient safety, there are 2 goals which they talk about. Goal 1 is identifying patients correctly. Now, let's see, how do we identify patients correctly? Usually, most of the organization have a practice where they define how to identify their patient. And the usual practice in most hospitals is to identify the patient by their full name. Like we saw in the movie, spoke about Anjali, but what is the patient's full name is something that you need to take care of. And something which is a unique hospital identifying number. Because you have a lot of names which are very common. Like when it says Sangeeta Rane, you will have at least 3-4 patients in the hospital at any given point of time with that name. So what is unique to this patient is the unique identifying number that the hospital generates. Now, when do you use this identification? Now, these 2 identifiers that I spoke about, that is mainly the patient's name and the UHID number, is used before any critical process has to happen. For example, before you give medications to your patient, before you give blood and blood products, before you are collecting any specimens for the patients or carrying out any test, any diagnostic things that is being done for the patient, and before the patient receives any treatment or any procedure is being done for the patient. Now, please remember, we cannot use the patient's bed number as the identifier, and which is what is a routine practice. No, bed number 416, yeah, bed number 21. That's not a right way of identifying the patient. So I want to reiterate the right way of identifying the patient. You can have many ways of doing it, but most organizations have a practice where they talk about identifying the patient by using the full name and a unique identification number which is given to the patient. Now, how do you do it? You ask the patient, you compare the name, you ask the patient for the full name, the patient will talk about the full name, you compare the full name, and then you verify and validate with what is written in the patient file.
Sorry to interrupt, ma'am. Ma'am, slides are not visible.
Just a minute. What was the last slide you saw?
Ma'am, it was blank. I couldn't see the slides.
Can you see the slide now?
Yes, ma'am.
Did you see this slide?
Yes, ma'am.
Yeah, okay. Now, there are certain special circumstances where you may call in for some sort of a change or a tampering, not tampering, I would say, a special process to be written down. Say, for example, if the patient is now, usually when the patient is conscious and the patient walks into the hospital, you can ask the patient his or her name and check the UHID number. But supposing you have a patient who's comatose, or for example, the third picture over here says if there are multiple accidents, patients who have come in, and there are multiple patients who have come in, and you do not know the patient's name. So say in this case where the patient is comatose and you need to identify the patient, the wristband says unknown and UHID number. If there is a newborn baby, you write it as newborn. For the newborn baby, you would write it as baby of with the mother's name and the UHID number. If there are multiple patients who have come in, there is no identification. Supposing there has been a big accident somewhere, you've got about 10 to 15 patients coming in, then we usually write as unknown 1, unknown 2, unknown 3, and so on. Okay? So these are the special circumstances where we need to focus on how do we address a patient's identification. What happens if there is failure to correctly identify the patient? This is not new to us. We all know that there are major errors and goof-ups can happen if we do not identify our patients correctly. Okay, just to name a few, there are medications errors that can happen, transfusion errors can happen, testing errors will happen, wrong person procedure, wrong patient can be wheeled in for a surgery. A lot of errors that can happen in the healthcare system if we do not streamline identifying our patients correctly and communicating how to identify our patients correctly. So we spoke about IPSG-1. How do we identify the patients? This is just to sort of recap what I was talking so long. We said we need to have certain identifiers. The two identifiers could be full name and UHID number. Some of the hospitals use birth date of the patient also. The situations are all critical situations where any investigations, medications, or tests or any treatment is carried out. And how do we do it? We could use an ID ban or an OPD card to communicate that this is the right patient. We now move on to goal 2, which talks about salient features of effective communication. So communication, as we all know, it should be timely, it should be accurate, it should be precise, and we need to keep it simple. And yes, there has to be clarity in what we communicate. Now let's look at what are the components of IPSG-2. Now here we're talking about 3 important aspects of communication, and in a hospital situation, we all know this happens. Those of us who have worked in hospitals will know that there are many a times where verbal orders or telephonic orders are given by the physicians. There are times when certain critical results, reporting of critical results happen. Like, for example, the patient's blood has been collected, the potassium, the lab people realize that the potassium level is 2 point something, and then which is very critical, and it has to be communicated to the caregivers, and finally the handover communication. So let's quickly look at each of these three. Now, verbal orders. As far as possible, when do you give a verbal order? It should be given only in an emergency or in a sterile field when the patient's file is not accessible. Who gives a verbal order? It is given by consultants, registrars, or RMO. You accept and you repeat back. Okay, who does it? It could be done by a physician, by an RN who receives it and repeats back what is done. And then it has to be transcribed by the receiver as a written order. The prescriber will verify the order, sign and date in 24 hours. So in case of a verbal order, to make it simple, we say that you do not always take verbal orders. It has to be done only in an emergency. It's a life-threatening situation when the patient has crashed and then maybe the consultant says injection atropine 0.6 milligram to be given IV stat. In this case, what happens? The person who is receiving has to repeat whatever the physician has said so that there is clarity. Who gives it? It has to be given by the consultants and the registrars. Who receives it? It is taken in by the physician or the RN who receives. And then what is very important is whatever verbal order has been given, it has to be written in the patient's record within 24 hours. Now let's look at telephonic order. Now in telephonic order, two important things to remember. As soon as you get the order, you need to write it down first and then you read back. What are the things you have to remember? That if there are numeric digits, it has to be pronounced separately. Okay, example 16, it has to be said as 16. The person on the receiving end may hear it as 60. So it's important that you spell it out separately as 16. If there are any new or unfamiliar medications, you need to spell out the name. Confirm the doses in terms of microgram or mcg or ml, not in terms of 1 bottle or 1 ampule. The recipient has to write the date, sign, signature, and also write the indication why the verbal order was given. The prescriber, whoever is giving the verbal order, must verify, sign, date, and write the orders within 24 hours for the completion of this telephonic order. So telephonic order, again, I just want to repeat, as soon as you receive the telephonic order, the person is supposed to write down the order and then read back. Now, when do you not take a verbal or a telephonic order? When the prescriber and the treatment sheet are available. It's a non-formulary medication. Chemomedicines, we do not encourage verbal or telephonic order, and no voicemail. Some of the hospitals have a good practice where they make a list of medications where verbal orders are allowed. Like, for example, this list of about 30 odd medicine. In certain hospitals, they say, okay, for these medications, we will permit verbal orders. What are the reasons for error-prone communication? Sometimes the medications are new. The person receiving the order will not be familiar with it. Accents, pronunciations, dialects can be different. There can be a lot of noise in the background. And of course, there can be issues with pronunciations. Now let's have a look at this short movie.
It's about the patient from room 175. She's complaining of pain. We want to prescribe them stronger meds like stop the pain. Okay.
Goal number 2, improve effective communication. First, the complete telephone order should be written down by the receiver. Write down. Is then read back by the receiver. Read back.
Okay, doctor, just to be sure, I will be giving tramadol 50 milligrams IV twice a day for pain scale greater than 4.
Finally, it is confirmed by the individual who gave the order. Confirm. That's correct.
There's one more video which you can see.
Speaking, I'm help you.
Hi, this is Dr. Madera. Are you the nurse taking care of patient in bed 8?
Yes, doc. Yes, doc. I'm the nurse in charge.
His blood sugar is running high. I would like to order Novolog, 5 units, QID, AC, and HS.
Okay, doc. Thank you.
Okay? Thank you. Bye-bye.
Bye-bye.
So there are two videos that I've shown you. One, the right way of doing it, and one, the wrong way of which should not have been done. So let's look at the second movie which we saw. What were some of the issues that they faced? One is the full name of the patient was not mentioned. What they spoke is the doctor called up and said, are you the patient? Are you the nurse looking after bed number 5? Then there was no mention of UHID number. Orders not said properly. Okay, there were distractions in the environment. There was music playing in the background and there was no documentation. Plus, as we said, read back was not done effectively. The doctor just rushed. She didn't even bother to see whether the nurses got access to information. There was not time given for documentation. So these were some of the things in relation to how do you communicate effectively in terms of telephonic orders and verbal orders. We now move on to reporting of critical results. Now, what is a critical or a panic value? A test result that is significantly outside the normal range and may represent life-threatening values. Now, why is it important? Because this detects life-threatening results. It reduces false positive critical alerts. It initiates prompt treatment. It will improve clinical effectiveness. It improves patient safety and enhances operational efficiency. Now, what are those departments from where or which departments can report critical values to you? It could be from the lab, it could be from nuclear medicine, radiology, the cardiac lab. So basically, any department which does diagnostic tests can report critical value. What is the process usually? So either from the lab or from the radiology department, they may call you up. Who receives it? It is either the treating doctor or the nurses on the floor who can receive it. What are you supposed to do next? As soon as a critical value is received, you need to document the date, time, name of the receiver and reporter. Once it is documented, you read back and confirm. Okay, that's important. Document first and then read back. Then you need to inform the treating doctor and carry out and document immediate action that was taken. We now move on to the last part of our effective communication, which is talking about handover. Now in hospitals as nurses, we have been handing over time and again. There are various processes, there are various ways by which people hand over from one shift to the other. Handover can happen from one department to the other, but whatever form of handover, it is important to remember that as an organization, you need to have a structured way of doing this. So what is a handover? It is a transfer of responsibility and accountability. Okay, it again, as I said, it could be from one shift to the other. The morning duty nurses coming and handing over to the evening, and the evening duty nurses handing over to night duty nurses. Or it could be from one unit to the other. Say, for example, from the emergency department, the nurse is moving the patient up to the floor. So there's handing over happening at that stage. From the floor, the patient has become critical. The patient moves into the ICU. There's handing over again. So whenever there is transition of care, a handover happens. It can happen between healthcare practitioners. It can happen between different levels of care in the hospital. It can happen from inpatient units to diagnostic or other treatment department, and it can happen between staff and patient families. What are the salient features of handover? It has to be standardized and there should be defined critical content. Otherwise, what can happen? Each nurse or each department can hand over the way they think is correct. Some units, some nurses may just hand over the vital signs and say patient is vitally stable. Some may hand over just the vital signs and the medication. Some may hand over vital signs, medication, and maybe something which is salient. So it is very important for hospital administrators to have a defined and a standardized way of handing over. You need to have structured tools, forms, or methods, involvement of healthcare personnel, and data from adverse events needs to be tracked. There are various tools which are available. For example, the SBAR, IPAS, SBAR, Vitals. You can adopt anything which is comfortable to your organization. Now here is one video showing how a good handover needs to happen.
Hi Lisa, I've got bed 14 today. Is she your patient? Yeah, do you want to go do Kindred? Sure. Hello, Mrs. Livingston. Hi. This is Jackie. She's going to take over from me this afternoon. So is it okay if we come in and do handover? Yes, thank you. Is this a family member of yours? Yeah, it's my sister Sarah. Are you happy for us to include Sarah in the handover? Yeah. How are you feeling today? Mrs. Livingston, do you mind if I check your ID band? Okay. So we have Tiffany Livingston 010101. Are you happy for me to call you Tiffany or would you prefer Mrs. Livingston? Tiffany would be nice, thanks. Yeah, no. Yeah.
So Tiffany came in, she had a melanoma in 2000 and she's had an excision of that lesion in 2000 and breakdown. She's got past history of arthritis and she's a current smoker. Tiffany's for Merkel's. Yeah. She's on BD obs and a daily VSL. We had a fall yesterday.
Now, how did you have your fall yesterday? My legs gave way and my leg. Was that when you were trying to climb out of the bed? No, it was while I was walking.
Those are some pain relief next to you. So she had it this morning. Basically, it's just a PRN. Means she can have it whenever she requires. She just needs to use that call bell and we'll get on top of it. Did I have that before?
Is the pain increasing when you're moving around? Yeah, it does. Okay. It might be a good idea then. You might need to get up, go to the toilet. Okay, Tiffany, that concludes our handover. Is there anything you'd like to add? Not at this moment. So Sarah? No, I think you've been very helpful. Thanks. If you have any other questions, don't hesitate to ask. I'll be back with the mayor to check on you, but if you need me sooner, press the call button. If you need to go to the toilet at all, not cheap enough, let me know. I'll meet you. Thank you, Sarah. Thank you.
Okay, so this was talking about safe handing over. How do we hand over our patients safely? And some of the salient features of this handover was the incoming nurse and the nurse who was leaving the duty. Both of them have gone to the patient's bedside. They have greeted the patient's bedside and they've spoken to the patient. There is a brief introduction which happens, telling the patient that I'll be the one who will be taking care of you. Patient is a part of the entire handing over process, okay, which is very good because patient feels involved in the care. There's a brief history which is being given. They talk about medications. There was a critical event which happened where she said the patient had a fall. So the incoming nurse does a little bit probing about the fall. And then they finally finish the handover in front of the patient, where the incoming nurse talks about the fact that she's available for help. So this is about communication and how important communication is in the hospital. We spoke about how we communicate by making sure that the patient's identification is taken care of, where we said we could have two identifiers, which is a patient's name and the UHID number. We also looked at other ways of communicating effectively. What are some of the critical communications which take place in the hospital? And we looked at three important critical information, which is the verbal and telephonic orders. We looked at handover communication, and we also looked at the details of how the third one was, how do you hand over critical lab values or critical communications to critical values about the patient in the hospital. So with that, I end the session. If there's any questions, I would be happy to take it up. Hello.
Yes, ma'am. Hello. Yes, ma'am. Hello. Yes, ma'am. Thank you, ma'am, for sharing your valuable insights with us. Sorry. Since this was a post-lunch session, it was very thoughtful of you, ma'am, to start a session with a movie clip. Madam has emphasized on purposes of internal safety, importance of communication in hospital, and errors committed. Session was very much informative and was very much helpful. Thank you, ma'am.
Thank you so much.
We are privileged to have with us Dr. Pawan Mittal, Business Director, National Healthcare Academy, Singapore. Thank you, sir, for your unmatched assistance and cooperation for organizing this conference. Your contribution is really appreciated. I request, sir, to throw light on how to crack interviews for the healthcare management job. Let me introduce sir. Sir has completed his MBBS from Government Medical College, Nagpur, after which he did his MBA from KG Somya Institute of Management. Sir has completed Master Black Belt Lean Six Sigma NHCA Singapore. Sir has completed Fellow Psychology Counseling and Mind Coach NHCA Singapore. Presently, Sir is working with NHCA Singapore as CEO and Program Director. Sir has worked as a behavioral psychologist. Sir is a founder in RSV Healthcare. Sir was working with Pfizer Company as a country portfolio manager. I welcome you, sir. Over to you, sir.
Thank you, ma'am. Good evening, everyone, and good evening to those who are watching live on the stream. Have you noticed why a lion is the king of the jungle? So this will be completely interactive session. This one, 45 minutes next, you will love it. So if you are free, not with the patient, so to avoid any patient safety issues, so interact. So you can write in the chat on the YouTube as well as here. What do you think? Why do you think that lion is the king of the jungle? It's not fastest. Cheetah is the fastest. Lion is not the strongest. Elephant is the strongest. Lion is not the tallest. It's giraffe. Right? It's not the highest predator. But what makes it the king of the jungle? There are other animals which are intelligent. Confidence, yeah, that's a good answer. The attitude. Lion thinks, I am the king of jungle. I have the right to be the king of jungle. That's why lion is the king of jungle. Similarly, have you noticed in your hospital, in your own department, there are some people who are younger to you. How many of you have this scenario? That in your department or in your hospital, there are some people who have less experience, but they are getting higher salary. There are some people who have less experience, but they are at a higher position. There are some people who are probably less qualified, less experienced than you, but they are working in a middle management, top management level. How many of you can write in the chat rather than raising hands, because there is a limit to raise the hands. Good. So many participants are replying on the chat. Wow, that's great. So I'm also watching the YouTube live stream. That's good. What do you think? What is the difference between them? What you have done for last 10 years, 20 years, right? That is one thing, right? There is another component. If you want to go from your present role as a nurse, as a clinician, to management job, where you get higher salary, you get a fixed job duty, you get a status, you get a work-life balance, there you need to do certain things. Number one is you need to invest in yourself. You need to prepare yourself. You need to do some courses, certification, infection control management, quality control management, Six Sigma. And another is you need to apply. And when you apply for the interview, those 10 minutes of the interview will decide whether you are in or out. So it doesn't matter if you have 20 years of experience. Even if you have 1 year of experience, that is okay. Today, I will give you a demo. Saring, today I will give you a demo of the interviews, which will be the good interviews. When someone asks you, okay, you don't have experience of infection control nurse, why should we take you? Right? So there are people who have 10 years of clinical experience, 20 years of clinical experience, but they are not fit for managerial role. But there are some who are very smart. Within 1 year, within 6 months, they are working into managerial role. What is the difference? They are talking the correct thing during interview. And that is what we train you in our programs. Especially in MH in international business, we tell our students, when you go for any interview, you talk to your mentors. You talk to us. We will tell you what should you talk during the interview. And that is the reason for highest success rate for our students in the interviews. So what are the common questions you have encountered during your interviews? Write in the chat, please. Tell me about yourself. That seems the starting question, right? What are the other questions you encountered and you didn't find answer? Like there is an education gap, there is a work gap. You took a maternity break, you took a career break, or you took some break because of some reason, because you were fired from the job. How do you handle that scenario? Right? So you want to know this answer? So keep replying on the chat. How much experience do you have? Okay, what is your dream? Very good. You should know yourself, right? So today we will do all these demos. So this most of the questions and the answers, even for if you are applying for a clinical role, go to NHCA website. On the in their contacts and testimonial, you will find the career guide. There is a page, career guide. On that, you will find questions and answers for almost all the jobs. Either you are going as a critical care nurse, OT nurse, or you are applying for a staff nurse, in charge nurse, team manager, nurse manager. All those positions, what are the common questions asked and what are the suitable answers? If you are applying for management role, what are the questions you will expect and how to answer that? So start with one of the common questions which we have. First, we'll see what should you not talk during the interview. Many of the people I have seen, what they do is when they get a call from HR, the first question they will ask is, ma'am, what is the salary? You're not selected. She has a pre-decided salary and she is going to give you more than your present salary. But you should ask question, what is a job? What is a job role? What is a description? And you should use this opportunity of the first call to pitch yourself, right? To make that HR manager realize that on the call itself, you are a good candidate, right? So when she calls you, she will typically, a call will be like, this is HR and this is you. Okay. So HR person is calling you. Her name is, for example, Soumya ma'am. Okay. So Soumya ma'am is calling you and you are answering the phone. So she will say, hi, this is Soumya from HR manager from this hospital. So you will say, hi Soumya ma'am, I'm this. You will take your name. I'm Pawan Mittal and I'm very interested to work with your team and I'm interested to work in your hospital. I have heard about your hospital and I have done this is courses, this is programs, and I have this much of experience and I'm very interested to get opportunity and work in your hospital. And this is my dream job, what you're calling me for. She will like you because this HR manager is calling 100 other students, 100 other candidates, possibly 1,000 candidates, right? So you have to stand out on that phone call. So she will note down your number and she will keep your resume aside and she will invite you for the interview. Right? Try this. It's very simple. Okay. So the first phone call is not about you taking her interview. You should not start taking interview of HR manager, asking what is your salary, ma'am? What is the position? No, you start your interview, your pitch in the first call. There are some second mistake. What many nurses they do is that they're applying for management role or they're applying for in charge position or a nurse coordinator or team manager position. And they will talk at length about their clinical experience. Not required. You say that in a short that, or there are some people who talk just all the things they can do in the clinical, right? All the techniques. Instead of that, you should talk. You should say in the one line that I have 10 years of experience of clinical, as well as I'm a good team manager. I'm a natural leader. I have done management programs from NHCA and I have learned the different management tools, how to manage people, how to manage my work, how to get the work done, and how to put controls. There are various management tools and control tools. So I know that. That's what you should talk. You should not talk of clinical in management interviews. Obviously, you will talk clinical in a clinical interview. There are some people who are MSc and they think that after doing MSc, they will get a management role. No. You get a management role if you are suitable. There might be a GNM, there might be a BSc who has done some course in management and she is far more suitable because this 10 minutes of the interview, what she's talking is far more important than what you have done. Or when you're going for some interview, have some relevant qualifications. So invest in yourself something and make sure you have those qualifications with you, right? And you have that knowledge, read the books, go in the interview and demonstrate that you are a candidate with a positive attitude. You like to help people, you like to learn, and you want to contribute to the hospital. You are not there just to take salary and go. Hospital doesn't want to pay you salary if you are not bringing the revenue. They are looking for the benefit. They are looking for the outcome from you, right? So give them that outcome, right? So demonstrate the positive attitude. How many of you think that you have failed in your life multiple times or few times and risen back? Reply in the chat. Please reply in the chat rather than raising hand. Right? Failed in life and rose back. Multiple times, Trupti Gowde, you are hired. Call me. Take my number from someone and call me. I will take you in my team. So I like those people, right? Show it. If an opportunity comes in interview, if there is something negative point, convert it to your positive point. Okay. All the hospitals, all the big organizations, MNC, HR people, they don't want to hire you because you have been successful. Someone who has always been successful doesn't know how to rise back, right? If someone who has always been successful, if it falls, if fails, doesn't know how to come back. But if you are a candidate who has failed few times or multiple times and risen back, good, you know how to bounce back. So if your team member does a mistake, if you do a mistake, if hospital does a mistake, if there is a terrible issue, you know how to come out of it. You are a good manager. You will get a higher salary, you will get a higher position, and you are more suitable candidate. Personally, I would hire a person who has failed multiple times and risen back, rather than someone who has always been successful. And this philosophy goes with most of the top management positions. Very good. So someone failed and got positive. Very good. The job which you're applying for, identify what is the position about, what is the expectation, what is the salary range, right? Salary range nowadays you can check from naukri.com, in which hospital, how much they are paying, for what position, what they are paying, okay? And be realistic. When you go for some interview, be realistic, right? And one more mistake people do is they emphasize on 10 years experience, 20 years experience, doesn't matter, right? There are people who become CEO of big companies at 35 years of age. There are people who are in the middle management in your own hospital who are 25 years of age. Your nursing superintendent might be younger than you, and you are still a nurse manager, or you are still a staff nurse at the age of 60 years. Someone might be at a retirement age and still clinical nurse or maximum in charge. And someone might be 35, 40 years of age and nursing superintendent or chief nursing officer or medical director or nursing director, right? So the number of years of experience is not what matters. What matters is what have you achieved through those experiences? What have you learned? What have you done for the hospital as a value addition? That is far more important. So always highlight what value addition you can bring. Either you fail or you succeed. Either you have education gap, career gap, what value addition you can bring to the hospital. That is far more important. Another mistake some people do while going for a management interviews, they do not have proper certification. They do not know what the management tool is. Some people, they do some certification from local academy where they just watch some live videos. Okay. At NHCA, we do not have live, they watch recorded videos, some local academy. At NHCA, we have all the live sessions and we repeat the sessions. There is no recording because live you will interact more. You can learn better, right? So you will learn all the proper management tools and you should revise the book before you go for the interview and you should talk in that language. Okay, if you are going for infection control management role, so what are the things you will talk? You should talk of some of the infection audit tools. We should talk of the infection rate, how to reduce, what are the steps, isolation practices, transmission precautions, standard precautions, all those things you should talk and demonstrate during the interview. And that opportunity, some interviewer may not give you. You have to find that opportunity, and you have to show that you have knowledge, you have passions, and you want this job, and you will do best in this job. You have to demonstrate that at every opportunity. The interview is for 10 minutes. Within those 10 minutes, you have to do that. How many of you have a career break in their jobs? In the past or the present? Now, when you see your resume, there was some career break or there is presently career break for whatever reason. Either you got fired or you left the job because of some mismatch in thoughts, or you had a fight with someone, or you had to leave because of family reasons or further education, or you were doing something, right? So many people have it, and it is not to be ashamed of. Number one thing, as a psychologist, I'm telling you, remove that from your mind. That gap is not in your resume. That gap is not in your life. That gap is in your mind. Okay. Everyone is going to have gap. You are a human being. If you are a woman, you will go for a maternity break, and that is not negative for you. That's a positive thing what you have done. So remove your all the barriers. So that barrier, that gap is here. Number one, you remove it from here. And when you, and if you had to leave some job because of some undesired circumstances, it's okay. It's life. Things happen. What should not happen is you should not criticize your previous company, or you should not bring up that bad or undesirable circumstances during the interview. You can say that there was some mismatch, or there was some, I had some family reasons, or I had something else. Okay, you can say that, right? So sometimes you have a gap, and then when you are fresh going for, you have a gap of 1 year, 2 years because you were fired, okay, or you were on a break because of your own reason. And when you go for the interview, the number one barrier is you. You have to fight with yourself. Okay. So convince yourself. Don't be, it is not to be ashamed of. There is nothing wrong in having some gap. You say, there is another option. You can say, I decided to take a break for a few months for my personal growth. And during that time, I did certain courses. Okay. So filling that gap with some of the courses is a very good idea. Right. Another is, you can say that if you are not a mother, you cannot say maternity leave. Okay. Do not make an excuse of health reasons, because the next question HR will ask is, okay, bring your medical documents, and you will not be able to come back. So do not give false reasons. Right. Another reason, you can say that because you have to shift your city, or because you had some family emergency or needed to take care of someone, or there can be another way to turn it around. How the managers think, top manager. If you're going for an interview with a top manager, okay, I tell you one trick. If you were fired from your previous job, or you had to leave under undesirable circumstances, you say it. Okay, you had to, don't say use the word fired. You say that you had to leave the previous job under some undesirable circumstances, but you learned. You learned certain things from that, and what are the things you have learned, right? Or you say, you put it that though it was not my mistake, but the circumstances became like that I had to leave, and I respectfully left. So now HR manager is very tricky. She will ask you a question. Okay, is there someone to blame? Do you blame someone, or was someone bad with you? Do not start gossiping there, right? So that's a trick question. So you say, it's better not to bring other person into the picture. I would like to take the responsibility of what happened, and I have learned from that experience. Though it was not my mistake, or it was not purely my mistake, right? But circumstances became like that I had to leave. And since then, I have been searching for the job. And during my break, I invested my time and energy for reading further and educating myself for this course. Sir, I have read about your organization. I have gone through your LinkedIn profile and I have researched about this. And sir, I'm looking for this job, or ma'am, I'm looking for this job. Right? So not because you need it. So the other person is not going to give you that job because you need it. Okay, don't start begging there, right? So what you will say is that I'm really interested, and my interest is proved because I have invested my time, energy, and resources, and I have put efforts to study and do these programs, right? This to prepare myself for this role. And if you give me this opportunity, I assure you, I will do my best. You say this. This is a conversion call. So there was a failure. You demonstrated that you were fired, but you do not have grudges or grants, and you are not talking anything wrong about the previous organization or previous your team member. And you utilize this time to prepare yourself for the next role, and you're keen to learn more and put value to the hospital. Hired. Okay. Hired. Most likely the other person who's taking your interview might have the similar experience. Right? So when you stand today, if you are in the career break, everyone, if you are in your career break because of whatever reason you have, okay, and you look forward, you may not see the dots, you may not see the stars ahead, okay, but I assure you, when you walk 5 years ahead, when you go 10 years ahead and look back, how beautiful life you have created, how beautiful career you have created, you will be able to connect the dots, right? People say connect the dots. You cannot connect the dots in the future. You have to connect the dots in the past. Probably you got fired from your previous job because life wanted you to prepare yourself for a better opportunity. Life wanted to test you, and that has prepared you for a better opportunity, right? Keep that mindset. Remove fear, right? Be bold. What is going to happen? At the max, you are going to get rejected. It's okay. Already you don't have a job, right? Go have fun. At least try to make a network. When you go for the interview, your objective should be at least that interviewer will remember you. Keep that objective. Okay. I'm going today not for the interview. I'm going today not for the job. I don't need a job. Okay. I'm already without job. Doesn't matter. Even if I fail, I have nothing to lose. But if I succeed, I will get the job. And I will tell my story after 5 years to everyone that it was good that I got fired from the previous job. It was good I took a maternity break. It was good I took the break because of certain reasons. Right? It was good that something happened in the past that made me prepare for this. Right? Okay. And when you go in the interview, don't go for the interview. Don't call it an interview. Call it a discussion. I'm coming there for the discussion. I will meet you. I will interact with you. I will make you my friend. I will network with you. Keep that objective. So if the interviewer is able to remember you, there are 100 candidates who have undergone interview for last 7 days, 10 days, right? But if she can remember you, if she can remember your story because of your failures, because of your truthfulness, because of your positive attitude towards life, right? She will remember you, and most likely she will hire you. Even if you are not the most suitable candidate in the list, right? Because she is also a human being. The interviewer is also a human being, right? So you are touching her heart, right? Make a story. Today, there is exercise for every one of you. Take a paper, take a pen. 4 minutes exercise we will do. That will change your life. I will give you the pitch. You talk during next interview and it will bring you a conversion. Take a paper and pen. If you don't have paper, pen, because you are completely digital, then take your mobile and you can write in notes or WhatsApp to someone. Okay, but this is your life story you are going to write. Okay, start writing your story, right? Create a passionate story about yourself, right? Why you are passionate about you. If you're not passionate about yourself, why the interviewer is going to be passionate about you, and why they should hire you, right? You have to be passionate about yourself. Okay, create a passionate story, right? Start with your name. your qualification, number of years of experience, and start talking your failure points and how you overcame that failure. Don't cry. Okay. So the failure, how you overcame the hurdle. There was a hurdle. You could not do your education because of lack of finances. You had to settle for nursing, though you wanted to become a doctor because you scored 1 mark less and you didn't have money to pay for higher education. That's why you did this. Okay. But you did this. It's okay. There is future life to do it. Okay. There actually nurses earn more than doctors. Do you know that? In most of the countries, including India, nurses earn more than doctors, at least initially. Right? Okay. So the post-test link, and please settle down, post-test link will be shared after this session only. Okay. And those who complete the post-test link and there is a feedback form after the link, they will only be able to generate the certificate. So please relax. So write your story. Okay. Next 3 minutes, write your story. Who you are, right? What are your skills? So your skills are not, you can do IV line and all. No. Your strengths are, those are skills. Okay. The strengths, sorry. So your strengths. So your strengths are, you can bounce back from the failure. You can surmount hurdles. You had financial trouble. You overcame it and did your education. You come from an orthodox family, conservative family, but you are working alone in another city completely. You convince your parents. You didn't have resources or money to become, to do your post-graduation, but you arranged that, did it. You earned your own money and invested for your education. That's the biggest thing to do, right? Some of you probably have arranged money for the marriage of your siblings. That is the selling point during interview. In interview, don't start crying, but this is your strength. You gathered all your resources, money for your education, for your sibling education, for siblings' marriage, your marriage, right? Whatever you have come to this place today, you have come on your own. That itself is a strength. This is called strength, right? So putting IV line and resuscitating a patient, these are skills. Strengths are what you can do. Other strength will be, I'm a good team leader. I'm a good team player, right? I follow instructions given by my superiors. I'm able to convince people why they should do certain things. I know management tools. I know management techniques. I know infection audit tools. I know quality control tools. These are your strengths. We should talk. Now, when a question comes, tell me about yourself. So these are the points you should talk during that interview. Start with your name. Take complete name, like you will say your name and the short title. So everyone write in the chart, what is your short title? So I will help you with that. You write your name and your qualification and number of years of experience. So this will be 3-line statement. Your name, your qualification, either GNM, BSc or BSc, MSc or MBA. Or if you have done some courses from NHCA, you will write the name of that course. And the third, you will write total number of years of experience in clinical and management. This becomes your title. So even when you prepare your resume, after your name, you should write this your title. Okay, short title, so that immediately your summary is visible. So sometimes some people write summary, I want to work in the organization which enhances my skills and challenges. Oh, no, no one cares for that. No one reads that. Not required, right? People are interested in you, your title, the real thing. Okay, probably the HR person also has the same statement in her resume also. She is not going to read it. It's boring. So what they are interested in, are you interesting? Okay, so the title has to be, even if you write a title, that itself is a good, interesting resume, because 1000 resumes, no one had the title, but you are writing a title, right? So write a short title, okay? And then you will talk your name, short title, and then you start with the sequence. When did you did your 12th, which year, graduation or diploma, which year, master's, which year, if you have done some infection control, quality control, Six Sigma, hospital administration courses, which year you did and from where you did. Okay, and if you did from NHCA Singapore, so most likely the interviewer or your hiring manager is already our alumni. So most of our students are working in top and middle management positions. So that is a positive point already. Then you talk of relevant experience. You can talk of summarize the experience that you have a 10 years of experience in the clinical as well as management, or 10 years of experience in clinical, assisting in NABH or audit, or managing the team, or assisting your in charge, or assisting a nurse manager for her role. So all those things, and what value addition you have done to the organization, right? So this is a tough question, value addition, and you should be able to tell. So what are the value additions you will be doing? One is assisting in NABH audit, complying with for your department for NABH, training your team members for simple things, hand hygiene and all those things. Whatever topics you are comfortable, you can take that. So training, if you say that you have trained people continuously, it demonstrates, wow, you're good. People learn from you, right? And what are you looking for in the new job? So in that you should, in introduction only itself, without asking, you will say that you are looking for a job, not a theoretical, okay? It has to be very clear cut. You should not say you are looking for a job which challenges your opportunities and all. No, no one interested. You should directly say you are looking for a job in managerial role, preferably infection control management, quality control management, or nurse management role. Or if you're applying for an in-charge role or a clinical role, you should say that whatever interview you are going, say this statement, right? So if you're going for a management role, don't say you're looking for a critical care nurse role, okay? So say that you're looking for that particular profile, right? And you should talk about your aspiration, and this aspiration should be linked with the job you are applying today. So that aspiration can be, I want to grow in the managerial position. Don't talk of the designation, okay? Designation are just titles, okay? Talk of, I want to grow in the managerial position, or say after getting experience of working with your hospital, Bridge County Hospital, for 2 years, 1 year, I want to go to Gulf country, or I want to go to Canada for my further work, right? So talk of number of years also, 1 year, 2 year. Otherwise, the hiring manager thinks, okay, you will come for 3 months and 6 months and then go. So make sure that you are clarifying that part, that you want to have a long-term relation with this present hospital, right? And that is one of the reasons they should hire you, right? So look for that, or if you are a person who wants to continue your job in this new hospital, you say that I want to grow in this hospital and continue working in this hospital only, and I will explore further opportunities after getting this particular job in this hospital only, right? So that itself is a selling point for you. That itself is the answer why we should hire you, right? So all these things you're talking about, tell me about yourself, and take around 3 to 5 minutes to answer these questions. And if you have written your story today, right? If you are not written, write it down. Before you sleep today, take 15 minutes, meditate, think of your life. What have been ups and downs? What skills you used? What strength you demonstrated to come out of your downs? That is your strength. And make a passionate story about yourself. Teach that, modify every day. You modify your story. The story you should remember by heart. And when you go for an interview, talk of that story. That story should ring the bell, click the heart, touch the heart of the interviewer. You should demonstrate that you are passionate, you are lively, you are cheerful, you want to learn, you want to help people learn, and you want to contribute value to the hospital. You demonstrate that. You have only 10 minutes. For the interview, you have 10 minutes. It doesn't matter how bad your experience was, how good your experience was, how good you have been in your previous job. Doesn't matter. What matters is 10 minutes of interview. What you talk, what you demonstrate. And that is what we exactly teach our students. Every class, we cover some of the other component that when you go for a particular interview, these are the things you should talk. And for MHA and hospital administration management students, we tell them before you go for a higher position interview, you talk to us. We will give you demo interview. We will tell you what should you talk. We'll help you prepare. And that is one of the success, one of the reason that most of the students of NHCA, they are working in middle and top management roles in most of the hospitals and NGOs in India, Gulf country, Canada, Ireland, and Europe. Okay, we'll cover two more questions. If you do not have a particular experience, this is a very common question, right? So you may not have experience in you may not have experience in a particular management role, but you had experience in the clinical side, right? So you say that while working in the clinical, I always had my interest in the infection control role. So I was assisting my infection control nurse, and you should be assisting actually, assisting my infection control nurse for her audit and managing infection control rates in my own department. I used to conduct regular training for hand hygiene, disposal of waste, disposal of syringes, occupational health hazards, and all those topics for my team members. Right? Even if it was for 3 to 5 members, it's good. That's a good start. And I invested my energy and resources to do a particular program, okay, to do infection control prevention management course, and that is what shows my interest and my commitment to this role. And sir, you please, or ma'am, you please give me this opportunity. I will make sure I will do best. I will learn, and I'm very fast learner. So when you have a gap, you have to say that I'm a very fast learner. I learn, and I have been doing some part of this role in my previous job, and now this will be a full-fledged role. I will do it. The next question probably HR manager will ask us is a tricky question. She want to hire you, but she's testing you. She will ask you, okay, but there are experienced candidates. Why should I hire you? So you say, you don't lose your balance. You say that, you take a pause, okay? Take a deep breath. And you say, now at some point of time, for any job, I will need a first break. And that's what happened with you also, ma'am. You didn't become HR director, right? You had previous experience and you got HR director role first day as a first opportunity. Even when you were HR manager junior, you didn't have any experience, ma'am. You got that role because you had that potential. You had that interest. Same interest I have. Same potential I have. Like someone has given you this opportunity, you give me this opportunity. And equally, I will demonstrate that I'm best for this role. You like the answer? How many of you like the answer? If you liked it, type yes in the chat. Good. There are around 1500 audience in the YouTube and around 500 audience in Zoom. Right? Even if 100 of you are able to use what you are learning today during this, and apply this during your next interview and get selected, that's a success. But I believe that each one of you has the potential. Okay. Be confident, be bold. Don't be afraid of anyone. The other person is not going to kill you. The other person is probably also afraid of you. Right? At the max, what will happen? You will not get the opportunity, but you were never going for the job. You are going for making friends. Don't go and say to HR manager, hi ma'am, I have come to make friend. Okay. But at the end of the interview, that person should remember your name. My name is Dr. Pawan Mittal. And I'm going to repeat my name every time. Same way, you repeat your name every time. Start with your name. In the middle, take your name. Ma'am, you will find Dr. Pawan Mittal as the best candidate for this job. End with your name. HR manager will remember you. And most likely she will call you. Either for this job or the next opportunity. Most likely this job. So, touch the heart. It's not about experience. It's not about your gap. Okay, it's about here. The line is here, right? After today's session, how many of you believe that you will be bold enough to go and talk in the interview next time? If you type in the chat, you will be able to do that. If you are afraid to type in the chat, yeah. Very good. Very good. Melvin Francis, you will write your story. Wow, that's great. Write your story. Revise it. Modify your story every day. Every day, modify your story. Sleep with it, dream with it, wake up with your story. Right? Keep modifying, keep modifying. And that assimilate. Keep it in your heart. And when the opportunity comes, talk. That has to be interview. Right? Even if there are 4 5 interviewers, 4, if they select you, if they like your story, they will take you. Okay. So people get selected. Some people get selected because they are liked, right? Not because of their education or something. Maybe someone had more education than others, right? I come from clinical background, shifted to marketing and now management background, right? So I can tell you, I come from a salary of 15,000 per month to 1.5 crores in a year. So that's the salary range I have surpassed. And that too, I think it's less. Okay. So that person can tell you how to do it. Number 1 is remove the gap here, remove the barrier here. Okay. Less experienced person, doesn't matter. Failure, wow, that's good. If you're a failure, that's good. Right? What I'm looking for is, what can you do with your failures? What are your learnings? And how you can apply for your new job? What is the value addition you will bring? Give me one answer, maybe 1 page, 1 line, 1 word. What is the value addition you will bring to my organization? When I hire you, this is the question every CEO, every HR director is asking. Every nursing director is asking. If I hire you as a nurse manager, what value addition you will bring? Right? If a hospital hires a doctor, they know that the doctor is going to bring the patient. But you as a manager, what are you going to bring? Right? We have 6 minutes. Now we ask the question, how to ask for salary? Right? How many of you are afraid of asking salary? Or you say, ma'am, whatever you think appropriate. Or probably you are completely crazy and you say double the salary. Right? So how many of you belong to the 3 categories? So after today, that will change. Reply please in the chat. Either you, please reply in the chat rather than raising hands. Either you say that you can decide whatever salary you want to give, or you say you don't know or you don't want salary, you are okay with anything, or you say that double salary. How many of you? Stop. Okay. From today onwards, you will ask. But before asking, you will do a research. This particular hospital, whatever you give, okay, I will give you 5,000. Come. Okay. That is the answer they give in their own mind and they laugh at you. Okay. And you're already rejected. So someone who is a demanding, someone who is a negotiator, that's the person they will select. Okay. If you negotiate realistically, if you demand realistically, wow, that's a good candidate. I will have that candidate. Because if you are demanding with me, if you are negotiating with me, it means you have demand and negotiating skills which you can use with your team members. Like it? You like it, right? So be realistic, be straightforward. You say that this is a range I'm looking for. Okay, and identify what is the range this hospital or this position can afford, right? So just because you have 20 years of experience, it doesn't mean you are going to get the 1 lakh salary. Okay, there are people who have 1 year of experience and they get 1 lakh salary, right? Because they apply for that particular job or they have prepared themselves for that, right? Don't be afraid to ask for an upper range, but it has to be within the range of the hospital, right? So 35 to 40% from my previous salary. Okay, so the hospitals have the standard, not bad answer. Trupti, it's still okay answer. But the question is, HR manager wants is, why we should pay you this salary, right? And next question is, as a HR manager, do I have a budget to pay you for that? Do I have that money? Has my hospital approved this much salary? And whether you qualify for that. So you have to prove. Even if you ask 1 lakh salary, 50,000 salary, doesn't matter. You have to justify. The point is, HR manager wants to justify to the superiors or to self why she should pay you this salary. Can you justify yourself? Can you justify? So today, second exercise, write down on a paper why you should pay me this salary. You can ask anything, crazy, go crazy, 100% increment, 50% increment, 10% increment, 0 increment, negative salary, 50% decrement, right? Or absolutely crazy salary. But you write answer on a paper in your diary with pen today, why this salary should be given to you. If you agree with your own answer, okay, you are in. Most probably, if you can convince yourself, you can convince the other person. Right? Another calculation I will tell you. How the salary is decided. So salary is decided on the value addition. We have 2-3 minutes. We'll finish in time. Salary is decided by, no one cares for dedication. There are very lazy people, those who work there are some smart people. Those who work for 2 hours, 3 hours, 5 hours, and they bring value to the organization. Okay. A nurse is working for 10 hours, a doctor is working for 2 hours, but the 2 hours doctor is taking more salary. A clinical nurse is working for 10 hours, 12 hours, shift duty, rotation duty, but a managerial nurse is working for fixed duty, 9 hours, and she's taking more salary. What is the value addition you are bringing? That's a question. Okay, so I tell you, in a hospital, the profit is brought. Who brings the profit to the hospital? Who brings the profit? Who brings the money to the hospital? Doctor. Doctor brings the patients, right? Doctor is the profit center. Nurse, managers, HR, marketing, everyone is the cost center. Doctors are bringing patients. They have their own targets. If they do not meet their target, they are fired. Most of the corporate hospitals work like that. And everyone is a cost center, right? So now, if you have done 6 Sigma Green Belt, right? One of the programs which we have, if you have done 6 Sigma Yellow Belt, it means your knowledge and tools to save $10,000 for the organization. if you have green belt, it means you have knowledge and tools to save $50,000, means around 35 lakhs rupees for the organization in a year. If you are black belt, if you have done our training of black belt, it means you have knowledge and tools, Six Sigma black belt. You have knowledge and tools which you will apply for the hospital, and you will bring a revenue of or cost or increase the profit of the hospital by $100,000, which becomes around 70 lakh rupees in a year. Correct? So you have learned those techniques. You will apply there, and you will do the quality compliance protocol and increase the profit of the hospital by applying those techniques. So $10,000, $50,000, and $100,000. Correct? If you are a Six Sigma green belt and you can bring the value addition of or cost saving of or profit of 35 lakh rupees in a year for the hospital, hospital will be ready to pay you 10 lakh rupees as a salary in a year. Why? Because you are bringing 3 times the profit. Right? Now, there is another candidate who is a Six Sigma black belt. The Six Sigma black belt candidate knows tools, techniques, management tools, principles to bring the profit to the hospital upwards of $100,000, means 70 lakh rupees. If this candidate asks 10 lakh rupees as a salary, and management, the CEO or the HR director will think, okay, she can bring me 70 lakh rupees to the hospital, and she is asking for 10 lakh salary, and this, so value addition is 7 times, 700%. This is the best candidate. So I will prefer a Six Sigma black belt. If you have done a Six Sigma green belt, so around 30 to 35 lakh rupees you can bring. So 300 times ROI. So while a hospital is paying you 10 lakhs and you bring 30 lakhs, that becomes an ROI of 300%. And that's how the salary is calculated. Now you understood how the calculation of salary works in the hospital or any organization. What value addition you can bring? If you're getting a salary of 1 lakh, you have to bring a value addition of 5 lakhs. In our company, in most of the pharmaceutical companies, value addition is 100 times. Okay. So if you get a salary of 1 CR, you have to bring the profit of 100 crores in a year. That's how the calculation works. Right? After today's session, how many of you think that your lion is awakened now? Please type yes if your lion is awakened. Right. And speak. Take your name. Everyone, 30 seconds exercise. Do with me. Take your name. My lion is awakened. I am Pawan Mittal and my lion is awakened. Do it. Write in the chat. If you write in the chat, your lion will listen to you more and will awaken more. Repeat after me. Your name, my lion is awakened now. I am bold. I can do anything. And when you get a job, inform us. Thank you, everyone. Enjoyed. Lot of interactions, lot of chats on YouTube as well as here. And thank you for the highest participants, around 1600 participants on YouTube channel and around 500 on Zoom this session. Thank you. The success of our session is the participants. Thank you, everyone. Have a great time.
Thank you very much, sir. So there was a question from the delegate.
Yes, please.
How to overcome fear during interviews?
Today I have told you a very strong technique to overcome the fear during interview. Okay. Don't go for the interview. Go for a meeting. Go for a discussion. Go for making a friend. When you go for asking a job, oh my God, will I get selected? Oh my God, what will happen if I don't know the answer? Oh my God, what if I get failed? Okay. No, that is the reason for fear. Interview is the reason for fear. No, say yourself. Today I am going to meet a person. Her name is Soumya ma'am. and I'm going to make her friend. Even if I don't get a job, actually, it doesn't matter because I have applied multiple places. And even at least I will make her a friend. I will network. I will develop a professional friend wherein if she needs me in future, I will help her. If I need her in future, she will help me. Go with that mindset of making a friend. Go with the mindset of not interview, discussion. Go with objective of meeting someone, understanding, interacting. Go for an interaction. In our company, when someone comes for interview, we do not say come for interview. We say come for the discussion. We'll come for the meeting. And most of our hires, what we have done is when we travel to different hospitals and we like someone, okay, this nurse manager is good or this nurse educator is good, we say, okay, you are hired. We just ask 2-3 questions. The questions we ask is, okay, what is your dream job? If that is a match, next question, what is your expected salary? Third question, when will you join? And that's what most of our team members we have hired. You take Anishma, who is in London presently, Dini Melvin, who started as assistant general manager 6 years back for India, and now she is one of the board of directors. Within 3 years, she became our board of directors. Right? So I hired Dini like a 5 minutes interaction. Same with everyone else. Right? So the interview is wrong word. So the correct word should be interaction, the discussion, and in your mindset, you go with that. Those who are looking to work with our team, so you can visit the website and somehow the others, you will get the number. And in NSC, we have a policy that every student, irrespective of the course, you get the number of one of the director level person plus instructor plus relation manager. So after you enroll, you are able to reach me anytime and every time, obviously during working hours. And those who are looking for a job, you will find the number from somewhere or other. If you are looking for something, you will find it. You have to be. Thank you, everyone.
Thank you, sir. So there was another question.
Yes, please.
This is Vidya Lakshmi. She is asking, if I don't know the answers during interview, how should I manage?
That is an interesting question, and most common thing happens. You are a human being. It is going to happen that you do not know answer to some question. Some question may be very theoretical, like where is particular monument located? Okay, what is the value of sodium in your body, normal value? You say that if some question like that comes, what is the normal value of sodium? Obviously, many of you know that. But if question comes, this particular values I have not memorized, because every time I see the lab report, there is a patient value and the reference value, and I see from that only. So the interviewer will like you. Okay, you are given a very practical solution. You don't need to memorize everything. Okay, and if there is some question which you should be knowing the answer, then for that you say, I'm not sure of this answer, so I will need to work on that. I will work on that. Don't say I will get back to you. You are not going an opportunity to get back. Wow, seriously, you are a manager that you will come and get back to that interviewer. So say very politely that I do not know. I'm not sure about the answer. So I will need to work on this. I will read more on this topic. You say this, right? Another way is what you can do is very trick. Okay, use this trick very carefully. Okay. Another tricky thing is you can do. While we are discussing, I will think on this answer and will reply in few minutes or reply in 10 minutes. So what you have done is you have diverted the topic. You have posted this question after 10 minutes. You are assured that your interview is going to long for 10 minutes. That's good. And you are up for next question. And you are not admitted that you did not know the answer also. Tricky? How many of you like this idea? And most likely after 10 minutes, interviewer will forget what was the question. If you like this idea, write in the chat on the YouTube as well as Zoom. Don't use it with your nursing superintendent because she is smarter than you. Okay. So you can use this when you're going for a management job, but you know the answer, or that question is a more of a general or aptitude question, not a technical question. If technical question you do not know answer, it is better to say, I will need to read on this. I'm not sure of the answer. I will need to read on this. Or if it is some very theoretical question, then you say that this thing I refer the book when I need. This is something which I don't memorize. I memorize something which is practically useful. Any other question? So I like the audience. Today audience is awesome. Very interactive. Yes, next question, please.
So that's all the questions.
Okay. Those who want to, I'm sending one link on the Zoom. Those who, we have a storytelling session every Sunday, 9 to 10. Okay. And those who wish to attend those storytelling, those stories are derived moral stories, different psychologists and NGO owners, which are our alumni of NHCA Singapore. They from India, and they conduct these storytelling sessions. So every Sunday, 9 to 10. 6 stories, 10 minutes each story. Mostly in English. So you and your children will learn, benefit from these stories. Also, we are starting from 10 to 10:30 or 10 to 11. We will start, or maybe a Friday, we will start how to clear the management interviews or how to clear the interview. Right? There we will give you demos. So this is typically for our students, but Terna College is our one of the closest, is going to be our international training center. So we will allow you, all today's participants, to attend that. So I'm sharing this link with you. Those who will attend the storytelling sessions will get to know further details for interview questions, sessions on interview questions. So I'm sharing one link for you to. Two links I'm sharing. One is, number one, you click on the channel and subscribe. You will get the regular alerts. Yeah, you like the idea? Wow. So right now, everyone click on this channel and subscribe. And click on this channel and subscribe. The second channel which I'm sharing is purely managed by NHCA students and alumni. We NHCA people do not manage the second channel. The second channel is managed by NHCA students and alumni. You have not seen any organization like that, right? And this second channel, Cogwheel Power is the name of the channel. They do the storytelling, art workshops, all those crazy things they do to help you and your children learn new things, learn moral. So the project name is Art Story. What is the project name? It's a copyright. Art for Fun, Story to Learn. That's the name of the project. Art for Fun and Story to Learn. So this is our trademark project. We have trademarked that word so that our students can use it. And our students run that project. So different art workshops and storytelling workshops. So if you subscribe to this channel, you will be able to assess that. And from that particular channel, you will also be able to assess management questions. Plus, there is one more bonus I'm giving you, everyone. One link for any interview. You want to go for any interview, right? And you don't know what is the answer to questions, don't worry. Any interview, all answers are here on the second page or this page, right? Either you go for a nurse, staff nurse, in charge, critical care, management role, all the difficult questions, technical questions, as well as aptitude questions, all are there in this link. So join that channel to enjoy more. And if you, how many of you are interested for storytelling sessions and art workshops? You can save this link in your mobile. Sunday 9 to 10. Sunday 9 to 10. 6 stories, 10 minutes each story. As of now, we are working on stories. We are going to start art workshop like this. This all we crazy things we do. right? This painting and some craft and pebbles and all, everything. We do all those things, crazy things. And sometimes I also send to my students art kit. And those who are most favorite, like Sering is quality manager from Ganga Prem Hospice Hospital. So such people, they get painting as a gift from me. So many of the students and some of the college directors, hospital directors, they get such paintings from me. And some of the paintings are books covers also. Yes, I will send it. Yeah, Sering is so happy now that her name has come for the painting. She has always been seeing others are getting it. So I will share with Soma ma'am. Soma ma'am will share with you the link for Sunday sessions, and you will just love it. Okay. And also make sure you subscribe to the channel. Thank you.
Thank you very much, sir, for your interactive and interested session. I think this is the most interested session for all the delegates and participants.
Thank you.
Especially the do's and don'ts while attending interviews. I believe we have lots of participants who have taken career breaks for whom this session is definitely beneficial. You have encouraged and boosted the confidence of all the participants, but I will say, sir, you have stressed all the HRs, including me, with this session.
Thank you. The session is good because the participants are awesome. So
Excellent interactive session, sir. And I hope all the delegates and budding nurses will have a benefit from this session. Thank you very much, sir.
Thank you. Dr. Pawan Mittal here from NHCA Singapore. Thank you, everyone.
May I now invite the last speaker of the day, Dr. Shubhangi Jadhav Madam, Nursing Head, MGM Hospital, Parel, to shed light on evidence-based practices on patient safety. Let me introduce Madam.
मुझे ऐसे लग रहा है हमारे स्टूडेंट के लिए रखना चाहिए.
Madam has completed her graduation and post-graduation in nursing, in CVTS nursing, and also PhD in nursing. Madam has more than 20 years of experience of working in the clinical side as well as nursing education. Madam has assumed various roles like examiner, research guide, clinical auditor, resource person, and patient safety assessor under WHO. She has attended various workshops and seminars. She has worked as a speaker in several CNE programs. Also, Madam has various publications in national and international journals to her credit. We welcome you, ma'am. Over to you, ma'am. Shubhangi, madam. Shubhangi, madam, can you listen? Can you hear this? Ma'am, please unmute yourself.
Now, is it okay? Are you?
Yes, ma'am.
Yeah, okay, the speaker one. Okay. Yeah. Yes, ma'am, I'll be present. Yeah. Good afternoon, one and all. Actually, I would like to thank you at the onset. Thank you to Soumya and Pratibha Jadhav, madam, for giving me this opportunity to share about the evidences based evidence-based practice in patient safety today at this platform. The previous session really I also enjoyed. It was very nice listening to Dr. Pawan Mittal. But I hope it's just a kidding that every nurse here presenting over here, they may go for discussion here and there, and there will be the issues. Issues may be faced by certain nurse managers or the nurse administrators. Just for a kidding, I'm just kidding. So let's start. Evidence-based practice in patient safety. In recent year, there is a lot of importance is given for the patient safety because what happened? Just WHO had simply not laid down these patient safety goals. Because WHO thought that there should be a patient safety goals, everyone should implement and practice. No, there were lot of errors were being analyzed through the research. With the extensive research, it was found that there are a lot of errors that is happening in healthcare systems by the healthcare professionals. So based on that, patient safety was being given importance, and this is the trending because we are giving care to our patient. It is our prior duty to maintain their safety because we are dealing with the human lives. We are dealing with the human lives, and we are the professionals, professional nurses. We need to take care of all these things. A small mistake can lead to cancel your practicing licensure because nowadays people have become very aware about their legal, they're very much aware about their legal, so many of legal things, and they are the healthcare consumers, so they know their rights. So this is being, I really congratulate to Terna Nursing College because this is the need of the hour. So this conference, the theme was very nice. Patient safety, which is actually need of the hour, and everyone should work very exclusively on this to safeguard our patients. I feel like this should be inculcated in our nursing syllabus also. This has to be given importance in our nursing syllabus. So let's start with this. We know that healthcare environment is very complex situations. There are a lot of things. There are technical problems are there. There are manpower shortages are there. There are a lot of expectations are there. We need to do a multitasker. We have to multitask at a time. So that is what error tend to happen, and there is a chances of unanticipated outcomes. The work environment in which nurses provide care to patients can determine the quality and safety of the patient care. So work healthcare environment has got very much important. It has to be so much valued so that the nurses will give care in such a environment with a high pride and with a high morals, and the patient safety will be maintained. Now we have seen in the first whole lot of, we are talking about most of the in these stations, what are the evidences, like what are the practices there that is came out through the extensive research to the solutions of the healthcare problems which the healthcare professionals were suffering, and with the extensive research, the solution came. So what are those? The evidences which we can implement in our own setting. The first we can discuss about the patient's identifier. Since the morning, you all are listening about the identifier, so many things that there has to be a two identifier, and different setting has got different kinds of identifier they are utilizing. Like in our setting, they said first name, last name, that is the identifier. In some of the other countries, they have got their NHS number is there with the first name, last name, date of birth, address, or NHS file number. Depend on the setting, there has to be a two identifier. That is must. We must identify our patient correct. So what will happen? There will be, if you don't identify your patient correctly, you will collect the blood of both the patients, and it will cause increase in the healthcare cost. So identifying the correct patient, there are a lot of research study which is telling us that there are a lot of errors, this diagnosis, going wrong drug, wrong treatment, because the patients were not identified correctly. So there will be a duplicative testing and increased cost, healthcare cost. Research indicates that between 10 to 15% of health insurance denial are due to incorrect patient identification number. So many times people face these financial consequences because they are being denied to medical insurances. More recently, say this has happened in 2019, not even 2-3 years. The Joint Commission Sentinel event statistics indicate 37 patient safety events out of 436 Sentinel events have occurred due to patient identification errors in the second quarter of 2019, including surgical or invasive procedures, event involving the wrong patient, wrong procedure, and wrong surgery site. This is happening. So ultimately, the patient is suffering. So what are the practices? What are the research evidences that is implemented in various settings? There are a lot of evidences are there. As we know, there are ID bands are there. Even I have asked so many hospitals, there are different color codes are there for these bands. Even for vulnerable patients, there are different bands are there. The colors are different, especially in old age patients or the children. There is a different color of band. So ID band is there. Then there are universal patient identifier, that is UPI. Very commonly it is used in various developing countries. UPIs is there, where everything is there in the central system about the patient's health, the data and other data is everything is there. But there may be some risk for the patient's personal information may get shared. Then there are patient ID card. One of the hospital I have seen, as the patient comes to the OPD, immediately the photo is being taken and patient's ID card is being made so that the next time that patient can refer that ID card. Then there are referential data matching software, because the patient's information is there in the system. So there can be from multiple sources, you can identify your patient correctly, that this is the correct patients, because same name, same patients are there. Then there are algorithm approaches there to identify your patients correct, like first name, last name, gender, date of birth, and social security number. These are the various things that is being used. Then radio frequency ID is there. Then most authentic is the biometric authentication methods are there, where there is a fingerprints are there, retinal scan is there, iris scan, speaker is there, their facial scan is there, hand and finger geometry is there. Then there is vein also, vein geometry is there. Then DNA also and typing is there, and of course the gate. These are the various biometric authentication methods are various places it is being used to identify your patient correctly. Now, the next part is effective communication. Effective health, we can call it as a effective health communication. That is very important. Effective health communication is very much important, so that the message is being reached to the right person at the right time, and at the right things are being happening. So there are a lot of tools are there for effective communication. Communication assessment guide, that is CAG, Agency for Healthcare Research Quality. They have done it to help you identify the members of your organization who are effective at delivering the disclosure communications. Sometimes what happens, the healthcare workers and the patients there keep on communicating on certain matter. So it may get prolonged. So out of that communication, there are chances of something wrong may go and some wrong information may be shared, or something wrong may happen. You know, in India, you have seen so many, because of some of the other words, the relatives get so much angry and they attack the healthcare workers and the hospitals. So this happens. So this is the tool where you can actually identify who's actually good at communicate to disclosure communication. So something they will share and there will be an immediate disclosure. I have seen one of the hospital in UK, what they do, if there is any kind of a medication error, one incident that was there was a major error was there. What they do, they keep an open communication system. Like they sit with the patient's relatives, and there they talk with open communication, and they do a disclosure of the things. Traditional approach that I was mentioning, when unexpected harm occurs, often follows a deny and defend strategy, providing limited information to patients and family is avoiding the admission of fault. So it may happen. So that is what communication is very important. A short communication, effective communication, what we can say. There are a little bit evidences about this ineffective communication. Ineffective team communication is the root cause for the nearly 66% of medical errors. That was found out in the last 10 years. Joint Commission reviewed 936 sentinel events and determined 744 were caused by the miscommunication. So miscommunication, it is all interrelated, interconnected. If you do miscommunication, there are chances of medication error may happen. There are different kinds of error may happen. So those are the interconnected errors. Effective communication between the nurse and the client during the drug administration has been demonstrated to reduce medication errors. You know, nowadays our patients are very, very smart. If you tell them something, definitely they are going to help you. No, sister, this is not my medicine at 4 o'clock. Sister, I have to take this medicine at 4 o'clock. They may help you. So that is what I meant to say. This effective communication is proved through the research that during the medication administration can save the nurses and it can help to reduce the medication errors. There are miscommunication. One of the example I would like to share here, that protester in the United Kingdom attacked cell towers based on the myth that 5G technology caused COVID-19. Causing property damage and risking injuries to themselves, bystanders, and law enforcement officers. So there are chances of miscommunication. Here, what happens? You know, we healthcare workers, we like to communicate about, you know, the good things. We like to immediately the things like spread like anything. You know, the holiday is declared, immediately the news spread. But some good thing related to patient, some new changes, or some new rule related to patient care, this transfers very slowly. I don't know why. There's a very slow communication about this. I don't know it is everyone's experience, but I have experienced it. Then now we can move about the medication errors. We are discussing about the evidence-based practices in the patient safety. So what are the evidences are there currently? What are the practices so that those practices we can implement in our setting to safeguard our patients? Like the FDA received, these are the numbers, just a number, these are the numbers. Why I am telling the statistical numbers, we should have some scare in our mind while doing the delivering the nursing care, so that we will have some scare. So the number scares us. You know what happens? We may contribute in these numbers. So that is what we can prevent ourselves from making the errors. The FDA receives more than 1 lakh reports every year that are associated with medication errors. 10% of hospital patients will be subject to medication error. 2019 study. Almost 1 in 5 medication doses given during hospital stays are given in error. Now you may think that, no, we are doing everything right. No, nothing happened. We never make a mistakes. What the research data says. About 530,000 injuries happen every year in outpatient clinics because of medication errors. Every year, 7,000 to 9,000 Americans die as a result of medication error. We think that they are very developed countries. But see the numbers. If it is not, this number is there, what we can imagine for ourselves. It may not be, it may be less or it may be more, but we don't know. We are very poor at statistics. Medication errors cause at least 1 death every day in US. It's a WHO study. The global cost of medication error is almost 1% of the total global health expenditure. Again, this is the study by WHO. One of the study which is done, why these medication errors happen by the nurses. It was done on around 298 nurses. What they found, what are the factors which contribute to the medication errors? So those are the factors, like factors such as lack of adequate training. What we think that we are trained already. Why should take again and again training? But no, my dear friends, we are connected with the healthcare or the emergency services. We need to update ourselves. We need to keep on training through lifelong. We need to keep learning and go through the extensive training all the time. Inadequate work experience. Because of that, there are chances. This is one of the factors which can cause the medication error, inadequate work experience. Interruption during the medication administration. Very commonly, we nurses are very much fond of workplace, because what happens, we are exhausted with all the frustrations, and where we express all this frustration with our colleagues, with our friends, more than the colleagues, we call them as a friends. So we tend to discuss everything, what happens for the yesterday's whole day, what we ate in the lunch and dinner, and what we did with what was the dialogue among the family members. We keep on discussing. But my dear friends, please don't discuss this during the medication administration. So there are very strict policies about during the medication administrations. Like there are double check, individual double check is there. Then there are two professionals double checks are there. I think since morning you must have heard about it. In some of the hospital, it may not be practiced, but you can practice with a mutual basis. I will check your patient, you will check my patients, so that it will help to safeguard not only you, but your patients also. Then unavailability of guidelines. Guidelines are very important. So because of that, it's administrative fault. Night duty shift were significant predictors of medication administration. These are the various errors. Some of the hospital, they strictly, remember that photo we used to go in the doctor's clinic and a nurse's photo with a shh, keep silence like that. So that kind of attitude has to be maintained during the medication administration. You keep that silence board, do not disturb board during the medication administration. Even especially during the IV, there has to be a multiple checks when you do for a IV infusion to the patients. Another study that was done, a study was conducted to assess the impact of implementing barcode medication. Everyone goes to the malls. There are barcode system is there, and for it may be used for the patients also. Patients wristband also, it may be used to identify the patients. So this is the barcode technology on the rate of medication administration error in inpatient setting, and concluded that the errors were decreased by 43.5% and resulted in the 55.4% decrease in actual patient harm events. This was help. So technology is helping us, but we simultaneously we need to be very alert. Sometimes technology may fail. So that is very important. Nowadays in India also, some of the hospitals, they are planning in abroad, UK and all, which I have seen that they have their drug dispenser. For that particular dose, the medicine comes only for that particular dose. So there is very much we are ensure that the patients, the medication administration safety is being maintained. Now there are various tools are there, safe medication administration tools are there. There are a lot of checklists are there, a lot of tools are there, particularly in particular drugs when you are administering a particular sections or department of the hospitals. There are a lot of tools are available. Research has got extensive material, like it is a sea. We just have to take some few drops for ourselves, for our safety, our patient safety. So barcoded medication administration system, that is medication safety, self-assessment for antithrombotic therapy are there, then oncology, then IV push medication, all these tools are there which will safeguard you, which you can utilize. You can find it on the internet. There are assessment for perioperative setting, all different types of computerized provider order entry are there. There are even some of the hospitals, they are paperless. They are paperless nowadays. In Mumbai only I have seen one hospital, they have a tab. The tab only the medication prescription is there, and tab only they enter everything about the patients. They don't have paper. And especially for the those patients like third party Mediclaim and all, if the only needed that time, they are giving the printout to those patients. Otherwise, it is a paperless. It is in the patient's tab is there where all the patient's information, the prescription is there, and you can just sign over there. So that kind of things are coming in India also. We are improving. For medication safety, there are especially high alert drugs, very important. In high alert drugs, you remember in ICU, I remember we used to prepare 3 of syringe pumps, like noradrenaline, dopamine, dobutamine, glucose, all the drips are going on. We have to prepare all the syringes. But nowadays it is so easy for the nurses. So many labels are available. You can put the labels on this, specifically. Even there are different color coded syringes are available where you can put a high alert. You can put a label on it, high alert medication, and which drug is going on, when it was started, how much is the dose. So that all you have to enter. Then there are safety cabinets are there where the drugs can be kept safely. And very important, there has to be a strict, stringent policy about these drugs, and there has to be protocols. The safety cabinets, only access has to be the authorized person will have the access for those cabinets, so that it is being not misused, and we will not be harming to our patients. So these are the high alert medication program performance audit tool. You can audit those, you can use those tools from the internet to audit. See, like if these are the high alert drug, you can see there are different color coded syringes are there for different drugs. What happens sometimes, do you remember we used to use syringes to measure the syrup, especially in the pediatric wards. So if in case if you're filling the syrup, someone calls you, sister, just come here, there's an emergency patient came, and by simultaneously there are other syringes prepared for injections also. There are chances the oral medication directly going to the patient's IV bolus. So these are the things are there. So like this caps are warning caps are there. That is shrink safe ID bands are there, so that it gives you that warning. It gives you that this medication has a high alert medication. I have to use it safely. I remember some of the in IV, you know, sometimes doctor tell us that this patient's IV going on, sister, IV going on. Please add 10 cc KCl to this IV full point. Sometimes we tend to directly syringe, you take into the syringe 10 cc KCl and you directly push into the IV bolus. IV pint. What happens? There are chances that this medication directly go into the patient's IV bolus, and patient can go into the heart attack, cardiac arrest. So we need to take all the precautions. You know, high alert medication drugs, which is displayed there. So you keep on reading every day. All the nurses must be thorough about all the high alert drugs, so that anytime any drug from that list is being prescribed to the patients, you may go and confirm multiple times. Hello? क्या हुआ समय? It's there. Is it okay? See, I've shared. हाँ? एक मिनट, शेयर किया था मैंने, पहले दिख रहा था? Can you see now? Yes. I'm very sorry. So these are the high alert drugs that the list is being displayed everywhere. So every nurse must see those drugs, and anytime if any of the drug is prescribed to your patients, you must get alert yourself. This is a high alert drug, and what precautions I have to take. I have to double check. I have to confirm with doctor 2-3 times with my seniors. Though they get irritated, though it is confusing, no problem. Please be behind that and confirm again and again. I told you that there are different color codes of syringes are there. So nowadays it is very easy when you are preparing multiple drugs like dopamine, dobutamine. So it will keep you like, no, so many times we have to keep on changing the syringes off. So that is easy. It will be remind you that this is the drug which I am going to change now. So there will not be any confusion. Now about the surgical safety checklist. Safe surgery saves lives. There are a lot of incidents about the surgery also. There is a wrong surgery sites, and that also WHO has released a surgical safety checklist, which is a 19-item tool created by WHO in association with the Harvard School of Public Health. What they do in the operation theater with that list, they keep on announcing, they speak loudly about everything. That is called as the time sign in, time out, and sign out. I think it is the session is being done in the previous sessions. So this is about the timeout. You tell about everything that patient before starting the actual surgery, patient's name, surname, and date of birth. the surgical and invasive pressure. So the patient is also getting aware that what is they're going to do with me, and patient is familiar about the team that is going to operate in the operation theater, will be assisting in the surgery. The procedure to be performed, all this, the timeout, and there is a, it is also called as a briefing, a timeout and debriefing also it is called as. Say in operation theater also we can use such kind of stickers like caution, face mask is required, wash your hands. It gives some kind of alert. It gives you some kind of alert. You remember everywhere that there are hand washing posters are being placed, which gives us reminders for the some other things also, for the someone tend to forget. Being human being, we tend to forget. So this will give reminder us that we have to take precautions. Don't shake your hands. All this kind of stickers you can put. Then there are there are different kind of bundles are available, care bundles, like surgical site infection prevention bundles are also available, which will safeguard our patient for the surgical safety. For this surgical safety checklist, a systematic review was done. The WHO surgical safety checklist positively impacts the things. It was explicitly designed to address the thematic analysis. What they did, what they found out that this surgical safety checklist that is designed for what purpose? It has got a very high impact in the healthcare setting. Again, one comparative study was done in a high income country and a low income country like UK and Africa. They have done to check the impact of surgical safety checklist. But irrespective of the settings, this surgical safety can be used optimally. That is, it has likely to be optimized regardless of the setting. That is, the research study has proved that. Then again, another study was done in the, say, WHO has released the surgical safety. Whether you are using or no, we don't know. So again, WHO, we used to talk that share ko hamesha sawa share hota hai, like that. WHO has got some giving something to check that. It also has given some tools, like a study was done whether to determine if the operation theater staff can discriminate between the good and poor quality of checklist. See, checklist de diya. So you people are speaking or whether it is properly implemented or no. Again, there has got a audit tools are there that is called as a WHO bars, where you can actually audit using this tool whether the surgical safety checklist can be utilized or implemented in a good quality or in a poor quality manner. So what they found that in that study that it can reliably discriminate between the good and poor quality checklist. This audit tool, you can do audit on your own. The next we can talk about the fall risk assessment tool for prevention of fall. There are a lot of tools are available nowadays. So many hospitals, they are using various kind of tools. Research tools are used to assess the risk of fall for your patient. There are scoring system. It is very easy to use. Once you read it, you can understand how to score it, how to total it, which gives you a low score, moderate score, or the patient who are very high risk at fall, so that you can make a lot of changes, you can keep alert, and you can make a lot of changes in the patient's environment, a lot of safety equipments, instruments you can utilize for your patients. So these are the various tools like Stratify, Estimate Fall Risk Assessment. You get ample amount of research tools to assess the fall of what risk your patient is for the fall. John Hopkins Fall Risk Assessment tool is there. So many are there, especially geriatric also, that is risk assessment, screening and management tools are available. These are the various, this is the fall tips, like fall interventions, like communication to resistant fall. These are the scales are there, which you tell what are the patients suffering from. If the patient is receiving some kind of a medication, so tend to fall, patient is on IV line, what you can do, how you can assist the patient in the toilet, or in the commode, then walker can be utilized, 1 person or 2 person help is being required, or patient needs a bed rest, so that falls can be prevented. So a lot of tools are there. See, if the patient's wipe, you remember in our hospital, especially during the cleaning and mopping going on, a lot of people come and go and come and out. So that is there. So in that case, we can use such kind of a boards, caution, wet floor is there, so that we can help to prevent the falls. So these are the various devices that is being used in various settings so that we can help the patient in the prevention of fall. So many restricted devices. Even patient going on a wheelchair, they're while walking up, while just sitting or standing up, their patient tend to fall. So there are good devices are there which can prevent the patient from fall. So there are additional devices that we can modify in the patient's environment. What you can do, install a grab bar so that patient can help and can get up with the grab bars. There has to be adequate lighting. Then non-slippery mats can be utilized. Then hand rails can be installed so that patient then repair the floor. Bed, and immediately I realized, oh, I may fall from this cord if it gets stuck into my leg. Immediately I put it more inside so that I can take precautions for myself even. So this is the during the learning what I realized. Then make items accessible as much as possible. The call bell has to be at the reach of the patients. Then exercise regularly. Even you remember there are mirrors. There are various indicators which tells us this is a demarcation areas are there. Then there are mirrors are there which you will come to know that who's coming from the opposite side. Then review medications with your doctor. Then get your vision checked. Then there has to be a good point of quality of footwear so that non-slippery footwear that can be here. Don't stand on the tools. These are all the fall prevention tips that is being practiced in so many places to improve the patient's environment. These are the various kind of a fall risk assessment tools are there. It is very easy. The scoring systems are being given over there. This is the fall risk assessment tool that is called as a FRAG. Even this is a steady, that is stopping elderly accidents, death and injury. You remember for your ACLS, BLS, there are algorithms are given for what happens if there is a cardiac arrest, what can be given, if there is a changes, what can be done. So like that, this Center for Disease Control and Prevention of US, they have given the high risk. This is algorithm they have given when the patients are at what kind of a risk. If it is a patient is at low risk, moderate risk, or high risk of a fall, they have given an algorithm so that the falls can be prevented, especially from the elderly persons. Then about the next, we are talking about the patient's handover. It's the same thing which I was talking. We like to chit chat very much, handing over the patients. It is very important. WHO had given so many tools so that the patients is properly handed over to the next duty nurses, and there will not be any errors in the patient's care. So there are a lot of structured, those are the structured, in a written form. In one of the UK hospital, what they do, as they enter in the clinical area for the next shift, there is a general handover is there by the senior nurse. By the senior nurse, she will hand over generally all the patients, using about the structured tools mostly. Some of the hospital, they are directly entering the patient's information in the system, or sometimes they take the printout and they give to the next duty staff nurses. So a critical review of research on clinical handover was done using a 252 documents. What they think that the important information may be missed during the clinical handovers, because we are human beings, we tend to forget so many things. Structured handover may improve the information exchange. If it is a structured, it's a written form, definitely it will going to improve. Then multidisciplinary education about the clinical handover is necessary to each and everyone. It has to be practiced. Then if again, I told you all these concepts are interrelated. Patient handover, again, ineffective communication is a major cause of adverse. So in the beginning, we have seen the effective health communication, very important. So ineffective communication is a major cause of adverse events. So inadequate handover communication is a key contributing factor to harm the patient with 80% of adverse events. So that is very important. So training is very important. Training, policy, protocols, regularly it has to be followed. Training has to be extensive training has to be carried out. WHO has also predicted the increased use of standardized handoff reports will reduce the adverse events. The research that is put. These are the ISBAR. These are the various research tools are there. These are the structured tools and how you can structurally in a proper way, in a systematic way, hand over your patient. It tell you what are the things you are supposed to while handing over the patients. What are the things you are supposed to communicate to exchange the information about the patients. Like this is bar, that is ISO bar is there for the cardiac ward verbal handover. Identify like I for identify the check patient identity 3 ways. So you have to identify, you have to tell the patients everything about patient's identity, patient's name, surname, date of birth. So this is very most important information. Then situation, operation and surgeon, complication, unexpected event that you can tell, observations like what were the vital signs, abnormalities, background, relevant past history, allergies, sensitivity, assessment, patient progress and status. And recommendation, that is what needs to be done, when and why to be, by whom it has to be done. You can tell information about that this patient needs a chest physiotherapy, so that at 4 o'clock, the chest patient will get the chest physiotherapy. So these are the very structured tools are there which can be used. Lot of things are there. Data is there. S-bar is there. It is all about the same thing which tells you what are the things you have to communicate about your patients when you hand off your patients to the next duty nurse. Then next is prevention of pressure ulcers. It is very important, prevention of pressure ulcers. Sometimes it is, I feel like it is a nursing fault. Definitely we have shortage of nurses, but getting a bed sore to a patient, it comes on nursing head only, I feel like. No, so in UK, most of the hospitals in ICU, they have got air mattresses. In our setting, I remember in our setting, we have got 2 to 3 or 4 air mattresses. And then we decide, after getting the patients, we see that 2-3 days patients is now going to be a chronic patients here, and then we take a decision and we put the patients on air mattress and all. So in that case, what happens during that period, there are chances of patient may get the bed sores. So that much we don't have economically, that much opportunities or provisions are not there, so that every patient in ICU will have an air bed. But there are a lot of scales are available very extensively. This Braden scale, pressure ulcers risk assessment scale, is used everywhere. It is used so that we can prevent the pressure ulcers in our patients. These color codes are there and very easy to administer. You can score it and it will tell you that patient is at what risk and what precautions you can tell. Total score ranges from 6 to 23. As the lower the score is there is a more risk of developing pressure ulcers. Then there is a Norton scale is there, which tell you about the patient's condition. If your hospital has an electronic health record system, integrate these assessment tools into that system. And there has to be a proper pressure ulcer prevention protocol has to be there. Then next is preventing venous thrombosis. All these causes these are the harms are avoidable. We can avoid it. Preventing hospital-associated venous thromboembolism. There are a lot of guide are there. The guides are there. Then there are tools are there. You can assess. A guide for effective quality improvement outlines the latest evidence on how to lead a quality improvement effort to prevent hospital-acquired venous thromboembolism. One example I would like to share here. I remember one patient. She was a little old age patient was there. After post surgery, she developed a lot of complications. She was done some orthopedic surgery, lot of complications with lot of things. We on ventilator, we mobilize her, we gave her different positions and we mobilize her, and she was quite good and she was supposed to get discharged in a few days, like in a 3-4 days. But somewhere I predicted that somewhere the thrombus that we mobilized and patient died before going to discharge. So much of hard working and so much efforts we took for that patient, and that patient died. So this can be because of the maybe a thrombotic events or emboli. These are the various tools for preventing the venous thromboembolism. Mobilization is very important. Mobilization, in our ICU, we remember we used to follow all the standard guidelines. We used to mobilize. We never used to wait even for the doctors or physiotherapy. On your own, we used to mobilize the patients. Then there are devices like intermittent pneumatic compression devices are there. Then chemical prophylaxis is there and aware. So, patients are in the hospital. They feel like I am a king. I wanted to rest because I'm suffering from a illness. I am undergoing a surgery. I must take a good rest. But please threaten them, warn them, whatever. It is your own nursing creativity, how you make them aware about the dangers of venous thromboembolism. It is mostly so that we can, as patients get scared, they will help you, they will cooperate you in their mobilization programs. Next is your hospital infection. So hospital-acquired infection. It is also avoidable cause. So many things. Hand washing is the best for each and every hand wash. I will say hand washing is the only solution of it is this. And hand hygiene is there. Environmental hygiene. Nowadays, so many private hospitals, there are displayed the timings for the hygienic, all the process. So that during that time, they make the relatives to stay out and they clean that time, and they will check and they will take the signature of the authority that I have cleaned these areas. They have schedule. During that schedule, the cleanliness is being done. Then there are screening and cohorting patients, surveillance, antibiotic stewardship, following all the guidelines. Safety cultures is very important. Infection control manuals, protocols, that is very important. And the training, extensive training. There are studies being done in West Bengal and Maharashtra where they have seen in the swabs various that Klebsiella and Pseudomonas very commonly observed organisms were there. There are a lot of care of bundles are there. That is, everyone is aware about this bundle. WAP bundle is there, CLAPSI bundle, catheter association, urinary tract infection. That bundles are there. Then surgical safety. All these bundles, if we implement in our setting, we can reduce reduce MRSA enhanced protocol are there. There are toolkits are there to improve the antibiotic use in acute care hospitals. Lot of material is available. The next we are going to talk about early warning signs. What happens when patients goes into emergency situations? So before that, every disease has got a warning sign. Every disease gives us a warning sign so that we will get an adequate time to safeguard our patient. We will have an adequate time in our hand to save the lives of our patients. So early warning signs. So there are these scales are available. What happens even there is changes in a one single parameter also will be able to alert us something we need to take, we need to take actions for this. The earlier the warning signs are identified, the more time will be available for taking appropriate corrective actions before the negative consequences of problem. Sure. So that every disease, so there are scales are there, which is called as a NGOs, that is a national early warning signs, and there are MUs, modified early warning sign, where there are 4 to 5 parameters are there, which can be measured. If there are any changes in these parameters, immediately nurses can report to the doctors so that the prompt action will be initiated, and nurses will be able to take decision that this patient must be frequently monitored. It required a nursing alert and nursing attention more frequently. Currently, most rapid response teams in the United States are triggered by one parameter. I told you, even a single parameter also, you can just call the rapid response team, or they are called as outreach team over there. So immediately, even though there are changes in a single parameter, immediately you can inform, and a rapid response team or outreach team, they are getting triggered, even a one parameter. That parameter often represents a significant change in particular vital sign. Like you can say pulse, or like you can say blood pressure, it's blood pressure, pulse, these are the volume indicators. Volume indicator, you can identify what is the volume status of your patient. So then these are the MUs2 and MUs2 are, these are the parameters which are measured in this particular scales. The scales, there have got this thing, interpretation is very easy, and it can tell you what you can take a prompt action when the score is between this to this range. There's a low risk, medium risk, and low to medium risk, or a high risk. What you can take a prompt action, this will be there displayed in this scales also. Then there's a pediatric early warning signs. This is in the POs, that is called as the POs. In a systematic review, 90 papers are varied designed with a view to assess the use of POs in pediatric acute care setting, and found that it is extensively used internationally in the pediatric inpatient hospital settings. We have to implement all these things. Now we have talked a lot about the research and the research evidences what are available. So even when research is available, it is often not used in practice. Sometimes the settings are different and the scenarios are different, the situations are different. It is very difficult to implement those things applied in different setting, in our setting. So there are possibilities. Adapting the research to practice can be challenging because of numerous barriers and deficits of facilitator to change. We may ask them, we want this, that, but it may not be possible. So for the, especially if you are working in particular hospital, the management may not be agree to implement those change because of any kind of a constraints and financial. Hello? Hello? Yes, finishing in 2 minutes. Now, these are the various resources you can have. Just I have kept it for the resource. You can have these resources like various resources are there to prevent the pressure ulcers are there. These are National Institute for Clinical Excellence. They have got their assessment scales are there. And these are the various references, resources you can have to know. There are one more things I wanted to tell you, my friends. Online, there are a lot of courses are available, modules are available. In spite of spending so much time on WhatsApp, why can't we attend those courses, short courses, not just to get the certificate, but to safeguard our patient? We can keep ourselves updated. That is very necessary. If you are updated yourself, your moral will be high at the workplace setting, your confidence level will definitely goes high, and you will deliver a patient care with a pride. So thank you so much, and I wish thank you to the team of Terna for a huge success of this conference. I wish you everyone and all the speakers, congratulations for focus on this very important topic of patient safety. Thank you so much.
Delegates, do you have any questions?
Yes, any question? Soumya?
Yes, ma'am.
Thank you all the audience for bearing with me. It was the last session. Last session is always boring. Really sorry for that.
Thank you very much, ma'am, for your enriching session. You have highlighted about effective health communication, about communication assessment guide, especially about medication errors, and madam has highlighted about prevention of healthcare associated infections also. We are very much thankful to you, ma'am, for accepting our invitation in short notice period. We are very much highly obliged to you, ma'am, for being with us today. Thank you.
Hello. I have done it.
Yes, yes. Thank you very much.
Yeah.
Sorry. Dear delegates, we have been listening to the eminent speakers deliberating in the area of patient safety. Now it's time for paper presentation. Let me introduce
finished with the scientific session. Now here we start with the paper presentation. Am I audible? Am I audible? We have finished with the scientific session. I mean, by 5 minutes. To continue with the session, we are going to start with the paper presentation.
Dear delegates, we have listening to the eminent speakers.
My voice is audible.
Hello, am I audible to you all? Hello, check. Am I audible? Hello, am I audible? Are we audible to you all?
मैम सिर्फ सूरज का आ रहा है, हमारे से नहीं आ रहा।
Hello, am I audible? Are we audible to you all?
बाकी को नहीं सुनाई देता है, ये मेरे बाजू पे। Yes, ma'am.
Dear delegates, sorry for inconvenience. There was some technical issue. So herewith we start with our paper presentation. We have been listening to the eminent speaker dedicating in the area of patient safety. Now it's time for paper presentation. Let me introduce our eminent judges for the paper presentation. Herewith we have today Professor Dr. Smriti Mani ma'am, Professor Mr. Eknath Gangre sir, Professor Mr. Lakshman sir, Professor Mrs. Pratibha Athare ma'am, Mrs. Soumya Menon ma'am. Let me introduce the judges. Dr. Mrs. Smriti Mani ma'am. Ma'am has a huge experience of over 41 years in West Bengal Health Services and over 29 years of teaching experience. Ma'am is an officer in charge, West Bengal University of Health Sciences. Ma'am is an officer of IUCD training in West Bengal training by Ma'am is an examination from syllabus committee in PhD committee examiner of PhD. Ma'am has worked as a member review committee for family of healthcare and family welfare. Ma'am has published several publications in national and international journals. We are very honored to have ma'am with us. We welcome you, ma'am. The second speaker for the day we have, the second judge we have, Mr. Eknath sir. Sir is an associate professor at Terna Institute of Medical Science, Srimati Eknath Rao Vicky Patil College of Nursing, Dhule. Sir is experienced for over 12 years, presently pursuing PhD in nursing. Sir is a member of BOS, member of Institutional Research and Ethical Committee, member of IQAC Committee in PIMS, Dhule. Sir is a UG and PG research guide and PG examiner for various universities. Sir has published 11 research papers in international journals. Sir has membership of professional bodies like CNE and Indian Society of Psychiatric Nursing. We welcome you, sir. The next judge for the day is Professor Mr. Lakshman M. Sir is experienced for over 12 years. Sir is an editorial board member of an international journal for pediatric nursing, Red Flower Publication Limited, Delhi. Sir is a research guide for UG and PG. Sir has published 2 books, a handbook of community health nursing, published by JP Publication, New Delhi, and legal and ethical aspects in nursing. Sir has published and presented several research papers, organized and attended several workshops and conferences. Sir has worked as examiner for UG and PG students, paper setter for university exams, NSS officer, and organizing secretary for national conferences, etc. We welcome you, sir. The next judge we have for the day is Professor Mrs. Pratibha Athare, ma'am. Ma'am, Principal Terna Nursing College. Ma'am is Professor cum Principal HOD Child Health Nursing. Ma'am is an approved NUHS UG and PG research guide. Ma'am is a gold medalist in MSc Nursing and currently pursuing PhD Nursing. Ma'am is a national mentor for CHO training program. Ma'am is an editorial member of International Journal. She is an advisory member of Administration and Nursing Education Journal. Ma'am is a member of advisory member of Nurses of India. She is a paper setter, examiner for various universities like Bharati University, Bharati Vidyapit deemed to be university, D.Y. Patil deemed to be university, and NUHS. Ma'am has published various national and international journals. Ma'am has organized several national, international conferences and a resource person for conferences, workshops, seminars, and webinars. Ma'am has been awarded as a Best Principal by Nurses of India in year 2020. Ma'am has guided more than 35 UG/PG research students. We welcome you, ma'am. The last judge for the paper presentation we have Mrs. Soumya Menon, lecturer and HOD Medical Surgical Nursing, Terna Nursing College. Ma'am is pursuing PhD Nursing from Bharati Vidyapit, deemed university. Examiner for UG and PG nursing students at NUHS and other universities. Ma'am has guided UG and PG students for their research projects. Member of Institutional Research Committee and IQAC Committee. Ma'am has organized various conferences at local, state, and international level. Ma'am has published articles in international journals. Ma'am is a member for various professional organizations like TNEI, CCNS, NSS, etc. We welcome you.
Instructions for the paper presentation. Just a second. Sorry for inconvenience. We are facing some technical error. We'll shortly be back.
Am I audible? Hello, check. Am I audible?
Yes.
Thank you. Sorry for the interruption. We were having some technical error. We are back now. Start with our paper presentation. Instruction for the paper presentation. We have created 5 breakout rooms. Each participant has to get into the rooms allotted to them. The rooms for participants are allotted to them on their WhatsApp group. So please, will be going to your each respective groups. Each participant will be allotted 8 minutes to present along with the discussion. You will find the breakout rooms on your screen. On your screen, there will be 4 squares. You all have to Click on the squares and enter the respective groups which is allotted to you. These are the instructions for the delegates. Kindly delegates, presenters, keep a note. Click on the room and enter in your respective room. Remaining participants who are not presenting can go into the breakout room of your choice. Any of either of main room or in any of other rooms, the remaining participants can move. Once the paper presentation are over, all the delegates should leave the breakout room and for leaving the breakout room, you'll have to click leave button and not the leave meeting, but leave room. All the participants will be coming back to the main room. Am I clear with my instructions? May I repeat? Delegates, please go to your respective rooms. Rooms are being created. There is a 4 blocks you all could see. Click on that. Please move to your respective rooms. Judges, I'll just give a reminder. Main room, Dr. Smriti ma'am, Smriti Mani ma'am, you can be here only in the main room. Room number 1, Mr. Eknath Kavre sir. Sir, please move to room number 1. Sir, please move to room number 1. Room number 2, Mr. Lakshmanan M. Sir. Sir, please move to your room. That is room number 2. Pratibha Athare madam, madam move to room number 3. Room number 4, Mrs. Soumya Menon ma'am. Ma'am, please move to your room. May I repeat the rooms for the evaluators? Main room, Dr. Smriti Mani ma'am. Room number 1, Mr. Eknath Kavre sir. Room number 2, Mr. Lakshmanan sir. Room number 3, Pratibha Athare madam. Room number 4, Soumya Menon madam. Hello. Hello. Rooms have been created. Can move to your respective rooms. Participants and judges can move to your respective rooms. Rooms have been created. May I repeat again? Main room, Dr. Smriti Mani ma'am is an evaluator. Room 1, Mr. Eknath Gavde sir. Room 2, Mr. Lakshman sir. Room 3, Pratibha Athare madam. Room 4, Mrs. Soumya ma'am. Delegates, please move as per your allotment. Hello ma'am. Hello Smriti ma'am. Hello. Am I audible? Hello ma'am. Ma'am, can we start? Can we begin? Smriti ma'am, can we begin? स्मृति मैम को अनम्यूट करो. स्मृति मैम को अनम्यूट करो.
Hello?
Yes, ma'am. Can we begin?
Are you getting me? Yeah, I am getting now. So, just so many times I am telling, please unmute me. Okay, now
Sorry,
am I
ma'am,
audible?
we are having some technical issues. So.
Okay, okay. Am I audible now?
Yes, ma'am, I can hear you.
Okay. So, but screen is only with your ad, na? Terna Nursing College. Nothing is there?
Yes, ma'am.
Okay, okay, okay. I can see you.
Sorry for inconvenience.
It's okay, beta. It's okay.
I hope all the presenters are here with me. May I just call out the name of the presenter of main room for the convenience. Miss Asha Funde, Mr. Vinit Patole, Mr. Vishwas Ambekar, Miss Pallavi Lamkhande, Miss Usha Belore, Miss Nikita Barwal. I hope all are there along with us. I may just repeat an instructions for the presenters. We'll start with a presentation. Myself, Jayashri Misal, lecturer, Terna Nursing College. We'll just review for the presentation. Presenters will be getting 8 minutes. Along with a discussion, they'll be getting 8 minutes. And presenters will share their own PPTs. Okay, so let me call upon the first presenter, Miss Asha Funde. Miss Asha Funde, please share your PPT. Asha Funde, are you there? Okay, let me see, call upon Mr. Vineet Patore. Mr. Vineet Patore, are you there with us?
I'm sorry for inconvenience.
Ma'am, just a moment.
Okay.
Asha Funde, you are there in the meeting, so please.
Hello.
Yes.
Hello, ma'am. PPT is not sharing, ma'am. How to share it, ma'am?
You can share it from your screen. There is a share screen option there. From there you can share it.
Okay, ma'am.
See, there is an option, green highlighted option, share screen. From there you can share your PPT, Asha.
Okay, ma'am.
Yeah. Done?
Okay, ma'am. I'm trying, ma'am.
The next participant, please be ready. Vineet Patore, then Vishwas Ambekar, Pallavi Lamkhande, Usha Belore, and Nikita Barwal is in sequence. Please be ready. You can share your PPT, Asha.
Yes, I'm sharing, but it's wait, ma'am.
Can try.
Wait, ma'am. Wait.
There's a green button there for share screen.
बरं भाई पीपीटी पीडीएफ मध्ये करून घेतली
So
पीपीटी शेअर होत आहे ना
some of your screen.
आहेत ना 450 लोक आहेत
Asha, mute yourself.
शेअरच होत नाहीये. हॅलो.
Yes.
हॅलो सुप्रिया, शेअर होत नाहीये पीपीटी. ग्रीन बटन वर हे केलं तरी होत नाहीये.
Asha, mute yourself. May I call upon Mr. Vineet Patore to present your paper, please. Yes.
Yeah, ma'am.
Asha, you can take your time, be ready, and we can give you chance later on.
May I start, ma'am?
Yes, we can see you. Proceed, Vineet.
Ma'am, my PPT is visible now.
Yes, Vineet, we can see your PPT.
Okay. Good evening, judges. Myself, Vineet Patole, lecturer at Matoshri College of Nursing, presenting the paper. So, first of all, moving toward the paper, I would like to share introduction regarding my research. As we know from the decades, the nursing process has been evolved. Like in the decade of 1950, considered with the period during which nursing was gradually modified from the hospital-based to university-based profession and become an independent medical field. In 1955, Halls used the term nursing process and urged that by applying the nursing process as a framework for the patient, caring the nursing care plan by fully offered also the patient. Following the efforts made in the regards, in 1961, Orlando presented three-step implement nursing care based on the nursing process, including nursing client's behavior, reaction, nurses, and the nursing action. Over time, various authors and the scholars have proposed different forms of nursing process. But at latest six-step nursing process as a step provided by the American Nurses Association that was based on evaluation, recognition, nursing diagnosis, specifying the objectives and expected outcomes, and planning, implementation, evaluation. It should be noted that different phases during nursing was gradually modified from the hospital-based to university-based profession. And also the nursing process can be compared to the large container. Nursing process is now running a standard from nursing in healthcare system in most development countries. In United States, all nursing students who are enrolled in the first year of the nursing are trained using this module. The use of nursing process helps in making the planning a good, clear, and effective nursing care that is finally effective for improvement of quality of nursing care. So the problem statement which today I'm going to display is a non-experimental descriptive study to assess the knowledge regarding use of nursing process among staff nurses working in coronary care units of selected hospital of selected city in view to prepare self-instructional module on nursing process of cardiovascular disorders. The objectives for my statement is to assess the knowledge of staff nurse regarding use of nursing process while caring for clients admitted in coronary care unit of selected hospitals. Next objective is to prepare a self-instructional module on knowledge regarding use of nursing process among staff nurses working in coronary care unit of selected hospitals. Hypothesis for my study were there will be inadequate knowledge regarding use of nursing process among the staff nurses working in coronary care unit of selected hospitals of selected city. H1 hypothesis was there will be adequate knowledge regarding use of nursing process among the staff nurses working in coronary care unit. Actually, the need for the doing this study was, as we know, the nursing process has gained much importance worldwide, but all nursing professionals are using it in different ways. Nursing problem must be problem oriented, universally applicable, dynamic, cyclic, interpersonal, and collaborative approach. Nursing process is important for nurses because it provides a systematic and organized method of delivering nursing care and helps to avoid omissions and duplications. Patient encouraged to take decisions by active participation, focus the client as a whole, and both the clients and the nursing are evolved for the plan of care. Nurses are the largest group of health professionals in all countries. Nursing quality is closely related to the healthcare system effectively. In order to achieve quality of healthcare services, quality of nursing is the key element, and it feels that demand application of the nursing process has a significant role. But in practical application of nursing process is not well developed. As many of the nursing processes, as we know, the nursing process we teach every year, but the nursing process actually in the hospitals are implemented only at the NABH hospital and the reputed hospitals where the proper quality care is been given. So the need for this study was like the nursing process is widely used, but most recently we see that the current studies that the factor and the lack of knowledge, high patient and nurse ratio, load, and lack of education, training, and motivating factors affect the application of nursing process. It is possible that the hospitals look forward and the resources to promote the awareness of their nurses on this and the utilization. The research methodology for my study was, the research design which was used for my study was non-experimental descriptive one group pretest design. Setting for the study was selected hospitals of selected city. Then population and samples were coronary care unit staff nurses. Sampling technique which was used was convenient sampling technique. Sample size was 100 staff nurse of coronary care unit. The target population was these staff nurses which were present and comprises of coronary care staff nurses. Accessible population for the present study consists of coronary care staff nurse unit. Sampling techniques in present study, the sample selected where the subjects consist of coronary care staff nurses. Sampling technique in this study was non-probability convenient sampling technique. The major findings during this study was found that regarding the demographic data, the most of the nurses were in the age from 21 to 30 years, that was 64%. 32% of the staff nurses were from the age group of 31 to 40 years, and 4 of them were from the age group of 41 to 50 years. The analysis of data for the assessment of the knowledge of staff nurses regarding use of nursing process while caring for the clients admitted in coronary care unit were like 15% of the staff nurses had poor knowledge score from 0 to 8. 38% of the staff nurses had average knowledge from score from 9 to 16. 47% of them were having the good knowledge from
Sorry to interrupt, Mr. Vineet, but 1 minute.
Yes, yes, ma'am. Yes, knowledge regarding good knowledge that was from 17 to 25 regarding the use of nursing process while the caring for the clients admitted in the coronary care unit. From this study, it was found that the nurses had a good knowledge, had the knowledge from the average that was 47%, and the good knowledge nurses were high. But actually, the problem which was found during this study was like these hospitals which were not NABH accredited or the which were not following the JCR protocol as the nursing due to the more ratio of staff and the patients. The staff were less and the patients were more. Due to there were the difficulty in following the nursing process. They were having the knowledge, adequate knowledge regarding the nursing process, but they were finding it hard to implement the nursing process among the while caring for the patients and giving the quality care. Thank you.
Thank you, Mr. Vineet Patore. Now, may I call Vishwas Ambekar to present. Vishwas Ambekar, with what ID have you logged in? I am not able to see you.
त्याच्यातच विचारले त्यांनी पण त्याच्यातच उत्तर देऊन टाकले. नेट फॉर स्टडीचे विचारले होते ना, मग त्याच्यामध्ये
Mute yourself. Mr. Vineet Patore, please mute yourself. Vishwas Ambekar, please respond with what ID have you logged in? Yes, Mr. Vishwas, please present.
Unmute.
Mr. Vishwas, your time starts now. You are having 5 minutes to present your paper. Please begin.
Good evening, ma'am. Ma'am, I am audible.
Yes, you are audible. You can begin.
Good evening, ma'am. Myself, Vishwas Ambekar. My study was, ma'am, a study of awareness and implementation of contact precaution practices during management of multi-drug resistant organism in a tertiary care teaching hospital in Maharashtra. Introduction: the strengthening infection prevention and control essential to combat healthcare association infection and antimicrobial resistance. The present study was undertaken to assess effectiveness of structure teaching program among staff nurses regarding study of awareness and implementation of contact precaution practices during management of multi-drug resistant organism in a tertiary care teaching hospital in a Maharashtra. Then method. The place of study, it was the carried ward, surgery ward, ortho ward, and NICU and PICU. And in comparison, in critical and non-critical area, population was the staff nurses working in a surgery ward, ortho ward, and NICUs and ICUs. Then in, that is tool means tools in that standardized checklist we have prepared for assessing impact of implementation of infection control practices during management of multi-drug resistant organism. Then second one is structurized online questionnaire, that is Google form we made to assess
Mr.
awareness
Vishwas,
of
3 minutes
isolation
left.
precautions among staff nurses. Then study period was, ma'am, 1 month. Total sampling size was 25. Sampling criteria, it is inclusive and exclusive. Inclusive in that patient admitted in a tertiary care hospital, patient who have a contact isolation. Then exclusive, patient who don't have a contact isolation. Then statistical analysis, it is all categories variable will be expressed as a frequently as a percentage. Then this is a ma'am Google form pre and post intervention, that is divided in 3 types: average, median, and range. That is pre-test and post-test. Pre-test, it was quite impressive, 8.85% out of 10 points. Then median out of 10, it is 9 points, and range point is out of 10, it is 3 points. Then post operatively, it is an increasing number of points out of 10, 8.89%, then median 10 out of 9%, and range, it is a 5%. Then this is the intervention, ma'am, analysis. This is the elements we are capturing in critical unit and as well as non-critical unit. First is the hand hygiene compliance. Staff adhere to jewelry, nail polish, artificial nails. We are checking. Then adherence to safe injection and infusion practices. That is scrub the hub. Means scrub the hub 20 seconds. It will be scrubbed and 20 seconds dry. For a action time was 20 seconds. Then port properly kept or not. Then appropriate use of disinfection, chemical dilution for environmental cleaning, we are checking. Then sharp part disposable at a point, means whenever procedure that time small puncture proof container we are carrying or not. Then ANTT use or not, means aseptic non-touch technique use or not, we are checking. Then handling.
Mr. Vishwas, 1
Yes.
minute left. Hurry up.
Handling and cleaning of medication devices, that is thermometer and stethoscope, we are checking. Is a quite improving in post interventions. This is the non-critical unit. Then discussion, ma'am, the study relevant that the elements in a standardized checklist, that is hand hygiene compliance, staff adhere to jewelry, nail polish, artificial nails, adherence to safe injection infusion practices, scrub the hub, port capping appropriately done or not, then disinfection done or not, ANTT aseptic non-touch technique use or not, handling of clinical medical devices properly cleaned or not. Then most important, ma'am, is the staff patient ratio is maintained or not, we are checking. Then after implementation of structured teaching program, knowledge and contact precaution practices management
Mr.
multi-drug.
Vishwas, time up. Thank you so much.
Okay, ma'am,
Good
thank you.
presentation.
That is end, ma'am.
Yeah.
Thank you.
May I request Ms. Pallavi Lamkande to present your paper? Miss Pallavi, can you hear me? You are there? May I request Usha Belore to present your paper? Miss Usha Belore. Miss Usha Belore, are you there? Miss Nikita Barwal. Miss Nikita Barwal, are you in the meeting? Asha Funde, are you ready with your paper presentation? Your PPT? Asha Funde, are you ready? Presenters, please reply.
Hello.
Yes.
Good evening, ma'am.
Who's this? Can you please?
Myself, Pallavi Lamkhade.
Yes, Pallavi. Please start. Please begin with your presentations. We are running short of time. Pallavi, your time begins now. 5 minutes.
Hello. Ma'am. Some technical error. That's why I'm not sharing my PPT, but I am explaining my thesis. So myself, Pallavi Lamkhade, I'm working as an infection control nurse in
Are
Bharti
you sharing
Hospital
your
since
screen?
1
We are
year.
not able to see your screen, Pallavi.
Some error, because of some error, I can't share.
Present. Miss Usha Belore, are you there in a meeting? Miss Usha Belore, Nikita Barwal, Nikita Barwal, Miss Asha Funde, are you in a meeting?
त्याच्यावर कसं करू मी सांगा ना इथं कुठून घेऊ स्विच ऑफ झाला माझं कुठून करणार सांगा असं काय झालं ह्याला त्याच्यात कुठं शोधू मी आता मला अनम्यूट केलं त्यांनी लगेच कोणतं कोणतं दुकान आहे अरे माझी पीपीटी शेअर झाली आहे इथे आता बघा माझी पीपीटी शेअर होतीये हॅलो 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 गुड इव्हनिंग मॅम हॅलो गुड इव्हनिंग मॅम ma'am can I audible hello
Yeah, I was sharing your screen because you were unable to share, Pallavi. 1 minute, let me do it for you. Yes, Pallavi, I have shared your screen. You can present now.
Thank you, ma'am.
Yeah, your time begins.
Good evening, ma'am. Myself, Pallavi Lamkhade. I'm working as an infection control nurse in Bharti Hospital since 1 year. My study topic is a study to assess workflow management of Central Sterile Supply Department in Tertiary Care Hospital, Maharashtra. Because CSSD is the heart of the hospital. Then my introduction is, second slide. Can you share, ma'am, second slide, please? Yeah, okay. The topic introduction is the Central Sterile Supply Department is a services unit of a hospital responsible. Hello, ma'am. Okay. The topic introduction is a Central Sterile Supply Department is a services unit of a hospital responsible for providing graduate sterile equipment and instrument all the department of hospital for immediate use of patient care. The combat hospital acquired infection, hospital need to effective method of disinfection and sterilization which can be taken care by the Central Sterile Supply Department. Then the objective was to check CSSD practices, follow all infection control practices in CSSD, also monitor in a ward level for instrument cleaning and washing, and to find out the receive and dispatcher time from CSSD to ward all instrument tray packing and drums also. The method of studies research approaches is a quantitative approach. Setting of study was carried out in teaching hospital Maharashtra in CSSD. Sample size is a staff of sample, staff of CSSD. Sample size 11. Sampling design is sample random sampling. Then sampling criteria is exclusive. Criteria is a staff all working in a CSSD, and exclusive criteria staff not willing to participate in the audit. Tool is standardized checklist for observation in CSSD. This is the pre-intervention result from autoclave receiving and dispatching from ward to CSSD and CSSD to ward level. Autoclave, ATO packing, and plasma, so plasma sterilization. Then post-intervention result in that autoclave receiving and ATO receiving from ward to CSSD and CSSD to ward level. Then discussion is in CSSD instrument receiving as per list, cleaning, drying, packing, and sterile properly, it is 100%. Then unidirectional flow maintaining in CSD 85.71%. The necessary infection control precautions included use gown, cap, scrub, vest. It is 100%. And after post intervention, the properly tray dispatch in ward level for the patient care is 4 to 5 hours.
Done, Pallavi?
Yes, ma'am.
Okay, thank you so much.
Thank you, ma'am. Thank you so much.
Yes, thank you. Now I call upon Usha Bellore for the presentation. Usha Bellore, are you there with us? This might be a last call for Usha Bellore, Nikita Barbal, and Miss Asha Funte. Asha Funte, are you there? If you're not able to share your PPT, I can do it for you. Miss Asha Funte, you are there? If you are not able to share your PPT, I can share for you. Ma'am, Smriti ma'am. Smriti ma'am. Hello ma'am. Again the same thing. One second, ma'am, I'll unmute you. You'll see that option. Yeah. Yes, ma'am. Hello, ma'am. Ma'am, I've given you that option, ma'am.
I can't hear anything. How can I talk?
One second, ma'am.
Unmute.
Done, ma'am. I have done.
Oh my goodness, why are you keeping I can't say anything.
Ma'am, I have unmuted you. I have done that option for you.
Okay.
Usha, I have done it for you.
Yes. Okay.
Yes,
Thank you.
Usha,
Good evening.
I'm sorry for inconvenience, ma'am.
Hello. Good afternoon.
Okay, please allow Usha.
Yes. Okay. Good evening, ma'am. It's Usha Belore.
Presenters
Am
just
I
wait.
audible? Am I
Yes,
audible?
Usha, you are audible.
Yes, you're audible.
Okay. Please share my PPTs, ma'am.
Usha, you want me to share your PPT? Just give me a
Yes.
second. Just
Yes.
give me a second. Yes. Yes, Usha, you can see, you can present now.
Ma'am. Myself, Usha Belore. I have completed my MSc Nursing and I am working as a MMF Hospital Association Ratna Memorial Hospital as a nurse educator. Ma'am, please share my next slide, ma'am.
One second, I'm doing it.
Yes, thank you. The title of the study is a study to assess the effect of the health teaching program on knowledge and practice regarding prevention of uterine prolapse among high-risk women at selected urban area. So this is the title of the study. Next slide. The uterus and an organ of the female reproductive system. The uterus can undergo the minor displacement in the ways to be a specific. Uterine prolapse constitute a severe uterine problem in which the uterus protrudes through the pelvic floor apertures or a genital interruption. Uterine prolapse occurs most often in having a multiple birth woman as a response to the injuries to the muscles of the pelvic province during the childbirth. So the main objectives of the studies are to assess the level of the knowledge and the practice on prevention of the uterine prolapse among high-risk women, to determine the effect of the health teaching on knowledge and practice regarding prevention of the uterine prolapse, and to find an association between knowledge and practice with selected demographic variables. So the method which was used, the research approach, quantitative research approach, research design like the pre-experimental one group pre-test and post-test design research design, study like the Pule Nagar, population like mothers who had delivered under between 30 to 50 years who had vaginal delivery and the high-risk woman in the selected urban area at Phule Nagar. The samples like the multiparous woman with the age group of 30 to 50 years and my sample size is the 60. The sampling technique, it's a purposive sampling technique, and the sampling criteria in the inclusion criteria, the high-risk woman between the age group of the 30 to 50 years, women who have had 2 or more vaginal deliveries, the women who are willing to participate, the women who do strenuous or a heavy lifting work. So it's about the inclusion criteria, and about the exclusion criteria, women with had undergone the operative delivery have undergone the hysterectomy. The main data collection technique and development of the tool, the self-structures interviews and the modified short state questions are there. The tool consisted of the demographic variables, level of the knowledge, and rating scale to assess the practice regarding prevention of the uterine prolapse. Now I will show the systematic diagram. The population, I have taken the mother's age group between 30 to 50 years who have had the vaginal deliveries. There are total 60 samples pre-test, and after later on I have given the health education post-test, and on 7th day the good improvement on the 7th day after the health education. So my findings are: the post-test was conducted for the group on the 7th day. The test used were the calculation of the frequency, percentage, mean, standard, and deviation. Peer t-test by the ANOVA. The level of the significance set for the testing, the hypothesis was the 0.05. The p-value is the 0.00. So the analysis concluded the study by the accepting the H1 hypothesis. So H1 alternative hypothesis is accepted, and there is a significant effect of the health teaching on knowledge and prevention of the uterine prolapse among the high-risk women at the selected urban area. So main implication of the study, obstetric and gynecological nursing education. Thank you, ma'am.
Yeah, thank you so much. It was a good presentation.
Thank you, ma'am. Thank you.
Now
Ma'am, can you share my PPTs, ma'am?
Asha, right? Yes, Asha. I'll
Can
share
you
it
share
for
my
you.
PPTs, ma'am?
Yes,
Yes,
sure, sure.
okay,
Give me a
ma'am.
minute. I'll share your PPT. Yes, Asha, you can start. You can see the PPT.
Yes, ma'am.
Yes, you can start. Your time begins now.
Okay. Good afternoon, everyone. So myself, Miss Funde Asha, working as a pediatric nurse in Women's District Women's Hospital, Ambejogai. Ma'am, can you share next PPT? Okay. So today's my research statement paper presentation topic was effectiveness of helper skin tap technique on pain during intramuscular injection among neonates born in labor room of selected hospitals, Pune. Next slide, ma'am. And my studies objectives of study: firstly, to assess the pain level of neonates during iron injection with usual standard technique in control group. Second one is to assess the level of pain neonates during iron injection with helper skin tap technique in experimental group. Third one is to compare the pain level of neonates during iron injection.
Asha, you intimate for your next slide, okay? You intimate, just intimate.
Okay, ma'am. Yes, ma'am.
I said you just intimate me for your next slide.
Okay, ma'am, I will intimate. Then my fourth objective was to find out the association between levels of pain experienced in selected demographic variables. Next slide, ma'am. Next, please, next slide, ma'am.
Yes, yes.
Study introduction was, ma'am, please, next, before this slide, ma'am, one slide is there, remaining. Introduction slide. Can you show the introduction slide, ma'am?
Yes, yes, 1 second.
Okay, introduction. My study's introduction was effective pain management not only reduces physical discomfort but also improves quality of life. Developing a plan that caters to every individual in providing them with pain relief and comfort can improve both psychological and physical patient outcomes. Next slide, ma'am. Please, can you show next slide, ma'am? Research methodology was type of study design. A study design used to true experimental post-test control design. Sample technique was non-probability purposes sampling to select study subjects who fulfill the inclusion criteria during period of data collection were selected for the study purpose. My sample size was 60. In that, 30 sample was control group and 30 sample is experimental group. Next slide, ma'am. Methods of data collection tools was study instrument in section A, consent form, section B, demographic system, section third is self-modified neonatal infant pain scale. In that, self-modified neonatal infant pain scale was some parameters was there according to Apgar score, means babies crying, arousal, then babies parameters, and according to this scale was modified and I have used for the my study. Then conclusion, in the findings of the study concluded that after detailed analysis, the study leads to following conclusion. The non-pharmacological method helper skin tap technique. This technique, it is with the help of the 3 fingers 16 times. We have to tap it slowly and gently and during the IM injection, and then afterwards we have to do the IM injection because
Asha, 1 minute left.
Okay, next slide, ma'am, please. Next slide, ma'am. Next slide, ma'am. Discussion slide is there, ma'am. Discussion. Okay, I will tell my study result only. Means whose baby's weight is the more than 2.5 kg. That baby is getting the less pain and more pain, and whose baby more weight is the more than 3 kg. That baby is getting the less pain. This is my study's result, and this will be very beneficial for the babies and the pediatric areas. Some analysis of data showed that there was a significant difference between scores of pain level among neonates in experimental and control group. Neonatal complication due to pharmacological pain relief measures can also be minimized by using helper skin tap technique.
Is Nikita here? This is the last call for Nikita Barbal. Is Nikita Barbal in the meeting?
Okay, is it is it over?
Asha, mute yourself.
Is it over?
Yes, ma'am, it's over.
Okay. So can I discuss one by one?
Yes, ma'am.
Yes, ma'am.
Yes, ma'am.
So let them hear also. They are audible,
Just
now.
a second. Asha, mute yourself.
Okay. So first of all, Vineet, just I want to congratulate all of you who have presented here, and at least they have done something. But I want to tell something one by one. That is the first of all, Vineet. Where are you, Vineet? Vineet, where are you? Okay. You listen now. Nursing
process usually in the nursing, in our nursing occupation, we are teaching nursing process from the first year.
Ma'am, there are 4 of our
what was
delegates.
the
They will
need?
give the feedback of today's session now.
What was the need to do it in your hospital? Nobody is listening, or nurses are not learned from, not taught from the proper institution. And if you see your result, you can see that 85% they have the good and moderate knowledge. Only 15% had the poor knowledge. So what was the need to conduct that study? I don't know why you have done that one. Because nursing process is a simply it's an educative process which can be taught in a school or college only. So for that reason, it is not a researchable topic at all. Am I audible? Am I audible?
Yes, ma'am. I can hear you. You're audible, ma'am.
So, Bineet, have you heard whatever I have told? No. Shinu?
Yes, ma'am. You are audible. We will listen to you.
Okay. Next I am coming. That is the Vishwas Ambedkar. Where is your objectives? Our sample only 25. And your inclusion criteria, all those things, you have to check it again. And pre-test and post-test, if we see, only that is 8.6 and 8.9. Where is the difference? I don't know why you have done. You didn't do any groundwork. For that reason, this study is not at all a useful study. And next I am coming to the Pallavi. Yes, Pallavi, your objectives are not a research objectives. You can check it because always in our research, we are using the action verbs. So nothing is coming out from your research. It's not a research. Actually, this is the problem we are facing. CSSD is a hospital policy. We are doing that only. Who is not doing this? Is a simple supervision. Who is not maintaining, who is not doing properly. Is it researchable? It's just in service matter only. And design, what is your design? I don't know. Design you didn't mention. And sample with only 11. No, in our qualitative study also, we are not taking this much, just only 11 staff nurses you can observe, and it could be a good study. So, and population, sample, inclusion criteria, all were same. It cannot be like that. And it's a mere method of nursing work only. This is not a researchable study. Rather, I would say that, and have you observed, Pallavi, 85% nurses are doing in a very good manner. And then what was the need to check it? Have you observed 85% nurses are doing in a proper manner? So it's really, there was no need. And Usha, knowledge and practice you have done. Yes, you have done it in a right way. But if you see your tool, knowledge questionnaire, your tool, you have written that level up questionnaire. Level up questionnaire is not a name of the tool. Tool must be knowledge questionnaire, and you have checked the, you have assessed the level of knowledge. And I don't know how have you practiced. Practice you have checked through rating scale. So practice, I think you have done the observation checklist, and that is in rating scale. So scoring you must have done with the rating scale, but that is the observation checklist you have made. I don't know, you have written rating scale and tool knowledge question. Otherwise, your findings and your statistics you have rightly adapted. Next, Asha. Asha, I am telling, Asha, would you please answer me? Why have you chosen a labor room as your setting? Because you have taken your sample and a newborn. So newborn, how many injections they are getting in the labor room? So I don't know, actually for the helper technique, we can use in the pediatric ward where the babies are getting again and again injections, so that, and not only that, you have checked in your introduction, you have written psychosocial of the environment, psychosocial condition of the newborn. My goodness, newborn who is in the labor room, how can you check her psychosocial condition? And not only that, you have written it's a true experimental. No, it's not a true experimental, because we need so many control and random sampling. So it's not found in your study, and objective 4 is not applicable, because objective 4 you have written, I can't see after one presentation if it would be given for the discussion, then you could answer also. And I don't know whether you are, and your analysis part was also very poor, because nothing is just research will give anything, maybe positive, maybe negative, but something result will come out, but nothing is there in your analysis part also. And this skin tap technique, yes, this is a known researchable topic, but your design, your setting and your sample could be different one. So this is not at all applicable. So thank you very much for giving me the for calling me. But really, if you could suggest, you could check all the studies before presentation, so that it could be a good presentation. Thank you very much. So my presenters, keep it up. I want to see again. You are doing a very good research, and I want to see that. Thank you very much, organizers. Thank you.
Thank you so much, ma'am.
Can I tell? I like the USA study. That is more or less correct. Without just 2-3 points, she has done the mistake, but otherwise she is good only.
Thank you so much, ma'am. It was really very good. It was very honored. We are very honored to have you with us. And the discussion part was really very nice. I hope many of our delegates might have got very much to learn from the discussion, and would have helped. It will definitely help us and all the delegates for their further research and for the presentations. Thank you so much.
Okay, thank you very much. Thank you.
Yes.
Dear delegates, 2 more groups are having their paper presentation now. Meanwhile, I'll be giving you some announcements. Please fill the post-test and feedback forms. Link for post-test is shared on Zoom chat box, WhatsApp groups and YouTube live chats. Fill both the post-test and feedback forms. Dear delegates, you have been listening to our distinguished speakers so far. I hope you all had a beneficial session today. We would like to receive feedback from you all. I request the delegates to provide us the feedback about the conference. If any one of you can give the feedback, you may raise the hand.
One of our delegates is Priya Jayaraman. She is a business director of Hewlett Packard Enterprises, HP. And she is one of our alumni from NHCA Singapore. And she will give the feedback of today's session also and NHCA as well. Priya, please.
Thank you, Dr. Mittal. Hello, everybody. Can you hear me well? Can someone confirm if you can hear me?
Priya, just a second.
Okay, sure.
You please unmute again. I'm muting again. Please unmute.
Sure. Can you hear me now, sir?
Yes, Priya, you are audible. Please continue.
Okay, awesome. Hello, everybody. Thank you very much for allowing me to be a part of this beautiful conference. So many wonderful people joining this learning, and anything from NHCA is always enriching. I'm a part of NHCA. I joined as a student. I've done some counseling sessions there. And I must say that I'm not from the medical fraternity, but I'm a part of it right now, feels like a part of it. I'm from the IT industry, like Dr. Mittal called out. I work for Hewlett Packard Enterprise. I've been in the IT industry for about 22 plus years. And coming from the IT industry, you must know that we do a lot of research before we get into anything that will enrich us for the future. And I did the same before joining NHCA. I did my research for about
Kindly
a
keep
year.
your video on.
And
Can you please keep your video on?
Sorry, I was some technical problems. I'm not able to turn on my video at this point, but I will go on. Thank you. So I'm Priya Jayaraman. I come from Hewlett Packard Enterprise. Dr. Mittal gave an intro about myself. So I will not go into it, but I'll take the moment to speak about NHCA. I did my research, found out about a lot of great institutions where I can learn counseling, and I found NHCA to be the top. And NHCA provides a lot more than counseling courses. There's nutrition courses, there's nursing courses, and I'm sure you all are aware of it. And with my experience over the year that I have been inducted into NHCA, I must say it's been one of the most enriching experience ever. NHCA has provided me with the great counselors who can help us, case studies. We have mentors touch base with us week on week, and they give us examples of live case studies that helps us become better day in and day out. And also I've encountered with a lot of people who landed up with great opportunities after going through NHCA. So to me, it's one of the best institutes to be in. I feel privileged, and I have myself benefited a lot out of the programs that I've enrolled in. So from one program, I figured out, the benefits are enormous. So I enrolled in the other, and I continue to. So learning is never an ending story, and for me, it continues to be a journey, and I'm enjoying the journey myself. And I would recommend NHCA for anybody who is looking up to creating a career opportunity in any of the fields that they choose, within which NHCA offers courses. So thank you for the opportunity today, and wish you all to do with your future. Thank you. Thank you, Dr. Mittal.
Thank you very much, ma'am. I see Anjita has raised her hand. Sering Yoden, may please provide the feedback.
Serin, please unmute.
Hello.
Yes.
Hello.
Yes.
Yeah, hello, I'm Anshita. I'm calling from UK.
Yes.
I'm an NHS staff nurse. I'm working in Princess Royal Hospital, which is in Telford
Please keep the
place.
video on.
I tried to, but I couldn't turn it. I think you have to disable it from there.
Okay.
Hello?
Yeah, you may continue.
Yeah, hi.
Yes, yes, you can continue.
So,
Okay. Okay.
are you able to see me?
No, we can't see you.
Oh.
Yeah, you may continue.
Yeah, we can see you.
Hello?
Yes. Yes, Sanchita, we
Hello?
can see you.
Yeah, hello. Yeah, so I'll introduce myself again. So I'm Anshita Satyan. I'm an NHS staff nurse. I'm working in UK and Telford Hospital, Princess Royal Hospital. So I would like to speak about something about today's conference. All the sessions were really interesting. The effort was really commendable, and I would like to say that all the presenters, they have done an amazing job. It was really helpful and such an interesting session. I think it really helped to update the knowledge regarding the patient safety, and I think it touched almost all topics as well. So also I would like to congratulate and all the members who have taken initiative to do this conference. It's really wonderful to see all the nursing professionals to come together and conduct such an amazing job. So I would like to thank everyone, all the presenters as well as all the members who worked for this conference. That's all. Thank you so much. Hello.
Thank you very much. Thank you very much, Madam Anchita.
My pleasure. Thank you.
Vineet Patole. Anyone else? Vineet can provide the feedback. Vineet, are you there?
Yes, I'm there. Yes.
Yeah, you may please go ahead.
Yes, good afternoon. Good afternoon, everyone. Good evening. Sorry, good evening. Actually, about today's conference. Today's conference was good. The sessions were interactive, and also the initiative taken by Terna College of Nursing and all the staff. It was appreciable, and it was well managed. Though there were technical issues, but everything was running smoothly, and also the efforts were seen for conducting a good conference. The speakers were very good, and all the topics which were covered. As previously, I was working as a liver transplant in charge at Jupiter Hospitals. Mainly the patient safety goals and each and everything which was been covered in the conference. It was very good, and all the knowledge today which we are having, and also the knowledge which were given today, it was like brushing up all the knowledge, and also it was good. The conference was good, and also all the congratulations to all the Terna College of Nursing for arranging such a good and wonderful conference. Also with the National Healthcare Academy Singapore, it was a good collaboration and a good conference which was to be held today. Thank you.
Thank you very much, Mr. Vineet. Analysis. Now I request Madam Soumya. Menon, Organizing Secretary from Terna Nursing College, to share the analysis of the conference.
Thank you everyone for coming in such a large numbers for today's conference. From the various platforms of Zoom and YouTube links, we had to stream this through 2 YouTube links. So because of such a huge number of participants and around from the analysis of pre-test and post-test what we have got, and still people are doing it post-test, but till now we have come across that we have around 1000, more than I can say 1700 participants who have come in such a large number and benefited from this particular conference. So now I proceed with a vote of thanks. Ladies and gentlemen, once again a very good evening to one and all. I, Ms. Soumya Menon, lecturer, Terna Nursing College, on behalf of Terna Nursing College, first of all extend my most sincere thanks to the Almighty God for making today's event a resounding success. With His blessings and grace, we are able to make this event what it was meant to be. Next, I would like to thank our patron and inspiration, Dr. Padam Singhaji Patil sir. Without his blessing, we couldn't think of organizing this event at such a large scale. I also thank our Chief Operating Officer, Malar Rana Jagjit Singh Patil sir, and our Chief Executive Officer, P.T. Deshmukh sir. We are grateful to you, sirs, for being as a pillar to Terna Nursing College to make us strong and successful in what we do. Next, I would like to extend my vote of thanks to our chief guest, Ms. Minimal Verghese Madam, for accepting our invitation to become part of today's event. With immense pleasure, I thank our special guest for the day, Dr. Neelima Bore Madam, for being a mentor and motivator for us and gracing this event with her presence. I extend my deep gratitude to Dr. Pawan Mittal, Sir, Program Director, National Healthcare Academy, for his guidance and support. Sir was very helpful and approachable, instantly coming out with the solutions of the hurdles we faced. We hope that such fruitful collaborations continue in future as well. Next, I also thank Dr. Deepali Umale Madam, real motivator for proceeding with a collaboration with NHCA. Thank you, ma'am, for all your help. We are indeed grateful to Maharashtra Nursing Council Registrar, Ms. Rachel George ma'am, Observer for the Day, Ms. Vaishali Taksande madam, for taking out a valuable time in attending the same. I would like to specially thank Deputy Registrar, Ms. Swati madam, and Roderick sir, and the entire team of CNE for their constant support and guidance in the planning process. I also extend our sincere thanks to all respected speakers for the day, Dr. Sushila Kavde Madam, Dr. Elizabeth Joseph Madam, Dr. Shubhangi Jadhav Madam, for their excellent sessions and also making themselves available for us in such a short notice as per our humble request. We are thankful to all the speakers from NHCA Singapore, Ms. Anishma Madam, Ms. Dini Madam, for the informative talk related to the theme of the conference and also supporting us with all the technical help needed. We are also grateful to the moderators of the paper presentation, Professor Dr. Smriti Mani ma'am, Mrs. Jyoti Naikare madam, Mr. Eknath Gowde sir, Lakshmanan sir, for taking out their time in guiding the budding nurse researcher and giving them valuable insights about research. I also thank the paper presenters for the day for sharing their research work with us and enlightening us with the research topic. Also, I would like to thank Terna Medical College, particularly Dean Dr. Sunil Petkar sir for his cooperation and Mr. Sagar More for helping us with technical assistance. I also thank Vidya Sagar sir from Terna Medical College for all the support and help that he always provides to us. Also, I thank Terna Specialty Hospital Research Center and Ms. Simi Punus, Nursing Superintendent of Terna Specialty Hospital Research Center for their help and support. I also thank Terna Engineering College for their cooperation. My heartfelt thanks goes to Pratibha Athare Madam, Principal, Terna Nursing College, and the entire teaching, non-teaching faculty, first and second year MSc students and fourth year BSc students for their constant hard work and dedication in making this event a grand success. I also thank Ms. Mrunal Bandal, third year BSc nursing student, for her soulful performance at the start of the day. I thank Mr. Anthony for providing us with delicious meals for the day. It's my pleasure to announce that we have conducted today's conference through Zoom, live streamed it through 2 YouTube channels. Hence, my sincere gratitude to all the participants of today's event who came in such a large numbers, actively participated and patiently listened to the conference, thus making it a grand success. Many thanks to one and all once again. Thank you.
Dear delegates, kindly fill the post-test and feedback forms. When you fill the post-test form, you will find at the end of that page, generate certificate. So you will be directed to the feedback form. So once you fill the feedback form, you will be receiving the certificate. And for receiving the attendance certificate from MNC, it is mandatory to fill the feedback form too. Attendance certificate will be reflected in the MNC portal within 15 days. And those who have presented the papers will also be receiving the certificate. For those who have attended the session through YouTube link, despite registering through MNC portal, we will try to approach the MNC for your attendance certificates. The first and second position for the best paper presentation will be displayed on the MNC website. Those candidates will also be personally intimated. Post-test link will be active till 6 p.m. only for today. I repeat that post-test link will be active till 6 p.m. today. Thank you, Madam Soumya, for your vote of thanks. Let us all be guided by the things we have learned and heard throughout the conference. Thank you all for your kind cooperation in making this event a grand success. Have a nice day. You all may leave the meeting. Thank you.
Thank you, Terna College of Nursing, Terna Nursing College, and each of the professors and team members for conducting this wonderful workshop, webinar, conference, and managing very smoothly. Thank you. And thank you for the participants. Participants are from India, Canada, Gulf countries, and Europe. Total 2,600 plus 500 participants were there. Thank you very much.
Okay, thank you, sir. Participants may fill the post-test and feedback form and may leave the meeting. Till 6 p.m., the link will be there. Link will be open. So you can fill the posters and feedback forms.
शुभं कुरु त्वं कल्याणम् आरोग्यम्